Okay, everybody, warm welcome. We are a few minutes late, so let's get cracking. So warm welcome to the 5th meeting of Knowing the Unknown, Parkinson's Hidden Face. It's the 3rd time in Lund, and it's wonderful to see you all here in the auditorium, and also those of you who participate online. Warm welcome to you too. First, some practical things. There are emergency exits, and I'm now going to look like an air hostess, but we have emergency exits there, and we have emergency exits here in case of emergency. There are lavatories out on this side and 20 meters that side. The ficas and lunches will be served also outside here. There will be 2 stations, so we want to avoid any queues. If you have pre-ordered any dietary requirements of some special sort, they will be at a special table, and that's also marked out. All speakers and chairs for each session, we would like you to, before the session starts, in good time before that, see our excellent tech team to get your headsets ready. And also, if you haven't already uploaded your presentation, most of you have, but if you haven't, also again see that our tech team. If you want to present from your own computer, that is possible, but again, make sure that the tech team knows about it, so we have a smooth journey. Each talk is 30 minutes, and that time includes questions. So nice if you speak about 20 or 25 minutes to leave time for some questions, both from people who partake online. You can write your questions in the chat, and we will get them here. And also for the auditorium, there will be a microphone that will be passed around for questions. And we encourage everyone to pose questions. And with that, I would like to leave the word to our parts of our organizing committee.
Thank you, Ulrika. Also from my side, a warm welcome to this 3rd non-motor meeting here in Lund, 2021, 23, and now 25. And I welcome you on behalf of Skåne University Hospital, a hospital which has traditions since 1768. And now with 13,000 employed, it's, I think, one of the 3 biggest university hospitals in Sweden out of 7 such ones. Also welcome you on behalf of Lund University, which has traditions since 1666. And now with 47,000 students and 7,500 employed, it's one of the biggest universities in Scandinavia. It's great to have you all here, and I do wish you 2 very interesting but also relaxing days here in Lund. We should already from the beginning thank the involved people in the organization, the organizing committee, for a great program. And of course, the sponsors for a fantastic sponsorship. We have AbbVie, we have Bial, we have Britannia, and we have Merz with us. And also Multipark from Lund University supports this meeting in a very nice way. And we should also thank LU Conference for the technical organization. You see them up at the back. And we should, of course, thank Elisabeth, Camilla, and Tiziana, who did a fantastic practical organization of the meeting. Thank them already now. And with that, I give the word to Carolina.
Dear esteemed faculty, Professor Odin, Professor Ray Chowdhury, it's a great honor and privilege to be here in this meeting. And during this meeting, we will focus mainly on comprehensive care of people with Parkinson, and I hope you will find all lectures very interesting and useful. And here I would also like to acknowledge Mr. Raghu Kataria Foundation from Dubai for financial support and for support of other our another research. Thank you once again for attending and making this meeting a great success.
Okay, I think my role is really to bring you on to the main meeting. I'd just like to say a few words about the Parkinson's Non-Motor Group, which is what this meeting is about. We formed in early 2000, myself, Pablo Martinez-Martin, various other people are there, Lars Dimmermann, and it's nice to see Annette Schrag, nice to see Alexander Stoik, nice to see everybody here. And I think what has been really impressive is that we've put together a really fantastic faculty. You could easily compare it to a society meeting. And I think if you see the content of what we're going to be talking about, I hope you go back quite enriched and emboldened by what's going to be discussed. Like Per and Carolina, I would like to thank all of you and people online for attending. We plan to continue this tradition on a yearly basis, to have this meeting every year, probably in rotational sites. Lund University has been one of our fantastic hosts, so thank you, Per, thank you, Ulrika, and thank you all the organizers for making this possible. And finally, so finally, I think I'd like to also, as Per did, thank the sponsors. Non-motor aspects of Parkinson's usually still a bit of a problem, particularly when it comes to funding from industry. They're more interested in dyskinesias, in motor fluctuations, things we've been discussing since the late 80s. Non-motor remains a Cinderella subject, but I'm happy that the industry is becoming more aware of it, and we're very grateful to them for support, without whom we can't really do this, and also to some of the philanthropic donors. Carolina mentioned the Qataria Foundations. We have a named lecture which she will deliver, but also we have a great participation of patients here, and we're very privileged and fortunate to have Sir Nicholas Mostyn, who will attend later. And Nicholas, who's a main speaker for patients in the UK, but actually now runs a global podcast called Movers and Shakers. He's here, and we'll do a live video with him as well about his journey with Parkinson's. He's a foremost judge, a barrister. He was involved in the divorce. He's a divorce lawyer, so we have to be a bit careful. He was involved in the divorce of Prince Charles, and then subsequently Paul McCartney. So two very high-profile divorces he has been involved in. And so he's here. And with Parkinson's now for 5 years, it's been my patient to talk about that. So, but he's supporting bringing in a patient voice to this group, so which is, I think, very, very important. So I think with those words, I'd like to finish and open the session up, and you'll see the program starting, and I'll pass you back to Per. Sorry, Ulrika.
Well, I will just make a short introduction of your co-chair for this first session, Angela Cenci-Nilsson, professor of Lund University. Welcome.
Thank you. So it's a great pleasure to co-chair this session with Ray, and we will share the tasks here. So I will present the first speaker, Maria Svanberg from Lund University, speaking about progress in understanding RBD in Parkinson's disease through genetic studies. And Maria knows she has maximum 25 minutes to speak, because we need to leave 5 minutes for questions. Yes. Please.
Jag tror att det är den förra. De har inte switchat.
Have the wrong lecture on. Yes, now we are all right.
Thank you, Angela. I'm glad I got the right presentation. Otherwise, it would have made it difficult for me this morning. So thank you for the organizers for inviting me to talk about how we can reach progress in the understanding of RBD in PD through genetic studies. So REM sleep behavior disorder, RBD, many of you are familiar with this. It's a loss of muscle atonia during REM sleep. And this leads to dream enactment, vocalization, movement, which is disturbing to the affected individuals, of course, but also the partners. And that can actually, both parties can be hurt by this. The prevalence is around 1% in the population above 50 years of age, and we have a predominantly male affected. Now it's estimated to a 2-to-1 ratio, in the past up to 9-to-1. So what happens normally during REM sleep is that we have an inhibition of spinal motor neurons that leads to the atonia during REM sleep. And if this happens in the absence of other neurological disease, we call it isolated RBD. And if concurrent with, for example, neurodegenerative disorders or autoimmune disorders, it's called secondary RBD. And having isolated RBD could be considered a prodromal marker for alpha-synucleinopathy, since and also other neurodegenerative disease. So 6%, a little bit more than 6% of affected individuals convert to Parkinsonism or dementia, and around 75% will convert into synucleinopathy within 12 years. So this is substantial. And looking at the cases, then almost a half of individuals with Parkinson's disease also have RBD, and even more so for dementia with Lewy bodies and multiple system atrophy. So how is RBD connected to synucleinopathy? So this is a schematic illustrating a potential connection. So we have synucleinopathy starting in the brainstem and disturbing this circuitry leading to REM sleep atonia. And then disturbed regulation leads to RBD. We then have a progressively assessing synucleinopathy leading to motor neurons when disturbing the basal ganglia, and then to higher order brain regions involving in cognition. And we also know that in Parkinson's disease, disturbed sleep is a key characteristic in different ways. One can talk about sleep destructuring, and that affects many aspects of sleep. And also, when looking at the subpopulation of PD patients that also have RBD, this is associated with a rigid akinetic form of Parkinsonism and also more non-motor signs and hallucinations. So clearly of relevance for this audience. Also, they progress more quickly to dementia and other aspects. So the question is, does isolated RBD define a specific subpopulation of patients? And can those patients then benefit from early neuroprotective therapies? And also we can see that this high rate of phenoconversion that suggests shared biological mechanisms between the diseases, RBD and PD. And to identify which mechanisms these are, genetic association analysis is a great tool, and I hope to convince you about this if you are not already convinced. So what is a GWAS? Some of you are well acquainted to these Manhattan plots. For those who are not, usually we compare cases and controls and genotype, the entire genome, and these variants are then assessed for association to the specific trait, in this case, a disease. And the level of association is plotted here. So the higher up, the more associated to disease. And those above the genome-wide significance threshold, here indicated by the dashed line, can then be considered as significantly associated to disease. And often the closest gene is indicated close to these variants. And you will see that in plots like this. So these are results from the latest, largest PD-GWAS meta-analysis from the 2019 by Nals et al. And you can see there is a lot of loci here. This was a big study. And in total, 90 independent BIS loci were identified here. And this was by comparing Parkinson's disease versus controls without Parkinson's disease. And a similar strategy has been used for RBD. And this was led by Sid Ganor at McGill. And here, isolated RBD versus controls and PD patients with probable RBD versus controls were assessed. And a meta-analysis was performed between these cohorts. So these are the results showing this Manhattan plot, and you can see the significantly associated loci indicated here. So we have 5 loci and 6 variants associated to the risk of RBD in this case. And 2 of these loci are novel, have not been implicated in RBD before. So looking at the odds ratio here, first for the ones that have been reported or as involved in RBD before, we can see these include well-known genes for Parkinson's disease, alpha-synuclein GBA, TMM175, and then we have these new associations to genes not previously implicated in PD. So when looking at the allele frequencies here, we can see that there is an expected inverse correlation between allele frequency and odds ratio. So the more common alleles are generally have a lower odds ratio, confer a lower risk of developing a disease. The rarer, larger risk. And this is logic in the population. And we can see that these odds ratio range between just above 1, 1.2, till above, up to almost 3 for the GBA variant. Interestingly, these 5 out of 6 are associated to the autophagy lysosomal pathway. So there's a clear connection to mechanism here. So looking more into detail here, we can see that there are overlapping signals with PD-associated variants indicated here in brown. And this indicates that the same variant or a variant in linkage disequilibrium inherited together with this variant is associated with PD and with a shared mechanisms in PD and RBD. And the independent signals, then, here in blue, they are unique in this study to RBD, meaning that they indicate pathways that are unique to RBD and not to PD. Notably, there are also absent signals, loci that are associated to PD and DLB that are not seen as associated to RBD. And this is, I would say, as interesting as those identified as associated, because they can also tell us something about what matters, what differs between these diseases. And there was a 80%, more than 80% statistical power to detect these in the current study if they had had the same effect size as in PD. So all together, this suggests that our PD with RBD is a distinct subtype of PD. And these variants could be important in distinguishing PD and DLB subgroups without RBD. So going further to polygenic risk score. So this is a way of using GWAS data in a complementary way. So here we use the data from a GWAS to identify significantly associated variants with the trait in question. And then each variant is weighed according to the risk conferred. So a high-risk variant will have a higher impact on the polygenic risk score than a variant conferring a small risk increment. And that allows us to calculate each individual's combined genetic risk for that disease, that trait. So looking at this histogram, we can then, on a population basis, identify those with a low genetic risk, intermediate, and a high genetic risk for this specific trait. So on an individual basis, the cumulative genetic risk can be assessed, but it can also, on a population cases, identify at-risk populations before that disease or trait is even manifested. And by comparing the polygenic risk score between different diseases, that can tell us something about the mechanisms behind this. Would two diseases share mechanistic pathways associated to the same genetic causes or risk variants? The polygenic risk score would be as good predictor of the disease A as disease B. So, how to use this now on the GWAS data here? So it was used to segregate isolated RBD and PD plus RBD from PD without RBD. So for each individual included in the study, the polygenic risk score for RBD was calculated, and then that score was analyzed for its specific power to predict outcome. So if the outcome is isolated RBD, you can see it in red, the power is quite high. The area under the curve is around 0.6, which is a good predictive power. It's almost as good in predicting PD with RBD, but not as well a predictor of PD without RBD. It's quite logic, and it tells us that, but it also tells us that there is a distinct difference, genetic difference between Parkinson's without RBD and Parkinson's with RBD and RBD isolated. Isolated RBD, round 3, almost as good for PD with RBD, but a non-significant ability or power to detect or foresee PD without RBD. So it tells us the same thing as the previous ROC curve, but in a different way of calculating this. So next question is, can a genetics affect the risk of RBD in PD? So here turning only to cases with Parkinson's disease, but dividing them into Parkinson's disease with RBD or without RBD. So a GWAS was performed first, and only one single loci was detected with significant association, and that was in the alpha-synuclein with an odds ratio of 1.2. And then, in order to assess more how the connection between RBD and PD overall, we got back to the 92 risk variants identified in GWAS in European and Asian populations, and then assessed those for association in this cohort specifically. And that identified additional 2 variants in alpha-synuclein, but as you can see here, the odds ratio is below 1. So carrying these variants increases the risk for PD, but reduces the risk for PD with RBD. Same thing for LARC2, the G2019S variant. It's significantly associated to decreased risk of Parkinson with RBD, although we know it's associated with increased risk for Parkinson's disease with an odds ratio as high as 11. There are also additional potential associations in other genes that need to be further investigated. And notably, here, the GBA1 locus showed no significant association to Parkinson's disease with RBD, which might be a bit surprising. So, in summary, what can this genetic data tell us about RBD and PD? From the GWAS results in the RBD, we know that RBD heritability is around 12%, calculated to around 12%, and this is similar to dementia with Lewy bodies, but lower than the estimated heritability of Parkinson's disease. We can also see from comparing different GWASs, we can see that there are both shared and independent risk loci for RBD and PD, and here also dementia with Lewy bodies. So there is an overlap, but there is there's a unique overlap between the pairs between these diseases, but they're also shared between all three, and there are individual. Looking more specifically into the alpha-synuclein locus, there a specific variant co-localizes with SNCA AS1 EQTL, and this is a long non-coding RNA antisense, and so the theory behind this association is that increased SNCA AS1 expression would lead to brain-specific reduction in alpha-synuclein, and this is based on expression data, tissue specifically, and that is done could explain the reduced risk for RBD and synucleinopathy. However, in experimental studies, based in, for example, in cells and in vivo, actually the inverse has been suggested, that SNCA AS1 is associated with increased expression of SNCA and alpha-synuclein protein. So this is something that needs to be more looked into on a functional basis. We can also conclude that RBD risk variants converge on the GBA1 pathway. And looking specifically into the PD population and dividing them into those with RBD and without RBD, we can draw conclusion from this 5' located SNCA variant that increases risk for RBD in PD. And looking into this more specifically, this one is linked, it's in linkage disequilibrium, and then co-inherited often with a variant identified to be a risk variant for RBD, but also to variants, risk variants for PD plus RBD and PD and DLB individually. So, and that's one of the challenges with this when identifying loci, that we know that closely located variants can be inherited together, and we can pick up signals from these in different analysis, but they are actually tagging the same thing. But then it is really important to assess this and see which are independent and which are dependent. And here we can say that we have, in the alpha-synuclein locus specifically, we have both when it comes to RBD and PD. And I want to point out that these PD-associated risk variants in alpha-synuclein and LRRK2 encoding genes decreased risk for RBD in PD. So I hope with this that I've convinced you that genetics can be a good tool to look into mechanisms behind RBD in PD, and hopefully to identify at-risk populations or early at diagnosis, say something about the progression of disease and to target intervention accordingly. And the co-pilot agrees with me in this and draw me this picture. And to me, this says that genetics can be the compass for us to navigate through this complex interactions in the brain and the complex interplay between different synucleinopathies. Thank you. I'd like to thank my collaborators, my team in Lund University, collaborator here at the Skåne University Hospital, and especially Siv Ganor and his team at McGill, who has led these GWAS studies. Also to supporting organizations and funding bodies. So thank you.
Thank you, Maria. It was a really excellent lecture. Let's see if we have some questions. Please, Lars. Yes, too. Yes.
Yeah, Maria, thank you very much for this really interesting talk. When I'm seeing patients, last woman from Marburg, when I'm seeing patients, I know how scared they are when they Google and know that they have RBD. And one of the major things they want to know, when do I convert to real Parkinson's? And when we are honest, when we are thinking about disease-modifying substances, such we are looking at this ADLL study, and currently we also want to know who's a fast converter and who's maybe a little bit slower. And my hope to you genetics people is always, can you give us a little bit more hint who's maybe the kind of the fast converter, maybe by a process of getting fast into this GBA line, and who's maybe a slower converter? Have you ever kind of had an idea that something could help us in differentiating there?
Yeah, so this is, of course, clinically a very relevant question. So RBD, as you clinicians are very aware of, is not always easily diagnosed. So in these cases, PD with RBD in this larger G was probable RBD, so it's self-reported. And often it's reported with questionnaires or in interaction with healthcare. And it may not be really practical to do polysomnography on all individuals. That said, the polygenic risk score can be such a tool to actually identify individuals with those that are at risk for faster progression, or what subtype are we talking about here? So I think that can be a great tool. But as always with genetics at a whole genome level, one needs to be careful with translating into individual care. So my main hope is that these polygenic risk scores, the genetic insights we see, can point us to pathways looking more into. And yeah, what this says, and finding that out, I think is the key, so that we can target the right medication or treatment to the right person. Did that answer your question? I don't have the answer, actually. I think if we did, we wouldn't be here.
Please. Thank you very much for your great talk. I wanted to ask, what is the major risk variant for development of dementia with Lewy bodies? Because that's something our patients are afraid of, and I see it as a malignant form of neuronal synucleinopathy. And then another quick question. Of course, when we talk about PD with RBD, we know that RBD can precede PD, but also it can develop during PD already. So what patients were those with PD with RBD? You know, how... that's the question.
So the first question, we know that ApoE, for example, is associated with the risk for dementia with Lewy bodies. And also that we have...
Okay.
Yeah, of course, patients they read and they see these, maybe, this would be a worse prognosis than the other. What was your question? How we could distinguish that, or how they can know?
The risk variant, and then whether that RBD can develop during the course of PD.
So when we say Parkinson's disease with RBD, whether that used to be an isolated RBD that phenoconverted, or that the RBD occurred after, after the PD diagnosis. Well, often we don't know. And based on questionnaires, we often don't know when it happened. We can be segregating, at least identifying those with Parkinson's disease without RBD, can maybe not foresee if they are going to develop RBD later on, but at least they should have they have been protected, so to say, from this phenotype for such a long time, even though it's a prodromal feature of Parkinson's disease. They did not exhibit this phenotype. They got the PD diagnosis and some time has passed. So it tells something about their risk profile as well, I think. So in the clinic, I guess it's important to identify these and try to figure out when did this start. But as I said before, it's not always easy with the RBD phenotype to actually identify, and especially in the early stages.
Okay, thank you. In the interest of saving time, we need to move on. Thank you. You can speak more with Maria during the coffee break. So it is my great pleasure to introduce Annette Schrag from UCL, I understand, in the UK, and she will speak about prodromal Parkinson's disease. What is it? Ethical aspects.
Thank you very much. Thank you very much to the organizers for inviting me again to this lovely meeting. So my talk is really to give an overview about the non-motor symptoms that are so prominent in the prodromal phase of Parkinson's disease, and touch upon the ethical aspects which are really becoming more and more important for us to deal with, as already referred to in the question from on the previous talk. These are my disclosures. So we've known for a long time now that there is a prodromal phase of Parkinson's disease, which is really defined mainly by non-motor symptoms. And you've heard about RBD, which is a very strong risk factor or a prodromal feature of Parkinson's disease, but also others with perhaps a less strong association, such as depression, anxiety, constipation, which are more non-specific, but clearly increased in people who later are diagnosed with Parkinson's. And this knowledge has also now been incorporated in this proposed new classification of Parkinson's disease and related disorders in neuronal alpha-synuclein disease. So this is a hotly debated topic, of course, but I think it is notable that the clinical phase, so phase 2, is defined by the onset of either motor or non-motor symptoms. So we have clearly gone a long way from Parkinson's being defined as a motor syndrome to one that is a motor and non-motor syndrome. And clearly this is something that isn't established and is not a clinical tool at the present time, but I think it is indicative of where the field is moving. And these non-motor symptoms clearly comprise a number of features that we're more than familiar with from established disease, such as I mentioned, the RBD, loss of sense of smell, also constipation, but also a number of other less common features that we might not necessarily associate with Parkinson's disease. And these include other sensory symptoms, not just loss of sense of smell, but also loss of reduced hearing, reduced vision, and things like seborrheic dermatitis, which we know is a feature of Parkinson's, but is also increased in the prodromal phase, and other skin disorders. So the spectrum of prodromal non-motor features is expanding, and it's sometimes quite difficult to distinguish what is a prodromal feature, what might be an associated disorder, what might be a risk factor. And I just want to highlight things like inflammatory bowel disease, Crohn's disease here, and other disorders such as bipolar disorder, which we wouldn't necessarily associate with being a feature of Parkinson's. So we don't quite know what this association is. And so that's certainly an evolving field. So it's not just the ones that we have in the current criteria. Now, these studies that have really established this very strong association with many other conditions were mostly case control studies, but what's more powerful in terms of establishing the strength of an association are longitudinal studies, prospective studies, so cohort studies of people with a given condition and their risk of having Parkinson's disease as we know it later on. And this is being done, has been done in a number of studies. Most recently, this study in the UK Biobank, where specifically people were assessed for a number of features that we know are associated with the prodromal phase, such as depression, REM sleep behavior disorder, constipation, anxiety, orthostatic hypotension, hyposmia, erectile dysfunction. And they did confirm what these case control studies showed, but they also gave us an indication of the associated risk. So you've had a lovely overview of RBD, and clearly this has a very strong association association with later development of or diagnosis of Parkinson's. But interestingly, in this study, also orthostatic hypotension and others associated but less strongly. But they are, of course, more common, so to a degree more useful for in certain scenarios, such as screening in research settings. And we're familiar with hyposmia being used as a screening tool. I don't need to say much about RBD. You will know that this is an alpha-synucleinopathy, and the vast majority will develop Parkinson's over time. But the big question is when. I have one patient who had 40 years of RBD and then developed relatively mild Parkinson's. So it's not something that's quite unusual. So there's quite a wide spectrum. Hyposmia, we know from the PASS study, this was used as a screening tool to then go on to do DAT scans and other tests. It clearly is very useful for identifying or enrich a cohort at risk of Parkinson's, but the association isn't particularly strong. Other conditions like in this study that we did a few years ago, depression, a late onset of depression is highly associated with later development of a neurodegenerative condition and abnormal DAT scans and a number of other non-motor features of Parkinson's. And similarly, we found a very similar thing for anxiety, and in fact anxiety may be even more strongly associated with later Parkinson's. And you've already heard there are genetic risk factors, such as the LRRK2 mutation, but these may be patients who have a slightly different Parkinson's disease. So it's not just all one Parkinson's disease. So LRRK2 mutations in a recent study here was clearly demonstrated to be associated predominantly with motor features and less with non-motor features. So the Parkinson's patients who had a LRRK2 mutation had fewer non-motor symptoms than those who didn't. Now, this gave rise to various hypotheses of different subtypes and different ways into Parkinson's, and that's clearly true. People present in very different ways in the initial and later stages, and you will all be familiar with the body first and brain first hypothesis, explaining some of these differences and substantiated by imaging findings. But it's probably quite complex, a lot more complex than this, and various factors will contribute. We've heard about the genetics and we heard about the genetic risk scores, but there's also an increasing interest in pesticides. There was a recent study on association with living near a golf course. And there may be many contributing factors to Parkinson's disease and probably also to the early presentation. And certainly the interest in early gastrointestinal features is also very interesting in that regard. Nevertheless, it's very useful to combine these features for research purposes to calculate a risk score based on these prodromal features plus minus investigations. And this is a recent study in PPMI, and they showed that combining, so both hyposmia and anxiety were associated with later diagnosis of Parkinson's disease in the prodromal part of PPMI. It's a relatively small cohort, but this was a clear association. And when they combined both anxiety and hyposmia, the risk was increased. And they had a slightly different phenotype as well. And one can combine just these prodromal features just from the primary record presentations and already really enriches the risk of Parkinson's disease, just using these very crude prodromal measures. And of course, the genetics can do the same. You've heard of what the polygenic risk score, and one can combine them. Now, this has, of course, led and supported these criteria, the MDS criteria, which are for research purposes, of combining prodromal features as well as investigational results to calculate a risk score for an individual patient. But it's really important to emphasize this is for research purposes. And this is an evolving field, and as you will all be aware, there has been this big explosion in interest in alpha-synuclein assays, which have been demonstrated to be really quite specific and sensitive for Parkinson's disease. This is in the PPMI cohort, and a lot of groups are working at the moment on validating their assays in various tissues to identify abnormalities to support the likely diagnosis of alpha-synuclein disease. I don't have time to go more into this, but I just want to highlight that this is something that might also allow us to differentiate different types of Parkinsonism. Here, a recent study showing that there are some differences with PSP. There are also some studies on differentiating from MSA. And there are also, of course, other biomarkers. We know about MRI being helpful, and you'll hear about this later. But particularly biofluid biomarkers, which can, perhaps answering the previous question, even in a patient who has an alpha-synucleinopathy, having other CSF biomarkers contributes to the development to the prognosis. So it's not just alpha-synuclein. And also to perhaps mention that with this new definition, using the seeding assays, as well as the motor and non-motor features, there has been a merging of Parkinson's disease and dementia with Lewy bodies. And in this study, again, using UKB Biobank and primary care records, the prodrome of these three different diagnoses, so this was also including Alzheimer's disease, is quite interesting because, of course, Parkinson's disease and DLB do differ in their presentations, but the main difference is really the degree of severity of these clinical features, and DLB has more hallucinations and earlier on, and this is how we use it clinically. And of course, there's also an overlap with Alzheimer's disease. Hyposmia is a risk factor for Alzheimer's disease, so there is quite a bit of overlap. So it's important to remain aware of that. So I think this is a really, really fascinating, interesting field, and we're making a lot of progress in being able to identify Parkinson's earlier and being able to give people risk scores. But the question is, as clinicians, what do we do with this information? And I think it's very important that at this stage, it's very important that we consider the ethical implications because it's very exciting, and ultimately, I am sure this will lead to better treatments. But for the individual patient whom we see in clinic, it's extremely important that we use this information well. So most of this information is, and certainly the risk scores are for research purposes, but if someone has RBD in particular, they have a very high risk of developing Parkinson's disease, and there are a number of questions to be answered. So at a minimum, we should think about how we best do this. There may not be or there is not one size fits all. But we do know that receiving a diagnosis of Parkinson's disease can be devastating, or for most people, is a devastating. It's a devastating diagnosis, and this, in a way, applies in the same way to prodromal disease. So it is something to be done carefully and not just to be considered as a research tool. There are so many emotions that people have at the stage of diagnosis, which are likely also to apply to being given a risk diagnosis or prodromal disease diagnosis. So just to highlight how to classify all these different pros and cons in terms of an ethical framework, there are these 4 pillars of ethics. So non-maleficent, don't do any harm. Beneficence, what's the benefit for the individual patient? Autonomy, the patient's own decision making, and justice. So in this context, for the individual diagnosis, I would argue there is benefit in knowing that they have prodromal Parkinson's disease, because people do present to their primary care physicians and they do ask for treatment and they do have symptoms. So they can be treated symptomatically, and that Parkinson's might be diagnosed earlier. They can participate in trials if they want to. They can potentially take preventative measures, and they might want to plan for the future, having this knowledge. But of course, it is very important to avoid making this an absolutely devastating experience that many patients never forget when they are diagnosed with Parkinson's. To consider things like the insurance implications, which may or may not be relevant in your country, and the stigma that people might experience in some cultures more than in others. There is this issue of autonomy, which is the patient is the one who has the right to know or not to know, and that is something that is very important to do very carefully and to explore what the individual patient's preference is. And finally, justice, distributive justice. There's the economic issue. For some patients, it might have economical implications if they can't drive anymore, if they can't work anymore, because they have prodromal non-motor symptoms. Orthostatic hypertension or other symptoms, treating them has an economical implication. For society, might have economical implication in terms of keeping people in the workforce. For society, it is important to make advances in research to try and treat Parkinson's earlier. And for others, it will, future generations or future people with prodromal Parkinson's, it will be important that we advance this field and start trials with neuroprotective agents. And this is just as a reminder what the basic principle of all of these neuroprotective trials are. If we treat earlier, even with a mildly effective drug, we can rescue more function than if we treat later. So being able to treat early is really the key aim of all of this. And even now that we don't have any neuroprotective treatments, there are trials going on, and there are other studies going on as well to prepare for trials, such as this study by the RBD study group, who really carefully examined how do different symptoms in prodromal Parkinson's disease progress. And they found that actually it is the UPDRS part 3 that is most sensitive to change, which is really important in order to plan a trial. So even this research is very important for the field, but also many patients want to participate in trials and contribute to this advance. But the other thing for the individual patient, this is from a qualitative study we did recently in people from ethnic minorities to talk about their prodromal experience, what their symptoms were like before the diagnosis, and also about their diagnostic experience. And of course, many people had symptoms for a long time, particularly things like constipation, loss of sense of smell, anxiety. for many years, people have these symptoms, and they do have an impact on their functioning, and often it's a long journey in order to be taken seriously, or at least in their perception, and to reach a diagnosis. And many people wish they had been told that this could be Parkinson's or could be something more serious. So this is it's a tool, or it's a possibility to treat people for their symptoms earlier, even if they're not classical Parkinson's. So, and I've already touched upon autonomy, whether somebody, it's the patient's right to know or right not to know, and this is very individually different. For some people, they would never want to know, and there are some predictable factors. Perhaps someone who's very old, has multiple comorbidities, wouldn't tolerate treatment, and also personal differences that are less predictable. So it often requires a careful consideration and preparation and discussion with the patient before any information on prodromal risk is disclosed. But overall, in RBD, there has been most research on this. Overall, people do not want to be given a diagnosis, or at least a few years ago, this was the result from this study, if there is no consequence. But as soon as there is a consequence, in particular if there is a neuroprotective treatment, people do want to be told. But as you can see, there is a proportion who would never of doctors as well as patients would never want a diagnosis to be disclosed early, and others would always want it to be disclosed. So very individually different. And this is just to show an algorithm of a colleague of mine who put this together in people with RBD, how to approach this issue, because in RBD it is probably the most common situation where one needs to make this decision. So just to really very roughly summarize what the key principles should be of this disclosure of risk, the most important thing is to establish what the patient wants to know and to not make assumptions. And many people just don't get asked, and we assume we do it in the best way we can. It is good to ask what they wish to know. One should consider all the factors, predictable, unpredictable factors. But crucially, of course, it's how empathetic we are in communicating this diagnosis, the choice of words, and perhaps avoiding things like words like neurodegeneration, or going into too much detail about risk, which could cause undue anxiety, and provide follow-up and time in order to discuss issues that might come up. Information is very important. It should be accurate, but perhaps not too detailed, but very much depending on wishes and previous knowledge. And there is a lot of uncertainty that, like the discussion after the last talk showed, there are many things we don't know, and we do need to communicate that as well and take that into account. And perhaps not last not least, there are things that people can do. We know about exercise and nutrition, and people do want to talk about this, and it gives them control and agency in this situation where they are confronted with a risk. So really just to finish this, it's a very exciting time in research, and I think this will ultimately lead to better treatments, particularly the combination of prodromal features and biomarkers. We already have several prediction tools. I've mentioned the MDS criteria. We have our predict PD criteria. There are others, but they all combine different risks, different clinical features, and also investigational features to a certain degree. And that already does help patient management. Increasingly, I think we all use the presence of some of these prodromal features when we first make a diagnosis. Loss of sense of smell, REM sleep behavior disorder, and it will also help research progress. But very importantly, the benefits and the implications of this communication of risk and prodromal disease needs to be very careful and very individualized. Thank you.
Thank you for the excellent lecture. Let's see if we have some questions. Yes, please, Lars.
Thank you, Annette, for this brilliant lecture. I'm always fascinated how it takes probably 10 times the time to buy in Germany a new car and being considered what your new Mercedes can compared to the time it takes to give the diagnosis of Parkinson's disease. So you're absolutely right. I think we need dedicated time and very individual approaches. However, I recognize that we are kind of in sharp competition, not only with us as information giver and family and friends, but also nowadays with ChatGPT, Google, and whatever. So I was asking myself, because they sometimes come with really funny things and what they think, and I'm always asking myself, can we influence these machines, e.g. from MDS or from our societies, from the EAN, that we say, well, we give you some training data so that your machines kind of give a little more valid and useful answers to people who are Googling or ChatGPT asking. What do you think? How should we deal with the third new kind of column of information for our patients?
Yes, so I thought about talking about this because this is something that invades all our lives. But ultimately, I think this is an extrapolation of these other algorithms that we create ourselves. And ChatGPT and all these AI tools include information that's out there. So the more accurate information we put out there in research, the more accurate those predictions were as well. Will be. The other thing is to let people know of the risks of these unregulated tools to predict Parkinson's. And I think this is not new, and this is not specific to AI. I remember probably 10 years ago by being approached by people who had a commercial tool that they wanted to apply to people in the general population. They could get in the pharmacy and diagnose their own Parkinson's or their risk of Parkinson's. So whether it's with a wearable or some analysis tool. So this will be available, and there will be various ways, and there are already, I mean, the literature is full of speech recognition, facial recognition of Parkinson's. And these will be important tools, I think, for also, I believe, also for us in the future, to use this to measure progression, for instance. So I think we should use it as such. We should recognize it is there, but with the appropriate warnings. And I think that's the same for anything in AI. But we're not immune to this, so it's just the reality. But what we put out there is what these mechanisms will use.
Thank you so much for an excellent lecture. I just wanted to ask if you had any practical advice for seeing patients in clinic who have potentially a significant risk of developing Parkinson's and what to tell their health insurance company.
Well, I'm not so familiar with what the health insurance policies.
In the UK, I've got a patient who has RBD.
Yes. Requires
treatment. His DAT scan is negative, but he does have an occasional tremor. So just wondering if you have any sort of practical advice on
my practical advice is on two levels. One for the individual patient. They obviously need to put down whatever they've been diagnosed with, in which case, in this patient, you probably gave them a diagnosis of RBD. But at the point of making a diagnosis of Parkinson's disease, that's what they need to put. So I would probably refrain from making that diagnosis until they fulfill clinical criteria as we have them at present. The other level is, I think, as societies and professional bodies, we should actually advocate for this to be considered and for insurance companies not being allowed to use this. But these are bigger discussions, but it's a very, very important aspect of this prodromal risk assessment.
Thanks. We are ready to move on. Thank you very much, Annette. Thank you.
Thank you very much. Thank you. Thank you to also Angela, my co-chair, for taking those first two sessions. We now move on to the third lecture. One of the themes which we've tried to make this meeting for is this stepped care paradigm, which you'll hear about now, and to bring in more newer researchers in the field, not just have the same people speaking over and over again. So we have a smattering of quite a few new people speaking in this meeting. It gives me great pleasure now to introduce Karolina Poplaska-Tomasevic, who I've been working very closely with over the last 3 years or so, 2 years, and Mr. Kataria, who's been one of our sponsors and donors as supporting this research program. So Karolina, over to you. You're going to tell us a little bit about the subtype. So we'll bring it down to the clinic after those beautiful talks. We heard about RBD and from Annette's clinical perspective to the clinical arena. How can this sort of help our patients in real life? So we're talking a little bit about real life medicine, and I hope you'll hear from Karolina about that. Oops. Are you okay? Yes. Good. Thank you. Over to you.
Thank you for that kind introduction. And in my focus, in my talk, I will focus on comprehensive care for people with Parkinson. And of course, we all know that Parkinson disease is a complex, neurodegenerative, progressive syndrome rather than a single disease, with a dramatically increasing prevalence that is expected to double over the 2 decades. And the incidence is projected to rise from 5 to over 100,000 new cases yearly. Another major problem is early onset PD, so PD diagnosed before the age of 50 with a high non-motor symptoms burden, with a higher risk of impulse control disorder, more genetic cases, with a huge societal and financial impact, higher rate of anxiety and depression. And also there are some racial variation, with PD projected to increase significantly in Asia, Africa, and in the Middle East. And recently, a very interesting study was published by Dr. Mehta and Professor Chowdhury with Emirati population. And this study showed that Emiratis appeared to have an even higher rate of young onset Parkinson disease compared to white Caucasian European population. So all of that means that care for Parkinson disease must be holistic and comprehensive. But at the same time, there is a treatment burden with, as you can see here, several causes, such as treatment, workload, and challenges of taking medication. Some healthcare provider obstacles, like lack of patient-centered care, poor patient-provider relationship, lack of care coordination, inflexible organizational structure, limited access to the service, lack of the proper information. And so this treatment burden can lead to physical and mental exhaustion of the patient, but also caregivers. So to fill this gap, we developed the stepped care concept, linking together motor and non-motor assessment that can be easily applied in a very busy clinic. We all the clinicians, so we all know how outpatients clinics looks like. And now I will guide you through all its steps, also including the subtyping and the use of dashboard recently created by Professor Chowdhury together with expert patient Sir Nicholas Mostyn. And the need for stepped care came actually from this international survey, which you can see here. I will quickly remind you, give you some information about the dashboard itself. So the dashboard consists of 5 domains called vitals, as you can see here. So we have motor vital, non-motor one, vision, gut, oral health, bone health and falls, comorbidities, and co-medication. We have data from all over the world. And in this survey, the physicians were asked from general neurology, outpatient clinic, movement disorder center, they were asked several questions about comprehensive care for people with Parkinson. And as you can see here, this global survey showed that, for instance, gut, oral, vision health were recorded in less than 20%. The bone health recorded was also less than 20%. DEXA scan was performed in less than 15%. And non-motor symptoms recorded in less than 70%. So this reflects a shocking gap of care for PD globally. The stepped care consists of 3 steps, as you can see here, including motor and non-motor assessment, subtyping, and dashboard implementation. And the first step itself include a simple motor assessment with Heniar staging and a self-completed NMS quest by patient. And as you can see on that film, it is worth noting that NMS quest is patient can do by themselves in the waiting room before the visit, so it's not time-consuming. And the first step also includes the question about dyskinesia and gait problem. You can ask me why Heniar staging. We have so many other scales. So because Heniar staging is one of the longest standing category-based scale using worldwide, and it's very easy to apply it and very quick. So our basis of stepped care is based on modeling studies, which has shown that actually combining Heniar stage with NMS quest provide a reliable insight into motor and non-motor burden in real-life clinic. And here you can see our validation data on the stepped care protocol, which is currently under the final review. And this global study, including patient and physician from 20 countries. And as you can see here, it showed overwhelming support for using the stepped care in the clinic. So 92% of physicians and almost 99% of patients were in favor, as is shown in this slide. Now let's talk quickly about non-motor subtypes in Parkinson's disease. Of course, it has been well established that PD is not a single disease; it's a complex. It's a complex syndrome, and of course, plenty of motor symptoms exist. But we cannot forget about the non-motor one, which also has to be addressed. And many years back, in 2016, Professor Chowdhury, together with Dr. Sawabier, developed the concept of non-motor subtyping and distinguished then 7 subtypes of PD, as you can see here. And according to pathophysiology, of course, we all know that dopaminergic dysfunction leads to motor deficit, and based on that, we can distinguish tremor dominant type, akinetic rigid type, mixed type, postural instability, and gait disorder. But in turn, non-motor dopaminergic dysfunction can be grouped into 3 main subtypes, as a cholinergic one with cognitive problem, a serotoninergic one with sleep and mood disorder and fatigue, and noradrenergic related one with dysautonomia. So from 7 subtypes, we can now distinguish 3 main ones. Once again, cholinergic with severe cholinergic deficit, which are associated with dementia and Parkinson. Recently described PARC sleep, which is related with serotoninergic dysfunction, with excessive daytime sleepiness and a whole variety of sleep problems, and noradrenergic type dysfunction with RBD, pain, anxiety, and dysautonomia. And all of these symptoms should be addressed in everyday practice, and this takes us to step number 2. The second step. And in this step, we are asking patient about 2 simple tests. So we ask, here you can see, we ask about drawing intersecting pentagon and naming animals within the 90 seconds, which is a test for lexical fluency. And patient has to name at least 20 animals. And we are used the campaign study protocol, and also we recommended Epworth sleepiness scale. And these 2 tests came from a campaign protocol study. This is the study published by a Cambridge group, I guess, and they showed that when patient had a problem with either of these tests from the beginning, then could rapidly progress to dementia up in approximately 8 years, as is shown in this graph above. Another problem connected with cholinergic dysfunction is, of course, postural instability and freezing of gait, which are the most debilitating dopamine refractory motor, this time impairment, especially in advanced stage of Parkinson. And here you can see, the patient with freezing during the turning. So the upper part of the body is moving, but she presents severe freezing. Another feature of cholinergic subtype is cholinergic apathy, which is different to dopaminergic apathy. And according to MDS, the latest MDS recommendation, the treatment can include rivastigmine, which seems to be effective. So Stepker then advocates, we can say, personalized subtype-specific therapy, and the treatment of the cholinergic subtypes include avoidance of anticholinergic drugs, especially with the index more than 3. I will tell you more about it later. Consideration of early use of rivastigmine, also cognitive behavioral therapy if it's available or needed. Also, early bone screening has to be performed to ensure the optimal osteoporosis management to avoid fractures due to the gait problem and falls. Also, the proper rehabilitation must be implemented with cueing for walking exercises for on-freezing. And here you can see the video of Professor Chowdhury, who is teaching the patient how to walk properly. And actually, it's very good exercise walking through this slide. And also we can use microbiota, probiotic to enrich gut microbiota. So now let's talk a bit about another non-motor subtype, which is a PARC sleep phenotype related to serotoninergic dysfunction, as shown in this PET study with DAS-B ligand. And the real importance of recognizing the PARC sleep in the clinic using the Epworth sleepiness scale, which also is in second step, is to avoid the potential event of sudden onset of sleep when using dopamine agonists, especially pramipexole and ropinirole, to detect sleep apnea and to make appropriate life choices. Because the use of dopamine agonists with high D3 receptor activity, like pramipexole or ropinirole, can be dangerous, especially for this subgroup of patients, and may cause to sudden onset of sleep, which can resemble narcolepsy-like syndrome, and potentially can lead to car accident, head injury, drowning if swimming alone, or suffocation. So once again, we have to remember that especially pramipexole and ropinirole show high D3 receptor activity, and we must be particularly conscious about this drug in this group of patients with serotoninergic subtype, with PARC sleep subtype. And recently, we conducted a retrospective analysis of a PD patient treated with dopamine agonist, and approximately 43 of the cohort reported a high likelihood of dozing off while stationary in car, which showing a clear risk of falling asleep while driving, operating machinery, or swimming. So also it shows how cautious we have to be with this kind of drug, and also we have to remember to do the Epworth sleepiness scale. Another major issue in PD is wide range of sleep disturbances. And these two recent reviews present an overall approach to sleep problems in PD from excessive daytime sleepiness, RLS, RBD, and also insomnia. Insomnia also is a quite frequent problem and can be treated by using melatonin. Also, dopamine replacement therapy can be treated by sedatives. Also, we have to remember to treat comorbid psychosis or depression. Another problem is fatigue, and here you can see the rationale for fatigue treatment, also taken from MDS recommendation. And MAO-B inhibitor, especially rasagiline, seems to be effective and don't require, and very safe, and don't require any specific monitoring. Another psychoactive drugs like methylphenidate or modafinil, non-pharmacological intervention like acupuncture still don't have sufficient evidence of efficacy, but of course sometimes they are also used in terms of clinical need. So to summarize the treatment of PARC sleep and the serotoninergic subtype, the treatment include avoidance of D3 activation, use alerting agent like modafinil or caffeine, and using rasagiline, make a proper lifestyle modification, so be careful with driving a car or swimming alone. We have to review for sedatives, another dopamine agonist, or other somnogenic drug, and also we have to treat fatigue, as I said, sleep apnea, and in advanced cases we can consider advanced technique as well. Now let's look at the noradrenergic subtype, recently described also by Professor Chowdhury with Dr. Letta. And this subtype characterized by RBD, dysautonomia, mainly orthostatic hypotension and urinary dysfunction, anxiety, pain, abnormal cardiac, and IBG. And from a motor perspective, it is associated with akinetic rigid syndrome and freezing of gait. And here you can see the two examples of RBD, which today we heard about RBD. So, which is that this is the sleep disorder when patients act out their dreams during the REM sleep, often with vivid, sometimes violent movement and vocalization, because of the lack of relaxation, muscle relaxation that normally occurs during the REM sleep. Another problem is pain, and according to the King's Parkinson disease pain scale, 7 domains of pain can be distinguished, as you can see here, and treatment is related on the type of the pain. So for neuropathic pain, we of course can use antidepressant drug, anticonvulsive drug, combination can be used, with opioids considered like the last option. And for nociceptive pain, non-steroidal anti-inflammatory drug can be used like a first choice, and then before moving to low or high potency opioids. And in this busy slide, you can see actually all features of noradrenergic subtype with a proper treatment. So, for instance, for orthostatic hypotension, midodrine can be used. For instance, when we have major depression with anxiety and panic attack, we can use reboxetine, which is selective noradrenaline reuptake inhibitor. When we have depression which coexists with pain, we can use duloxetine, which is a serotonin and noradrenaline reuptake inhibitor. And for urinary urgency, mirabegron can be used. So we can, in terms of clinical setting, we can try to use the most suitable drug. So the treatment of the noradrenergic subtype include management of dysautonomia, as I mentioned above, treatment of RBD with using melatonin up to 10 to 12 milligram or clonazepam. We also can treat anxiety by using venlafaxine, reboxetine. We have to manage with non-motor fluctuation and we have to treat anxiety and pain. This brings us to step 3, where we focus on oral gut and vision health, bone health and frailty, as well as co-medication, especially drugs with anticholinergic effect. And on this table, here you can see a medication with anticholinergic effect, and especially we have to be careful with those who have very strong, so it means more than 3 points in this anticholinergic index. Recently, a very important paper was published showing the association between anticholinergic burden and risk of acute vascular events. So the authors state that drugs that have more than 3 points are related with a very strong risk of potential acute cardiovascular event in older adults. And of course, also we mustn't forget about the many other side effects of anticholinergic drugs, such as cognitive impairment and gait difficulties. And here you can see the calculator for anticholinergic effect. And on the graph to your left, I highlighted the paper where it's very interesting paper, I think, where the red areas show states in United States with a high burden of exposure to high potency anticholinergic drugs and high rate of cognitive impairment in PD. So you can see how big problem it is. So the key message is please avoid anticholinergic drugs generally, but especially in those patients with cholinergic subtype. So those patients who have a problem with copying, drawing intersecting pentagon, or having a problem with lexical fluency. Another thing we have to discuss is bone health. Broadly speaking, 2 out of 5 women and 1 of 6 men over the age of 50 have osteoporosis. So the bone health must be checked to prevent fractures. We all know that people with Parkinson have a gait problem, falls. So we have to remember about it and perform the DEXA scan if it's needed. Similarly, when it comes up to the gut health, it is important not to forget the danger of Helicobacter pylori infection, which can be easily diagnosed and can be easily treated by antibiotics. And left untreated, it causes a problem with levodopa absorption. Another thing is that we should avoid dairy consumption after levodopa intake. As you can see here, dairy flattens the levodopa absorption curve, as is shown in this very nice study. So also we have to warn the patient about it. And all of these you can read in the recent Professor Chowdhury paper, and also the mobile app is on the way. And also the stepped care, we can say, is also integral part of all advanced therapies. Here on the slide, you can see all available advanced therapies. So you can see infusion, the intrajejunal infusion, subcutaneous infusion, and deep brain stimulation. And generally speaking, all advanced technique increased independence of patient, increased mobility. So we really have to remember about all these vitals to be checked, and we really have to address all collateral problems which are connected with Parkinson's disease. So now I'm coming to conclusion. So stepped care management of Parkinson's should include, as I said, holistic motor, but also non-motor assessment and subsequent clinical subtyping with a dashboard-based personalized care. Such history is a part of the dashboard for PD and may avoid important complicated in Parkinson's disease, such poor levodopa response and delayed time to on because of dairy or Helicobacter pylori, falls and fractures, possible aggravation of cognitive dysfunction, and potential risk of cardiac arrhythmias when we're using anticholinergic drug, sleep attack with potential consequences on driving and occupation. So stepped care proposes to combine non-motor subtyping with use of the dashboard and is globally relevant and needs implementation, and digital app development is in progress. So once again, I would like to thank you, Mr. Raghu Kataria Foundation, for support, also Professor Chowdhury, my main collaborator, Professor Odin for invitation, PDNMG group, thank you very much.
Thank you, Carolina, for taking us through that very comprehensive treatment paradigm. Any specific questions on that? Okay. I'll take it.
Thank you. This was a really nice and comprehensive overview. I have two questions. One is, how would you clinically distinguish between dopaminergic and cholinergic apathy? And the second question is related to sweating, because it doesn't turn up on your slides, and I experience it's for a certain type of patients a huge problem. And how would you approach it?
I think, from my perspective, it's quite difficult to distinguish cholinergic apathy from dopaminergic, and actually we just can try just a proper drug. So we can try rivastigmine, which is really good when the apathy has this cholinergic background, or for instance pramipexole, which has a very good, maybe not for apathy, but antidepressant effect. So I think that there is no clear test which can distinguish these two forms of apathy, but you can just check, I think, these two drugs.
Yeah, if I can add to that, if you have the problem with the intersecting pentagon copy and the lexical fluency, and that goes with apathy, that's likely to be cholinergic. Dopaminergic apathy is not common. And you really see that only with fluctuations. When you get motor fluctuations and non-motor fluctuations, that time you can get an apathy with the off periods, and that's more dopaminergic. So usually it's more cholinergic origin.
Yeah. And we didn't address the sweating because there is no effective treatment, actually.
It is, but sweating, you're quite right. But again, we see that mainly as part of the autonomic part of non-motor fluctuation. I will address that in my talk. So it's a very good question. Professor Slaven.
Thank you for this excellent talk. I would like to ask about the medication, anticholinergic medications, because there is a plethora of different medications. Can we put them in a specific order, medications with a high risk or the lower risk? And we know that we have a specific calculator to measure the anticholinergic burden in terms of medications. Do you recommend to use this calculator in clinical practice?
Actually, I'm using this, and especially I'm very careful. Maybe I can go back my talk to this drugs which has the more than 3 index. So they are listed here. And as you can see, from Poland perspective, for instance, amitriptyline is very widely used for when patient has diarrhea, for instance. So when some cognitive problems started, I'm especially careful with this more than 3 index, and just ask patient which other drugs is taking and trying to change if it's possible.
Yeah, I think the use of the calculator is very useful,
useful,
and we have to go by that. I think. That study is quite interesting. There's Dan Weintraub and others showing that high rates of dementia in states with high anticholinergic use. So. Yeah, exactly. Also, combined effect.
Mm-hmm.
Correct.
Yeah.
Yes. That's also true. Yeah. Mm-hmm. So, if not, thank you very much. Thank you. So we move on to the next paper and the presentation, which is also very interesting and fits in nicely with the program theme, which is about biomarkers in neurodegenerative disorder and update. And we have Ruben Smith from here in Lund. Thank you very much for coming and speaking.
Thank you very much for the presentation and for the invitation to come here to talk to you today. So I'll be presenting, I think it's slightly changed from what's in the program, the title. I've narrowed it down a little bit to be biomarkers for movement disorders, not for neurodegenerative disorders. And it's going to be a bit of a mix of everything here, so just bear with me with that. So it started about 15 years ago when alpha-synuclein was quantified in CSF, and the initial report said that, well, there is a decrease in PDNMG patients, but follow-up reports show that there is a decrease, but there is also a very large overlap with control. So it's not really a useful biomarker for an individual patient. Now, more recently, there's been a development that Annette was alluding to earlier here with synuclein seeding assays that basically work in the way that they can detect misfolded alpha-synuclein in the patient sample, and then you allow it to react with recombinant alpha-synuclein and form aggregates that can then be detected. And then you have an increase in fluorescence that it's detected over time as a positive outcome. This turned out to be a really sensitive measure for PD and DLB, so for Lewy body related alpha-synuclein, as you can see here in the left-hand side, with a very high discrepancy or a very high difference between patients with PD, DLB, and also IRBD and PAF. But then you can also, if you look at the left-hand side there, you can see that also for MSA, these assays, at least this initial assay, didn't seem to work as well. This was then later on replicated in another study showing a very high sensitivity for PD and PDD. And relatively good specificity also in controls, even though there are some positive cases among the controls. And interestingly, 2 of the controls that later on converted to Lewy body disease were actually positive already at an asymptomatic stage. Now comparing these assays to neuropathology to see whether the results you get from CSF actually corresponds to Lewy body pathology at autopsy, it was found that it seems that these assays are really sensitive to at least more widespread Lewy body pathology. So in participants with cortical Lewy bodies, that is the last stage or the most widespread Lewy body pathology, almost everyone is positive for these synuclein assays. Whereas in patients with more brainstem or amygdala or more limbic only Lewy body pathology, that is, then not as widespread Lewy body pathology, then about 50% are positive in these assays. So does it really matter to be positive on a synuclein assay? And to answer this question, Sebastian in the group studied about 1,200 participants that were initially or at baseline cognitively and clinically unimpaired, so no PD symptoms, no cognitive symptoms. You can see here the prevalence of the different pathologies studied in the upper left graph, and the pathologies studied were Lewy body pathology or AD pathology studies, beta amyloid or tau. And about 6% of the participants were Lewy body positive, isolated Lewy body positive. About 12% of the participants were AD biomarker positive, and about 2% were positive for both Lewy body pathology and AD biomarkers. And as you can see in the lower graph, the prevalence of these pathologies increased with age as expected. Now, already at baseline, you can see that having the green ones to the left are the ones without any pathology, and then you've got Lewy body pathology, AD pathology, and the combination. And you can see that both for global cognition and memory, it seems that having just Lewy body pathology is actually not good for you. They have slightly worse results at baseline, even though they're cognitively unimpaired compared to the participants without any pathology. And then having AD pathology and the combination, or having the combination, is even worse. This is true for global cognition and for memory. For smell, however, it seems that having Lewy body pathology is associated to a reduced sense of smell that is not present in the AD pathology only. Now, this is also true when you will look at the longitudinal trajectory of these patients. So it seems that having either Lewy body pathology or AD pathology results in a faster cognitive decline over time that is even more pronounced if you have the combination of both pathologies. And this is true for basically all studied cognitive measures. Interestingly, we also found that among the ones that were synuclein positive or assay positive at baseline, they ran a very high risk of developing Lewy body disease, either than DLB or PD, over a 10-year period, whereas none of the ones that were synuclein negative developed Lewy body disease over those 10 years. So it seems having synuclein positivity in CSF is not really a benign thing. It's associated with faster cognitive decline and to the risk of developing Lewy body disease. I'm not going to go through this as much in detail. We then did a similar study looking into cognitively impaired patients, that is, patients having an MCI diagnosis. As expected, you have a higher prevalence of the different underlying pathologies, and they have very similar results when it comes to lower cognitive function, both with the global cognition at baseline. And interestingly then, attentional or visuospatial function, there it seems that Lewy body pathology is associated to lower scores compared to the AD pathology. And similarly to the cognitively unimpaired participants, the cognitively impaired participants have a more rapid rate of decline, having either Lewy body pathology or AD pathology. And the combination performs the worst. Now, so for the SAA results, initially they were treated as being either a yes or no answer. It was a dichotomous result. You either had it or not. More recently, people have been starting looking into different dilutions and having several wells where you assess the positivity and assessing the number of positive wells at different dilutions. And another way of looking at a concentration of alpha-synuclein in these CSF samples is looking at the lag phase, how long time it takes for the assay to become positive. You can also look at the intensity maximum of the assay as a measure of how much pathology you have from a start. So this was done in a longitudinal assay, and then now this is a little bit complicated. So to the left here, you've got an LBD-C group, that is the Lewy body converters, and then you've got the non-Lewy body converters, and that is a little bit difficult to get earlier. Or we need to explain how those groups are formed. So the non-converters are the ones that are positive already from a start. So they have a positive synuclein assay at baseline and then at follow-up. And the converters are the ones that start out negative but then convert to positivity over time. And then we can see that compared to the ones that are positive all throughout, the converters have a lower number of replicates and a longer lag phase, indicating that they have lower levels of synuclein from a start, which makes sense in a way. We can also see, and this maybe addresses your question to some extent, how can we determine whether an IRBD patient will convert and when that will happen? And we can also then see that the participants here converting to PD dementia do have higher levels of synuclein at baseline than the ones that remain cognitively intact. So potentially assessing the concentration of synuclein in the CSF sample could give us some sort of hint of when the patient is going to convert or not. This is another way of measuring synuclein load in the CSF sample. And so the log10 SD50 value there is really a value of how much you can dilute a sample and the sample is still positive. So the more you can dilute the sample and the sample is still positive, the higher amount of synuclein you've had in the original sample. So basically, the higher value you have on the log10 SD50 value, the more synuclein you had from the start. And then we can see that it's really nicely correlated. On the y-axis is the Lewy body density score in neuropathology. So the higher up you are on the y-axis, the more Lewy bodies you have on neuropathology. So it seems to be very highly correlated to the CSF values or concentrations of synuclein. The bead graph basically just shows the same thing in a slightly different way. But I think that the curves on the right are also interesting. These are different, the same sample, different dilutions. And you can see that the 1 to 900 dilution, the blue line on top, has the highest concentration of synuclein. And here at the very high dilution, the purple line at the bottom, there it's very little synuclein left. And then you can clearly see that with an increase in concentration, you have a shorter lag phase, so the assay becomes positive at an earlier stage, and it also reaches a higher intensity maximum. There's been a number of different assays that are also available to us as clinicians, at least in Sweden, at least some of them. So Abvis developed one, Amprim has developed one, and Belcoy as well has developed one. And they all seem to perform very similar when it comes to sensitivity and specificity. And as was also mentioned earlier on, people are now looking into, or have been looking into, these assays in different biofluids and tissues, and these are results from skin biopsies showing that also in skin biopsies it seems we can with a relatively or with a very high accuracy actually determine if someone has synuclein or not. I've seen other results from skin biopsies indicating that they might have slightly lower sensitivity compared to CSF, but I guess that will remain to be seen in the end, how sensitive these different tissues are. We don't want to know, since we know that sense of smell is really related to, or has been suggested as a prodromal PD risk factor. And we wanted to know whether you could use the sense of smell as sort of to enrich a population for synuclein positivity, and whether you can use the sense of smell to select out who should then be tested for synuclein positivity. So basically, this is an autopsy cohort where people where there was data available for smelling function. And people were divided into then either having poor sense of smell or normal sense of smell. And you can see then that in the synuclein assays, as expected, the ones that are negative here to the left, the ones having no Lewy bodies are very likely to be negative, and the more Lewy body pathology you have at autopsy, the more likely you are to be positive in the SAA assay. But also interestingly, we can see that the more Lewy body pathology you have here on the x-axis, the lower levels you have, or the lower results you would have on the upset smell score. So it seems there is a correlation between low alpha-synuclein load in the brain and the sense of smell. And if you just dichotomize results based on synuclein assay to negative or positive, you can see that the positive group they have much lower results on the upset score. If you then use these different the upset score and the synuclein assay to predict whether someone has Lewy body pathology in the brain or not. You can see that using the upset score only, then you get an accuracy of about 75%. If you use the SAA assay alone, you get a good accuracy of 92%. And if you then use these two combined, you reach an accuracy that is slightly higher, so 94%. This is for predicting neuropathological alpha-synuclein. If we then take these results out, this is into the PPMI study, so this is in the in vivo cohort, and here the sense of smell is used to predict synuclein positivity, and there in the SAA test, and then you can see that the smell test can reach an accuracy of about 80% in predicting synuclein positivity in vivo. So I think we're now with the ability to really detect synuclein in vivo in biosamples from patients. We're now moving towards a shift in our paradigm shift, where the diagnosis of Parkinson's disease could actually move from a clinical diagnosis into a biologically underpinned diagnosis, very much as we've seen with Alzheimer's disease happening maybe 15 years ago or so with the emergence of beta amyloid biomarkers. So just coming back to, this was not supposed to be only Parkinson's disease, but movement disorders in general, coming back to MSA and these synuclein assays. There's now been a report using the Ampren method that they can distinguish MSA-related alpha-synuclein from Lewy body-related alpha-synuclein with a relatively good specificity and sensitivity. And then you can see that actually the curves, they do tend to become positive also in the MSA cases, but the shape of the curve and the maximum intensity is very different from the ones with Lewy body diseases. Now, moving into something completely different. This is just a few words on the development of alpha-synuclein PET ligands as biomarkers. And there's, over the recent years, been a couple of papers published with human in vivo data for a number of different tracers. I'll just walk you through that very quickly here. Let's see. So the first paper was published by Makoto Higuchi and the group in Tokyo on the tracer called SPAL-T06, that is fluorine-labeled tracer. And these are the only images I've seen of this tracer. There are 3 MSA cases here, and then the control. And at least in 2 of the MSA cases, you can see a bit of binding in the pons in the cerebellar white matter, where you expect to see pathology in MSA. Now, the last thing I heard from Makoto Higuchi was that they discontinued the tracer due to off-target binding of the tracer. So I don't know whether we'll see any more data coming out of that. We then did a study with the Swiss company AC Immune for one of their tracers called ACI 12589 that showed in vitro a really nice binding to alpha-synuclein that was quite specific when it came to alpha-synuclein compared to beta amyloid or tau. And in the autoradiographies from MSA and PD patients, we could see a quite strong binding of this tracer. The dissociation constant was reasonable, 17 nanomolar, so it's not really strong, but it was maybe not as strong as it should have been, I should say. At least in vivo, then when we tested it, we were really quite enthusiastic when we saw that the MSA cases in the third one in the upper row here, they had a quite strong signal in cerebellar white matter where you expect to see pathology, and this binding can clearly differentiate MSA patients from other synucleinopathies and controls. Then what we did was that we started scanning other people with other neurodegenerative disorders, such as PSP, that is supposed to be tauopathy, and hereditary ataxias that are not associated with alpha-synuclein. And then we saw that there was binding also in those cases, not as strong as the MSA-C cases, but at least there was some sort of off-target binding that we couldn't fully account for. Also in AD cases, then we saw some sort of general neurodegenerative off-target binding that led to a bit of signal that we couldn't account for. I still think that we can use it to differentiate MSA cases from other cases, but there's some problem with the tracer still. More recently, Makoto Iguchi and his group and Hironobu Endo published this paper in Neuron last year using a tracer called C505 and they found quite nice results. This is binding in the substantia nigra of PD patients and controls. So you can see that the PD patients have, at least at the group level, slightly have a higher binding than the controls, and there are some cases that have an increased binding. But there is also quite an overlap between groups. Now, also this tracer, it's based on an old type of tracer called PBB3 that was developed as a tau PET tracer. And as you can see here, they've compared the binding to Lewy bodies against amyloid plaques. So Lewy bodies in black, amyloid plaques in gray, and tau in white. And you can see that also for the C505, there is a stronger binding to alpha-synuclein, but it's only about 60% stronger than the binding to amyloid or tau. So it has also got some specificity problems that will become a problem if you scan non-PD neurodegenerative disorders. I know that ACI are working on the follow-up study or follow-up compound of 12589, and they presented this data 2 years ago at AAIC, showing slightly stronger binding with their new compound compared to the previous compound. And I guess we'll have to see what comes out of it when it comes to the in vivo scanning. And then, I don't know, maybe you've seen the Merck has presented some also very promising data from using a carbon-11 tracer. I couldn't access their images, so therefore I didn't include it here. But there is at least some progress in this field. Now coming back to wet biomarkers, this was published 2 years ago, and it was based on in the Biofinder group on a proteomic study comparing PD patients to controls and seeing what proteins are significantly different. And what comes out as really Oh, sorry. It's not a pointer. Sorry. Okay, so you can see the point up in the right-hand corner in those graphs, right? That is DDC. So it has a very high effect size, and it's very significantly altered in PD compared to other controls. And when we looked at it, this is a comparison. Controls versus Lewy body disease, you can see that there is a clear increase in the Lewy body diseases. But also, if we look here in this on top here, you can see the synuclein negative controls compared to synuclein positive controls. And also there seems to be an increase in DDC in the synuclein positive controls. So it seems that it is an early marker of some sort of pathological change happening with alpha-synuclein accumulation. And it's not fully specific to alpha-synuclein. There's also an increase in other atypical Parkinsonian symptoms, so diseases affecting the basal ganglia. This has then been replicated also in 3 other cohorts, so it seems to be relatively consistent, and there is an increase also in prodromal and early untreated PD cases in the CSF. Now looking into plasma instead, so it would of course be good to if we could analyze this in plasma instead of CSF, but looking into the plasma data, there was really no difference. So it seemed DDC in plasma couldn't tell the PD patients apart from the controls. However, when the PD patients were followed longitudinally, there was an increase in PD patients. This was also seen in the Appleton study, where there was a difference between PD patients and controls, but there was no difference between controls, prodromal PD, or PD patients that were not treated. And they also saw that patients treated with levodopa containing the dopamine decarboxylase inhibitor, so containing carbidopa or bensericide, they had increases in the plasma DDC values, whereas patients treated with the dopamine agonists alone didn't have these increases. So it seems that the effects here is likely then driven by an increase in DDC that is induced by the blocking of the protein with levodopa. So it seems to be not as useful in plasma as in CSF. Then I just wanted to show this one as well. This is not PD related, but this is I think very beautiful data from Anders Schneider's group in Germany, looking into plasma extracellular vesicles, and where they did 2 different assays. So one assay is determining 3R and 4R tau. And then they create, so on the x-axis, there's a ratio of 3R over 4R tau abundance in these vesicles. On the y-axis is the presence of TDP43 pathology. And then in controls, the controls are the blue ones you can see here close to it, in the little square at the bottom here. So they have a 1-to-1 ratio of 3R and 4R tau, and they are low in TDP43 pathology. Then you end up, in the left-hand corner, you end up having the 4R tauopathy. So the patients with PSP end up in the left corner. Along the low in TDP43, but on the high in the 3R, 4R ratios are the 3R tauopathies, the PIX diseases, like behavioral variant frontotemporal dementia that is caused by tau or 3R tau. And then with a normal tau ratio, but increasing on the y-axis, are the different TDP43 diseases, as ALS or behavioral variant frontotemporal dementia caused by TDP or associated to TDP43 pathology. So this was really beautiful. It came out in last year in Nature Medicine. I haven't seen it replicated though, but it seems really promising if we can just get this method working. So in conclusion, for the biomarkers, there's been quite a lot of positive development over the past years, especially I think with these synuclein seeding assays that show a very high diagnostic accuracy and that seem to reflect the amount of Lewy body pathology in the brain. There's also been some development with MSA, even though I think that there will need to be some fine-tuning with those assays. It's also very promising that it seems that we can detect synuclein also in skin biopsies, and I know that there's been other biofluidics tested as well, so feces and urine and saliva and such. But I still think that skin seems to be the strongest competitor outside of the CSF. There's been some development of the alpha-synuclein PET tracers, even though we're not really there yet. And CSF DDC seems to be an early marker of changes in the basal ganglia, either due to alpha-synuclein or other Parkinsonian disorders. And there's this new very promising results for TDP-43 and different forms of tauopathies. And with that, I'd like to thank you for your attention, and these are my collaborators here at Lund University.
Thanks very much. Would you be happy to take a few questions?
Yes, of course.
If we have a little bit of time. Irina, and then Angela. Sorry, 3 questions, sorry. You first.
Thank you very much for this very comprehensive talk. With respect to DDC and CSF, does this also change with dopaminergic medication? Is that known from longitudinal studies?
My feeling is that it changes very early on. So it changes also in the cognitively unimpaired or unaffected participants that are synuclein positive. Then it seems to stabilize on a set level. So my gut feeling is that it wouldn't change very much with the treatment or later on. It becomes, or it increases, and then I think it stays up, really. But I haven't got the data to really base it on solid evidence, I must confess.
Angela?
Thank you for the great talk. I just wonder, what is the practical advantages of using skin biopsies or other tissue biopsies instead of plasma for this seeding assay? Because I would imagine that with skin biopsies, you need to take several samples. The skin is not homogeneously affected by any pathological deposition. What is your view about that?
So I think, of course, the ultimate aim would be to have a blood sample. It's simpler and people are more used to it. It's sort of a minimally invasive, but a skin biopsy is still a bit more invasive, and it takes a few weeks for it to heal, and sometimes there are complications as well. As far as I know at this point, there's been no really reliable or robust plasma SAA assays. So I think that's the problem. At this point, there's quite a lot of synuclein in erythrocytes. Maybe that could be one of the problems. I guess that if you could purify these brain-derived exosomes, then that might be a way forward. But there's still some work to be done.
Thank you. One last question, Philip.
Thank you very much for a nice talk. Could I ask, CSF decarboxylase, has that been compared to dopamine imaging? And does it add anything in addition to what we can see there?
It's a very good question. I don't think so. But my gut feeling is that it would be an earlier marker, since also the majority of the CSF or the CSF synuclein assay positive cognitively and clinically unimpaired controls would have a normal dopamine imaging. Is my gut feeling. At least that's my experience from looking into imaging of IRBD and synuclein positive controls, that they typically have that dopamine system in the brain is affected slightly at a later stage. And MIBG scans and the cardiac innervation could be affected earlier on, but typically dopamine imaging is slightly later.
But this would be an indicator of a central degeneration, presumably.
Yes, I would believe so. So I would believe that it's probably more specific, since you measure it in the CSF only, and there's not as much. There's a lot of DTC out in the periphery, of course, and maybe it's just a more sensitive measure of changes that are going on in the brain. Thanks.
Thank you very much for the terrific talk. Thank you so much. That brings us to the final talk of the first session. And again, it gives me great pleasure to introduce my co-host, Professor Rodin, who I'm sure will be known to all of you. I think Per is going to touch on a very important topic, which is I think, a big message for all our industry colleagues, to focus on non-motor symptoms and to get treatment for non-motor symptoms. You'll hear about the importance of that from a patient later on. And Per, I think you're going to touch upon infusion and other advanced therapies and non-motor aspects. Thank you.
Thank you, Ray. and thank you everybody for the possibility to talk a bit about pump-based treatments and the effect on non-motor symptoms. I tried to give an overview of what we have in the literature. First, the disclosures. Well, as we know, we have an increasing number of continuous dopaminergic stimulation-based therapies on the market, and especially the pump-based treatments are increasing. We now have 4 different. We have, of course, all since the 1990s, apomorphine infusion subcutaneously. We have Duodopa LCIG since about 2004 on the most markets. We have Lesigon now since 2019 in Sweden, levodopa entacapone, carbidopa intestinal gel, and we have foslevodopa, foscarbidopa subcutaneously since 2 years now. And there are more treatments of this type coming in. And we have learned over time that maybe it's not only the stabilization of the motor symptomatology that is important here. Well, all these are, of course, based on the theory that we get a more constant plasma concentration of a drug like L-Dopa if we give it as an infusion compared to as peroral therapy. And this has been shown in many pharmacokinetic studies. This is just an example. This is Duodopa LCIG in 18 patients getting it over 16 hours over a day. And we see that after getting effect of the morning dose, we have a pretty constant plasma concentration level in these 18 patients. And this is the mean, but the single patients look much the same. So a very constant plasma concentration level. Ray and Marion Politis and David Brooks also tried to look on the receptor level in the brain with raclopride displacement under Duodopa therapy versus peroral therapy, and could show that it seems that it also works on the receptor level in the brain, that we get a more constant displacement of raclopride if we treat with a pump compared to tablets. The motor effects, shortly about those. There are very many studies on this now. This is probably one of the more well-known ones, the one from Olanov et al. With LCIG Duodopa from 2014, which was then a double-blind, double-dummy study, as we know, in 71 patients. All patients had pumps, all had tablets. In half of them, the pumps were active. In half of them, the tablets were active. And here one could, first time in a larger study, show under controlled conditions that pump treatment gives a more stable motor effect compared to tablets. And what we see is the typical effect when you go from tablets to pump, that you get rid of about 4 hours of off time, or about 60% of the off time that the patient has. And we get a corresponding increase in good on time without troublesome dyskinesias. Angela Antonini, a couple of years ago, summarized the experience with LCIG Duodopa from 27 studies in 1,875 patients treated for 1 to 10 years, and could show that the typical effect is a 61% reduction of off time. So that is what we get. We get rid of about 2/3 of the off time for the patients when we go to pump therapy. So not 100% effect, but still pretty good. Also, apomorphine has now evidence after almost 30 years on the market with the Toledo study of a similar effect, about 3 hours reduction of off time and a corresponding increase in good on time according to this study. And recently, we now also for levodopa entacapone carbidopa intestinal gel have corresponding evidence from the elegance study interim analysis, which was published in the spring, that we get about 3.5 hour reduction of off time when we put the patient on Lesigon treatment compared to peroral. I will come back to that in the Britannia talk later. And we have, of course, now also with foslevodopa, foscarbidopa, subcutaneous infusion, corresponding effect, 3.5 hour reduction of off time and a 4 hour increase of good on time, according to the 1-year open label 741 study with foslevodopa. And with phospholevodopa, we also have the 736 controlled study, a double-blind, double-dummy study over 12 weeks. And it could, like we saw for duodopa, also again show that also under controlled conditions, pump treatment gives a more stable motor situation, a stronger effect on off-time reduction and on increase of good on-time, according to also this study. Shortly about dyskinesias, it was for many years discussed, do pump treatments really improve dyskinesias? The early studies from the 1990s and so did not really approach the dyskinesia so much, but we now know from many studies that there is an antidyskinetic effect when going to pump treatment. This is one of the most dedicated studies for this, the DISCOVER study with LCIG duodopa. Over 12 weeks, and using the Unified Dyskinesia Rating Scale total score as measurement, they could show that already after 2 weeks on pump, there was a very significant reduction of dyskinesia compared to control, best medical treatment, and this effect was stable up to 12 weeks. This was faster than we expected, because I think that many of us have a feeling that the antidyskinetic effect clinically comes a bit slow when we put the patients on pump treatment, but here they had it already after 2 weeks. So what about the non-motor symptoms then? Well, we get increasing amounts of evidence. This is where it started. LCID duodopa was actually the first treatment where we tried the non-motor symptom scale when it was newly developed. This is a small open-label study over 6 months in 22 patients. And we see that that we have very significant improvements of non-motor scale total score and several of the subscores when we move over to duodopa LCIG infusion from peroral therapy. If we, like Pablo Martinez did in this study, look on the effect size and remember that an effect size of more than 0.5 is a large effect, we see that many of these effects on the non-motor scale total score and on the subscores are large. So it's a clinically important effect. This has then been the effect of LCIG on non-motor symptoms has then been confirmed in many studies. This is another one of them, the Gloria registry study over 24 months with 375 patients included, showing a very significant and stable improvement of non-motor symptoms up to 2 years, which was the length of this study. Ray has, in this material, also looked on correlations and could show that the more non-motor symptom load you have in the beginning, the more improvement you get when you move to pump treatment with LCIG. And also that there is a pretty nice correlation between the improvement of the non-motor symptom total score and the improvement of health-related quality of life. So it again confirms that probably the effect on the non-motor side of the disease is an important part in explaining the improvement of quality of life with these treatments. And especially the subscores for sleep fatigue and mood cognition reflected this, so indicating that those symptoms and the improvement of those symptoms are important. Another big study showing that there is a good non-motor effect of LCIG, the Duo Globe study. This was 3 years long, and we have a significant improvement of the non-motor scale total score up to 3 years of treatment. Then a negative study, the INSIGHT study, was designed to look on the non-motor effect of LCIG, but was not significant. It compared LCIG duodopa with best medical treatment, and actually the improvement in the best medical treatment arm was so big that it was not possible to show a significantly stronger effect with LCIG. Ray again has summarized the effect on the non-motor side in 17 open-label studies with over 1,000 patients, where NMSS was used and could show statistically and clinically significant improvements from 3 months and up to 24 months, according to these 17 studies. And that was also the conclusion in this review a couple of years ago that LCID is beneficial in improving and relieving various non-motor symptoms, especially mood, cognition, memory, sleep, gastrointestinal symptoms, and urinary symptoms, and with that, quality of life. So that was LCID. What about apomorphine? Well, there we also have pretty good evidence now. This was an early study from Pablo Martinez-Martin, and we see here that also with apomorphine we have high significance for effect on non-motor scale subscores and total score, especially sleep, mood, apathy, urinary symptoms, and mixed symptoms seem to react in a good way. When Pablo then looked on the different questions in the non-motor symptom scale individually, he could also show that many of these single symptoms also improve significantly when moving to apomorphine pump therapy. And Pablo also estimated the numbers needed to treat to get this effect, and we see there that the numbers needed to treat is pretty low for a non-motor scale total score 1.9 and for sleep 1.71. So it is a common repeatable effect. Another study with apomorphine, 22 patients, 6 months, similar results, improvement of sleep fatigue, improvement of mood, and on mixed symptoms. Then Ray and colleagues put together this publication with both Duodopa, LCID, and apomorphine to the right, LCID to the left, and could show that with both treatments there are very, very nice effects on the non-motor scale total score and many of the subscores, maybe especially good effect on sleep with LCID and on mood with apomorphine. And then Haidar et al. Did the very famous now EuroInf2 study, which is actually the first and maybe only big study trying to compare the advanced therapies, including DBS, concerning effects on motor and non-motor symptomatology. And with the result that they seem to have a similar degree of stabilization of motor fluctuations according to UPDRS-4. And they all three also have non-motor effects. They have effect on the non-motor scale total score to a similar degree, and especially good effect here on sleep with DBS and LCID, and on mood with LCID and apomorphine. And altogether this results in an improvement of health-related quality of life at the top, measured with PDQ-8, also to a similar degree. We now also have data with levodopa, entacapone, carbidopa, intestinal lesigone from the elegance interim analysis, showing that also with lesigone we get this improvement of the non-motor scale total score. I will come back to that in the Britannia talk. Then several authors have also aimed to look at single non-motor symptoms to see in more detail what the effect is with the pump treatment. And a special interest has come on sleep, because sleep is probably the most reproducible effect that you get with the pump treatments. Here is one of these studies also using polysomnography to demonstrate the positive effect on sleep parameters when moving to LCID infusion. Also, the DuoGlobe study, 3-year study with LCID, show a significant and stable effect on sleep to the left here, on LCID pump treatment, and also an effect on daytime sleepiness. The ESS score even seems to improve further over time up to 3 years of treatment with Duodopa. Several studies indicate, like this one, the Cosmos study, that moving from 16-hour per day pump to 24-hour per day pump is a good thing for sleep. But it really still remains to be shown in a more stronger way that it is so. But I think that many of you or us who work with pump treatments have the feeling that when we let the patients have the pump in the night also, they will have an even better sleep. Some nighttime experience here with apomorphine, the ApoNight study. The ApoNight study showed improvement of SCOPA sleep and PDSS, and also of daytime sleepiness when having 24-hour per day apomorphine infusion. Another apomorphine study, the apomorphy study, using apomorphine only in the night, also showed that apomorphine only in the night improves sleep in patients who have sleep problems. And I know that that has also been tried in some restless legs patients giving pump treatment only in the night, and it seems to be very effective. What about foslevodopa, foscarbidopa, and sleep? Well, as expected, this is the one-year open-label study. There is a significant and good improvement of the PDSS-2 total score, as well as the subscores for motor symptoms, PD symptoms at night, and disturbed sleep up to 1 year. So a very strong and stable effect also here on sleep. And they also looked in the controlled 736 study over 12 weeks on the sleep effect in the middle here. And again, we see the PDSS-2 total score improves strongly with the subcutaneous L-Dopa infusion. This is also shown here together with that subscores again also improve significantly the motor symptoms at night, PD symptoms at night, and disturbed sleep subdomains. In another poster, one has looked on if there are any difference between the sexes, female and male patients, and they could show that the improvement of sleep as well as ADL function and PDQ-39 are very similar in men and women. Ray has also looked on nocturia in the controlled trials, the 12-week trial with foslevodopa, foscarbidopa, and the 1-year open-label trial, and could show that nocturia also improves as symptom when you have a pump treatment. And maybe this could be one of the mechanisms behind improving the sleep also. Ray again also looked on correlation between sleep improvements and improvements of off time, health-related quality of life, and ADL function, and could show a certain degree of correlation. The same type of study has been done in the 12-week control trial, again showing that there is a correlation between sleep improvement and quality of life improvement in this study. The foslevodopa foscarbidopa trials did not have the non-motor symptom scale included, but they had a MDS UPDRS, which also has, as we know, some non-motor components. And in this publication, one looked a bit closer to those and could show that also with foslevodopa foscarbidopa, there is a relatively broad effect on the non-motor side with improvements, with one exception, and that is hallucinations, and that we know that it has been not so uncommon side effects with the foslevodopa foscarbidopa treatment. So what about effect on quality of life? Well, we have touched upon it, and there are many publications around this, and most of them come to the conclusion that pump treatment gives a better quality of life for most patients, not all. This is one of the trials. This is a rather old trial from Hubert Fernandez et al. From 2015 in a large number of patients over 1 year open label. And they could demonstrate then the improvement of PDQ-39 summary index as well as 7 out of 8 subscores of this scale. And back to EuroInf, we could, as we said, see the improvement of quality of life with both DBS and the pump treatments to a similar degree. In Sweden, we also now looked on the LESIG treatment and quality of life. We have a Parkinson registry, Parkinson patient registry here in our country with about 16,000 patients in it, and we, for the years 2019 to 2022, we tried to include all patients who got LESIG as new treatment, 150 patients, and could demonstrate, apart from that it stabilizes motor fluctuations, that most patients also with LESIG get a better quality of life. Side effects and complications, I will not go deep into that. I would just like to remind us that concerning impulse control disorders, they seem to be relatively seldom with these treatments, especially with L-DOPA infusion. It seems to be a good way of improving impulse control problems. This was shown in this relatively small study from Ray's group, has also been seen in the Greenfield study with a bit more patients and QUIP evaluation. In the German evidence-based guidelines now for Parkinson treatment, actually moving to advanced therapy, either DBS or pump therapies, especially L-DOPA infusion, is recommended as a possible treatment of impulse control disorders. That together with, of course, reducing and taking away dopamine agonist. So we now have pretty much evidence on non-motor effects of the advanced therapies. We'll hear more about DBS later. And we see that there are certain differences in the profile of the effect of the advanced therapies on non-motor symptoms. And if you combine that information with information about the patient's profile of non-motor symptoms, that can maybe in the future help us to choose the right therapy for the right patient. I tried sort of to summarize the amount of evidence for effect on the different non-motor symptom categories here for the different pump therapies. And as you see, the most consistent effect seems to be with all the pump therapies, that we get improvement of sleep, we get improvement of daytime sleepiness, and we get improvement of mood, so neuropsychiatric symptoms. And also, at least for the intestinal infusions, an improvement of gastrointestinal symptomatology seems to be common. So what we can conclude is that we now have an increasing number of studies, open label studies, but still, mainly open label studies, but still that we have nice effects, we can have nice effects on non-motor symptoms when we move to pump-based therapy. And that this improvement of the non-motor symptoms seem often to correlate quite well with the improvement of health-related quality of life, indicating that, again, the non-motor symptoms are important for this, and the improvement of non-motor symptoms can be an important part of the effect of advanced therapy and pump therapies. And that L-DOPA infusion and apomorphine infusion seem to have the main effects in the sleep fatigue and the mood domains, and also, at least for the gastrointestinal infusions, on the gastrointestinal symptoms. We have indications that 24-hour therapy is better than 16-hour therapy for sleep, but we need more evidence on that. And probably we can say now that non-motor symptoms, and not least sleep, can probably be seen as part of the indication, not the only indication, but part of the indication to move towards pump therapy. Thereby, thank you very much for your attention.
Thanks, Per, for a masterful workout of the landscape. Any questions for Per in there? Professor Slavik. Sorry, I should take it.
Thank you for the lecture, but I would like to ask you about the hallucinations. There is a growing evidence that the number of patients for sleep-dopa, for scarbidopa treatment, they develop hallucinations, and even patients without a history of hallucinations, they present with this treatment. Do you think this paradigm of 24 hours infusion is should be maintained for all patients, or should we change this for the 16 hours like with duodopa? We did not observe so many hallucinations in this group of patients.
Yes, it's interesting that the phospholevodopa treatment has this effect, and I think also that the most likely reason is that we give relatively high daily doses when we give 24-hour therapy. And often, at least in the beginning with phospholevodopa, it was often also so that one did not reduce very much in the night. So probably we should work on that with the phospholevodopa treatment, that we are a bit more careful with the dosing, and that might solve the situation. Actually, we, for some time, at least when we started phospholevodopa patients, we even prophylactically also introduced quetiapine when starting up, and then took it away later if it was possible.
I think, would you say, thank you for that question. Would you say that it's also useful to lower the nighttime dose anyway when you start, so that you keep about 30% reduction of your morning dose to the night dose?
Yeah, absolutely. I mean, that we have learned with duodopa that the patients have enough effect of much lower dose in the night, probably around 30%, maybe even more.
And I've had in some places people are also skipping the night dose, so whether that becomes an issue in future in relation to 24-hour treatment, things we've seen. Lars?
Yes, short comment. First of all, thanks for your brilliant talk. And we also made the experience that lowering the dose during the night is totally sufficient to get them over very nicely over the night without the hallucinations. Probably we have to go down more forced. Another question, you might comment also, because I know that there are also many patients with long-term DBS. And we see now many patients with long-term DBS and severe fluctuations where we have now both DBS plus phospholevodopa. Can you share this experience, that there are more and more coming? And, well, in our hands, we're making good experiences with this.
You probably have more experience on that than we have. I only have a couple of patients with the combination, but it has worked well also in our hands. It's also what one hears from other centers, that the combination can be very, very favorable when one of the treatments is not sufficient for optimal effect.
It would be really useful to have that data, actually, which would be really... It makes intuitive sense, because you are going to use dopa anyway in some of those patients, so POS seems more... Yeah, thank you. Any other questions? Angela?
I have a comment. Usually the non-motor symptoms of Parkinson's disease are considered non-dopaminergic, but the fact that there is such a good effect on many non-motor symptoms by just changing the mode of dopamine administration it would indicate that there is a dopaminergic pathophysiology. What is your general point of view on this question?
Shall I take? A great question. I think it needs much more research by yourselves, because we need to understand the basic animal model-based data. But I think there are two aspects to it. One is that there is this non-motor fluctuation angle, which is dopaminergic. So when you have the fluctuations, you have this cognitive, sensory, and autonomic problems. And when you bring in a continuous drug delivery, you try to overcome that. We know that with the fluctuation data. The second is we are also learning that there are several aspects of non-motor symptoms which have a very clear dopaminergic basis, cognitive, for instance, the frontal caudate to frontal projections. Similarly, some of the other aspects of sleep disorder. So there is a dopaminergic aspect of non-motor symptoms which we need to learn more about, and second is the non-motor fluctuation angle. So I think that's where the infusion therapies, I think, come in more effectively.
Great talk. I just wanted to ask you, what is the mechanism, do you think, of improvement of impulse control disorder with switching to infusion? Because, I mean, I think the sense was that continuously stimulating that dopamine receptor was causing ICDs with agonists, and even with apomorphine infusion, you're saying that possibly less so than with the other infusions, that you're getting less impulse control disorder than perhaps without using them. So maybe you could postulate on that? I don't know.
Yes, I think that of course one component is getting away from the peroral dopamine agonists, but probably also the continuous stimulation can play a role here. And there seems to be a difference between apomorphine and L-dopa infusion. What do you say, Ray?
Yeah,
a little bit more risk with apomorphine, but not more risk with apomorphine compared to peroral dopamine agonists.
Yeah, it's very interesting because, in fact, there's been some imaging work by Paolo Piccini looking at a while back, in fact, with Kit and others, which showed pulsatile therapy is more related to ICD. By hitting the ventral striatum, it's getting your reward sensation more activated. And continuous delivery actually overcomes that. So apomorphine, in fact, has much lower rates of ICD infusion, not the injection. So I think it's a very interesting area, but I think the other thing that happens with infusion therapies, you get onto a lot of reduction of the oral therapy. You stop the agonists usually, and that might also explain why as a collateral benefit, you're not seeing that many ICDs.
Just one other comment about that pulsatile stimulation. I mean, some of these patients also, with that pulsatile stimulation, are dopamine dysregulating, right? So they have huge doses of levodopa.
Correct.
Down. So I can picture that, but it's just, thinking about continuous, long-acting dopamine agonists versus infusion, like, why would that be different? It's kind of interesting.
But there is data on that. In fact, we published that. When you compare longer-acting agonists, oral agonists, versus immediate release, the longer-actings have lower rates of ICD. That we did a European survey on that a while back. So there is probably something to do with the delivery system that is, I mean, again, we see this in DBS as well, isn't it? You've got a continuous stimulation going, your ICD rate seems to be less. I think we have
this one.
Yes, exactly. Yeah, which you did that work, and the reticotine patch.
Yeah, sorry, no, I just wanted to mention that in this study, in the DICE study we conducted, we also saw significant lower rates with reticotine compared to oral, long and short-acting dopamine agonists.
If I remember rightly, the rates were about 4.9% to 9%, which is substantially lower than ropinirole and pramipexole.
Yes, exactly.
There is more to understand on impulse control disorder, and we will have a separate talk on that later today.
Okay, perfect. Well, one comment on the reticotine patch, at least in the US, we haven't been able to use very much doses. I mean, the dose cap originally was, I think, 6 milligrams, and then it went up to 8. I know in Europe you guys have used more, but Anna, in that study that you guys did, was it like, I feel like the doses, we're just not getting to the same doses of like ropinirole and like pramipexole that we use that really fueled those impulses. So I don't know if it's a dose-dependent issue with the patch, but.
There's a difference being in US you're capped at 6. We're not so in Europe. We can use up to 16 milligrams. So this was a real life study. So people were using much higher doses.
We might not have seen the final answer concerning the dose relation because we did a study with Norwegian colleagues indicating that impulse control disorders are dose dependent with ropinirole but not with pramipexole.
Correct. Yes. That's very interesting. Yes. Okay, well, thank you very much for a fantastic opening session. I think we're going to. We have a. Ulrika, sorry.
It's
over to Ulrika.
Time for lunch. But a little reminder about everyone who is speaking or chairs for the first session right after lunch to meet our tech team to have your headsets put on properly and also that we start again at 12:30 sharp, so please be on time. And thank you very much.
So, dear colleagues, ladies and gentlemen, very welcome back. We are starting session 2, and the first speaker is Professor Elisabeth Landers, Lund University. Elisabeth is leading authority concerning dementia with Lewy bodies and dementia in Parkinson's disease, and that is what you will talk about today. Most welcome, Elisabeth.
Thank you very much. I don't have any picture of disclosures, but I'm going to do a different kind of disclosure here. It's not about financial, because I don't have anybody who is supporting me in that way. But I have a disclosure. I want to say that I'm very grateful to clinicians in the past who observed and recognized different clinical entities, such as Parkinson. But when knowledge expand, the boundaries between clinical entities change. And I think we have to be careful, and we have to have this in mind when we study the different diagnostic groups as we do. And we should not, I think, we should not treat clinical diagnosis as true diagnosis. We have to, so I welcome more biological base for diagnosis, as we heard from Professor Smith before. I think that's the way to go, and I think it will be increasingly important when we get more biological treatments directed to the causing pathology. That was the first disclosure. The next thing is that I want to say that my viewpoint in this field is that I have spent my whole research life to dementia with Lewy bodies, and that's 30 years about. My starting point has always been the experience of the clinical patients. So it's a very clinical focus on my talk today. Let's see, how do I change the picture? I'm sorry, I don't know. Oh, sorry. Okay, sorry. So, since the pathology of Parkinson's disease, dementia, PDD, and dementia with Lewy bodies is the same, alpha-synuclein, specific symptoms and what we call the disorder is more a question of timing and localization of the pathology. Accordingly, the only difference between PDD and DLB is per definition when Parkinsonism starts in relation to cognitive symptoms. So PDD is Parkinson first with more than 1 year before cognitive symptoms. And DLB, in DLB, Parkinsonism and cognitive symptoms starts within a year, or the cognitive symptoms comes first. We have heard today that alpha-synuclein has been found in multiple organs in Lewy body disease. And I think this is very interesting, and I think this was really changed our perspectives. We have known that alpha-synuclein is not only present in the CNS for maybe 20 years or more. And we also know that now that we can find it outside in the PNS. And for example, I wrote here the sympathetic ganglia, for example, in the heart and in the gut, nervus vagus and gastrointestinal, and in other places as well in the body. Lately, there are reports almost very frequently of new places, and we have also identified hypothalamus as a target, different cranial nerves with, for example, double vision as a result, the spinal cord, the skin, as we heard earlier today. These disorders are not just brain disorders. I think they are more systemic neurological disorders. Since the different locations represent different symptomatology, and it challenged us to broaden our perspective on early symptoms and other manifestations connected to the pathology. And approaching medical treatment of alpha-synuclein pathology, which is on its way, makes it even more important to recognize the full spectrum of these disorders. But it's not always so easy, because in the clinic, very many symptoms might be hidden, and they might be also important. We know that we misdiagnose and under-recognize DLB because if we look at the prevalences in different studies, for example, from a neuropathological perspective, it's about 10 to 20%. In different clinical cohorts, it's up to 24%. And in one quite well-performed epidemiologic study, 5%. But in our Swedish National Dementia Registry, it's only 2%. That must mean that we don't find them. Many years ago, one of my PhD students did a study on all patients living in special care homes for persons with dementia in Malmö, 650 persons. And we found in that study that 16 to 20% had at least 2 of the 4 core criteria for DLB. I don't say that they had DLB, but at least somebody should have considered it. And I think it was among the 655 had the diagnosis DLB. So it's under-recognized. Why do we misdiagnose DLB? Well, because I think the cognitive profile is not as in other dementia patients. Memory problems are not the main characteristic. So in a normal, regular conversation, we might be sustainable to memory difficulties in the patient, but we will not meet this in the DLB patient, and maybe therefore we miss that they have a cognitive disorder. The cognitive profile is more characterized by visuospatial difficulties, in which 3D perception and all practical motor and other activities are gradually affected. This, I would say, is often wrongly interpreted to depend on the Parkinsonism. They also have slower mental speed, which sometimes confuse our cognitive test results, leading to worse immediate memory, but a better delayed recall, which seems impossible, but could be explained by things passing very slowly through their system. And I would say that another symptom that is under-recognized is the difficulties these patients have with numbers and calculations. And that's very important, because this may lead to a financial vulnerability. And I have been part of, I think, 4 legal trials where DLB patients have been, they have been lurade, vad heter det? Förlåt. Fooled. They have been fooled because they don't understand the value of different numbers. So I think that's a good thing to look for. I hope you know that dementia is defined as difficulties to manage your daily life independently due to cognitive deficits. It's not a certain result on a cognitive test. That cannot tell us anything about if this is dementia or not. It's how you manage your life. And very often, I would say, the present cognitive symptoms are hidden behind the Parkinsonism, especially in PD patients. That they move slowly, they talk slowly. We say, well, it's because they have Parkinson. Yes, but it's not because of the motor part of the Parkinson, but the cognitive part. The cognitive symptoms can also be hidden behind the orthostatic blood pressure reaction, which then gives inability to sustain adequate cerebral perfusion, which leads to a global cognitive deterioration. I've seen many patients improve enormously cognitively since we treated their orthostatic hypotension. And maybe you know this, but you should remember that 50% of DLB patients with orthostatic blood pressure have no classical orthostatic symptoms. Other hidden symptoms are maybe the swallowing difficulties, which comes from a pharyngeal dysphagia. And they are often described as coughing at night rather than difficulties to swallow. Maybe they can say that it's difficult to the food gets stuck and they have to try to get it to cough also. Maybe that could be a symptom as well, but rarely swallowing difficulties. But this is very important to identify because as we have seen in our cohorts, 20% of our DLB patients died from aspiration instead of the expected 0.14%. So it's really something that is important to prevent. And some years ago, we also described that this dysphagia in DLB patients can be alleviated by carbohydrated drinks. 1 glass of carbohydrated water prevents or improves the swallowing for 1 hour. So it's a good practical advice you can give your patients. Also, the core symptoms of DLB can be hidden for us. And that the Parkinsonism, because it's very often without tremor. So if we don't examine the patient, we will miss it. The visual hallucinations can be hard for us to get to understand that they exist, since the patients very often have insight and they know that what they see is non-existent, and that's why they don't tell us. As one patient said to me, if I told you, you will send me to psychiatry. The RBD, as we heard before here, could have been present many years earlier and is definitely not reported spontaneously. In interview studies that I did several years ago, the wives of the patients with RBD in a common normal population, they said they would never tell a doctor. They would just shut all the windows and doors so nobody should hear this, because they were so ashamed of the shoutings and screamings at night. So nothing they would ever tell anybody. The fourth core criteria of DLB is variations in consciousness and wakefulness. And the variations in consciousness, that's episodic confusion, that is of course more often reported, but the variations in wakefulness with sleeping many hours at night and day, could be 14 hours a night, for example, not very uncommon, and this is not reported. When I asked the partners of my patients, they said, "Well, he was sleeping, so it looks so nice and easy, and I got several hours to fix with the household activities." So they don't complain about long sleeping hours. So, in conclusion, we under-recognize DLB because the symptoms are not reported spontaneously and are not visible on the outside. So we are responsible, and when I say we, I mean we doctors, not we in the room here. All of you know these things, and you don't. You ask and you examine your patients, but most doctors maybe don't do that. But I would say we, all the doctors who see these patients, we are responsible for asking about and examining the core and supportive criteria symptoms. Does he sleep many hours? Are there vivid dreams? Does he see animal or people that which others don't, and so on? And because the symptoms are not reported spontaneously, yes, that was what I said, sorry. What we also should do is we should perform cognitive testing and orthostatic blood pressure measurements, even if we don't think it's necessary, because they don't have the symptoms and they seem very cognitively orderly. So if we do that, maybe the hidden will be obvious. And we will find them, and we will be able to help them, because there are many ways of helping these patients. From my perspective, these are the patients that I can help the most in the clinic compared to other dementia diagnoses. So thank you very much.
Thank you very much, Elisabeth. Excellent presentation. Do we have comments? Questions?
Thank you.
Supranuclear palsy.
Which is in the same family. And he was asked, how does he react to that? And he says, it makes you wish you'd never been born.
Ja.
What would you say to him?
What you are saying now is also valid for many DLB patients. And sad enough, I think depression is more difficult to treat in these patients because it's due to their insight and their reflections of what they have lost and so on. And we know that more patients with DLB suicide that compared to other diagnoses. So it is really of importance, and I think for a PSP patient it's more difficult to handle, because you cannot say, as I can say to my patients, you cannot say to them, I have a lot of things I can do for you. No, but for DLB patients, there is a lot of things to do. So that's why it is easier, I think. Yeah.
Okay, thank you very much for a nice presentation, Elisabeth. I just had a brief comment regarding the prevalence estimates, and that is actually also based on this. It's Ruben up here in the back.
Yes, exactly.
it's based on the data from our cognitive impaired cohort. So in roughly 900 participants, we found that about 12% with mild cognitive impairment then had DLB pathology isolated, and about 11% had in combination with AD. So roughly 23% in total then having Lewy body pathology. That doesn't say that 23% of the population had DLB, but at least it indicates, and DLB could be more common than we think, or as you suggested, that it's maybe underdiagnosed in the population.
Absolutely, and I think it's about the same numbers from a general pathology study in the general population in UK from many years ago. About the same, I think it was 11. So, yeah.
Elizabeth, thank you so much for kind of giving your introduction with respect to how to define a disease or not. I was a little bit involved as president of German Neurology to think about how much specialization we do or not. And I think there are many, many examples where we know that kind of the biological basis is so important also for treatment and maybe development of the disease and comorbidities. Something like NMOSD and multiple sclerosis is so different that we know it's good that we have the biological differentiation. Mm-hmm. On the other hand, when we think about that, not only in hotspots like Lund University Hospital, but also way out in North Sweden. I'm also a little bit Swedish, very proud of this. Or maybe kind of in the middle of Germany where you have to ride something like 120 kilometers before you see the next big hospital. It's really important that we have some general neurologists and some general working colleagues. So with the hat of being somebody responsible for neurology in general, my suggestion is let's differentiate with respect to entities as soon as it makes relevant differences. But please let us all not differentiate all our R3, R4 subtypes of disease, Parkinsonism or whatever, to an extent that the general neurologists say, well, I'm totally overwhelmed, I can't do this anymore, I have to send them to university hospital. Mm-hmm. Just as a reply.
Yeah, I agree. I agree, because if you always think of what does it lead to for the patient, then you think your thinking is in the right direction, I think. Mm. So, okay.
Thank you, Elisabeth. Really nice and very clinical, very applicable, your lecture. I just wanted to come back to one point you made, which I really also take home from your lecture, and that's the measurement of orthostatic blood pressure, which we usually don't automatically do unless the patient reports any symptoms. And here to connect it to the cognition, I think it's really important, especially since it's so fluctuating. Mm-hmm. So I think this is a really good take-home message. Do you have any thoughts on why that is so early occurring in Lewy body disease, if there is like a neurobiological basis for that? And my other question is, how do you address this? Is this the same type of treatment we give for Parkinson disease patients?
Yes, it's the same. My last PhD student, he is having his dissertation in November, and his task was to investigate DLB and the heart. And that was because my idea was that patients with autonomic dysphagia or with orthostatic blood pressure, they have not very often, they don't have an adequate pulse reaction. So something has to be going on with the heart as well. So that's why. And actually, he has found alpha-synuclein in the heart and in the sinus node, and because he did pathologic studies, and he has also found that DLB patients get pacemaker in more frequently than other diagnoses in a big register study that we did. And he also saw that among normal Lewy body patients at our clinics, memory clinics, 10% fulfill pacemaker criteria. I think what comes out of his studies is that we also have to think about the heart, and we have to look at the pulse reaction, because maybe that's a factor behind the orthostatic behavior as well. Yes.
Thank you for your lecture. And I would like to ask you the clinical question on the differentiation between the Parkinson disease and DLB. We know that in DLB, it starts from the beginning with a cognitive decline, and in PD with motor symptoms, which are much easier to detect than cognitive decline.
Yeah.
And again, in the recent criteria for DLB, there is still the rule of 1 year, which is, I think, established arbitrarily, not proven by any clinical studies. And what is your approach to this 1 year rule? And do you use the supportive biomarkers like SPECT or other measurements which are suggested in the clinical guidelines published in neurology years ago?
Yes, for me it's well, I try to find out which symptom came first. It's very easy when it's the motor symptom, of course, but I totally agree that nobody noticed the cognitive symptoms. So too many patients with Parkinson diagnosis are actually DLB patients, in my point of view, which makes it a little bit dangerous with the medication. Maybe that is why when they get dopamine treatment first, that triggers the hallucinations, which they have inborn in the disorder, and then the whole circus is starting. And we talked about in an earlier talk here. I think you talked about clozapine. I would say, why not cholinesterase inhibitors, because that's the best medication against hallucinations. That's why we start with that treatment, and then we take the L-DOPA treatment in DLB patients, not to trigger hallucinations. You can think about that. There was something else you asked me. 1 year rule, yes. I think it's just a construction, and it's impossible. It's always impossible to know when a degenerative disorder started. It is impossible. So I don't. If the motor problem is first, that's what is. What then I think more about PD, of course. But they have to have a the diagnosis of PD. But I think the diagnosis is not only depending on that, it's depending on if you have core criteria, if you have the cognitive profile, and no exclusion criteria. So it's, but it's in the exclusion criteria, it's also about the time order. So, well, it's a problem.
Thank you very much, Elisabeth.
Thank you.
Now we are returning to the impulse control disorders, and we will hear Miriam Wolfslag talk. Miriam, you did your PhD thesis on this subject, and you have worked the last years a lot around ICDs, and now you will give us an update on that area. Most welcome.
Thank you, Per. Yeah, it's great to be back. Last time we were in a small room, we were 20 people, or not last time, my last time, 2021 during the pandemic. So it's great fun to see many more people in a bigger room and lots of interest for the topic. A little bit about me, since I think I'm much less known than many of the speakers. As Per said, I recently graduated here at Lund University. I'm now a postdoc, still at Lund University, still working with Per and other Parkinson's researchers. And I'm also a coordinator for clinical studies in psychiatry. I'm a molecular biologist to begin with, so I'm partly in clinical research, partly in preclinics and lab research, and have ended up more on the psychopharmacology side, but still work quite a bit with side effects of Parkinson's medication. And that's my thesis from April, so I'm starting to do my own research and start to grow into this disclosures. Parts of my salary as a coordinator is funded from Munich, from the pharmaceutical company here, HMNC Brain Health, and I run on a grant from Svenska Spel, the Swedish gambling, the state operator, who supports the gambling research we do. Briefly on ICDs, I think most of you know what we're talking about. For everybody that maybe works in a different corner of this, we're talking about pathological gambling, which was my main topic for the thesis and still is, since we work together with a gambling clinic in Malmö, where we get in many patients. It's also compulsive behaviors, sexuality, buying, eating, but it's a larger spectrum. These are only the biggest ones. We also see it's depending on the culture. There are some studies from Morocco, for example, that show that it can be very different behaviors. It's just maybe quite a Western perception of the main behaviors we see. Then we have a whole spectrum of like hobbyism, including pretty much any excessive behavior of collecting or of building things. I've seen gardening, and it's anything that goes over the normal. It's not enough to have a very intensive hobby. It's kind of losing control and maybe neglecting other things, crucial things in life. That's usually where we draw the line. And we have the dopamine dysregulation syndrome, which is also usually lumped into this spectrum, pretty much becoming addicted to your dopaminergic medication, which then, of course, is a bit different management approach, and they usually are a bit of their own category. But I threw them in here too. And I think we had a bit of the discussion already on the D2/3 agonists today in different contexts. I think both the narcolepsy-like state, which I hadn't heard of before, which is very interesting to hear. But even in this context, they are high-risk medication. That's been proven many, many times that in many study designs, these two are, for us, the bad guys in this context. And I think we had the question on pulsatile versus continuous stimulation, and we see that the pulsatile high-dose stimulation usually is the highest risk choice. Let's say, not broadly speaking, not in every case. So we do see cases where very low doses are definitely sufficient to cause impulse control disorders. It's not as simple. It's not a nice dose-response curve here, but we do see some association with dose and acute administration, especially orally. I brought 4 different studies today. 2 come from our own groups, 2 are others. But to cover the recent findings on impulse control disorders, this is from this year, from spring. Per, you've all met and know. I think Jonathan is sitting up there. So this was a collaboration on pretty much exploring the clinical practice side, not so much like we worked in 170 patients down here in Skåne that were registered in the Parkinson's registry. Per has mentioned it. And they had all mentioned already that they have problems with impulse control disorders. So we selected them for that and then wanted to look at how do they experience clinical practice? How are they met here in healthcare? And we used questionnaires and also went through their medical records to explore that. We did see that a bit more than 2/3 of all patients knew about this side effect issue before we asked them about anything. So they reported that I think most had been reading the adverse events disclosures of the medication or had been talking to their physician or some other route of being informed. And the staff, mostly we could tell that from the medical journals, that was very clear that the moment an impulse control disorder showed up, it was almost, I think, in every case linked to the dopamine agonist treatment ongoing. In Skåne, and it's quite an urban area. I think it's maybe a bit harder to get. We were talking, we're happy with the state of knowledge about impulse control disorders as side effects. We did also see quite little interaction with the psychiatric care. So I think most Parkinson's care providers here chose to handle at least the easier cases of ICDs in their own facility. And then we have the patient's reports on this. Multiple answers were possible, so this is why this doesn't add up to 100. We were interested if people brought it up. We maybe had the hypothesis that it might be stigmatized to talk about ICDs. There's different studies on that. It's not the most comfortable topic to bring up. I think the spontaneous reporting here that Elisabeth also mentioned is an issue, and we could confirm it with our study. It's only half of the people that had reported in our questionnaires to us in research written. They definitely have issues with impulse control disorders, but only half of them brought it up in their own care. Much less than that were actually actively asked about it, so the screening doesn't seem to be systematically established here at all. 14%, I think, is very low. Half of the patients were informed during the therapy about possible side effects, including impulse control disorders. Could, I guess, also be improved when prescribing dopamine agonists. And then there was a third of patients that wasn't included in any of these groups, so they had not ever talked about it at all in their healthcare visits. So yeah, that was a bit our insight into the clinical reality here, and possibly, while we also need to establish more knowledge, we also need to make sure it reaches out and is talked about. I think that's, whenever we talk about psychiatric symptoms, that's always an issue, that it's not as easy to bring up, and maybe also not as logical of a side effect compared to other motor symptoms, dyskinesia. I think that's a bit of a different corner. Then I brought one other study. We already heard quite a bit of about RBD today, so I think that fits quite nicely. Study, I think, also from this year or last year. I think we heard a lot about it. It's a prodromal symptom, often predicting PD in general. And this study focused on non-motor symptoms. If we can describe a profile that is most likely to show up when a patient has early RBD. It was part of the PDNMG cohort studies. They identified everybody with REM sleep disorders by symptoms, not by diagnostic measurement. That's why it's called probable here. They were followed up for at least 5 years. And then the non-motor symptom profile was mapped during this follow-up. And they mapped everything, apathy and anxiety, but I took out impulse control disorders here. Not the most pedagogical figure, but the crossed black bars, that is the RBD group. The ones without crossed bars is the control group. So we do see that the QIP score is here categorized into 1 to 7. They are generally higher, and then from left to right, if you follow the follow-up time, so it's under 2 years up to over 6 years of follow-up, you can also see a bigger increase in QIP score in the RBD group. So yeah, they could show all significant differences in QIP score. So they could show quite nicely that we can predict even impulse control disorders later on by an early RBD symptom profile. One more study from our groups. Angela sits here as well. I guess most people know her. And Per Halle was also here earlier. I don't find him. Here. Yes. So this was also published not so long ago, this spring. It was quite an extensive. It was quite an extensive rat experiment, 70 rats, and we pretty much wanted to map the pharmacology behind the co-treatment of the dopamine agonist ropinirole, the D2/3 agonist, together with levodopa. Because many studies, especially in animals, have been performed on either or, exploring impulsive-compulsive behavior, but the combinational therapy, which is very often applied in clinic, it has not really been covered like that in animal research. So that was one thing that we wanted to know. And in addition, we also mapped the striatal activity, but I'll come to that in a minute. Regarding our co-treatment, we mainly used, for the compulsive part, we used 3 different behavioral tests. Rat Iowa gambling task, which imitates the Iowa gambling task from patients, where you explore risk-taking behavior in a reward context. The compulsive checking, which I'll also show in a minute, and then stereotypical active behaviors. So we tracked spontaneous behavior in the home cage and could see differences in how often the behavior was changed and how many different behaviors were expressed. So that was the 3 main tests catching this compulsive behavior and risk-taking behavior. All clearly induced by ropinirole, quite consistent, and interestingly also to the same degree induced by ropinirole together with levodopa. So the levodopa add-on did not increase the symptom severity in our rats, which is, I think, there have been findings in both directions in clinical studies, but I think from our side, it could be a good option to treat. It's a good compromise to treat in the combined treatment, because to keep the ICD risk low, you could add levodopa, and vice versa, to keep the dyskinesia risk low, you could work together with the agonists. So for us, what we see is that the combined treatment might be a good profile to activate the broad receptors and not tip it over too much to any of the side effect sites. And we also see a similar effect in Parkinsonian rats and healthy rats, which I think points a bit towards that we have also other patient groups that are at risk here, mainly RLS patients. It's a very big group, many more people than Parkinson's patients, at least in Sweden, treated with pramipexole. And from our first preliminary results, we see that they are possibly as much at risk for developing impulse control disorders on pramipexole, both from this study and also from what we see in the clinics. So that's our main findings here. I brought, this is the compulsive checking test. A normal rat without treatment would explore quite relaxed and freely this arena, and in this rat you see it's walking quite hectic and very fast. It's also returning very often to the same spots. It's not at all looking into other corners, so this is what we call compulsive checking. It's going back to the same boxes, and this is a rat treated with ropinirole. So we track it by video, as you can see, and do a automated analysis in the video file, but I thought it would be nice to see what we actually do with our rats. And then the next part of the study was the striatum mapping. I brought both the example stainings on the top and then the group levels pooled together. Highest activity is yellow. We did find differences to be significant that are seen here in statistical mapping. And you can see that both in saline treatment and levodopa, it's a quite general dorsal activation of the striatum. I don't know how well you know your way around the rat striatum, but it's mainly the dorsal part. And then the moment we treat with ropinirole, regardless if in co-treatment or monotherapy, here on the 2 on the right, the activation is more narrow and it's more in the medial coordinates, central medial. So we do see a shift, possibly through D2, D3 receptors, more to look into, but I think it was really interesting. It was quite a robust signal. We caught it by eye. We looked through the microscopy and saw this is different. And I was in the end. I tracked all of these myself. You have to cut them out by hand. And in the end, I could really tell what the treatment was without knowing. I didn't look at the title. I just saw the image, and it's very, very interesting. It's very nice results here. Then I also brought this consensus that I guess some of you probably were part of this, and many of others have probably seen it before, but I thought it would still be a nice roundup. Now I've talked a lot about problems that appear with dopamine agonist treatment, and this is a bit what to do about it. It was an international Delphi survey process in 3 rounds. In the end, I think 30 expert views were included to reach a consensus on how to deal with impulse control disorders under dopaminergic treatment. One focus was how to classify severity, because that also, of course, changes the approach a lot, what to do about them. Then there's specific treatment recommendations for general ICDs, and then Panding and DDS separately. As I said earlier, they are usually more levodopa associated and have a bit of different dopaminergic background, so it's hard to lump them all together in management here. But I'll show you the general recommendations in a minute and the specific ones for the main ICD group. And then they also provided a recommendation what to do when the management doesn't work immediately or comes with complications here in the tapering of taking dopamine agonists out. So quite a nice article for clinical guidance, at least I think so. Exactly, this is the general approach to, regardless what severity stage, this is always the main guidelines to judge the urgency of it and perform regular screening. I've been into this before. It's nothing that is reported spontaneously usually, or it is at least hard for many patients. So the active screening is important. Involve family, significant others, caregivers. Also something we see often, it is them that bring it up. Patients themselves might not be aware, might not want to talk about it, might for some reasons not bring up the ICDs. So very important point. And then I think the legal and financial difficulties often refer to gambling disorder here. I think that's what we see with our patients in Malmö. They're often highly indebted and have come in contact with the authorities. So if that's not already in place, it's also important to support the patient in all life categories, not just look at the medical treatment, but it often comes with lawsuits, with losing their apartment. It goes very far, very fast, unfortunately, with gambling. And then I've also mentioned this before, involve psychiatry if the need for that seems to be given. And then this lovely scheme is a bit more in specific, now split into severity degrees. So if you go from left to right, slight ICD severity all the way to very severe. On the left side, the recommendation is maybe to watch and wait, or possibly go down in dopamine agonist dose a bit. And otherwise to follow the general recommendations I just talked about. And then the more severe it gets, the first idea is always to go down in dopamine agonist dose, possibly take it out completely, if possible. That's been, I think the consensus is very broad here. You see the 3 pluses, and also many studies show that helps taking out the dopamine agonists. So that is one option, which hopefully works. If it doesn't, there are other dopaminergic medications to reduce or take out. Less associated with impulse control disorders, but still might help. And then in the middle here, the orange block is alternative ideas if none of this really helps. Then we have the advanced therapies. I think Per took them up. So we see nice results on the LSIC pumps and also on DBS. That might be if other factors for the patients match as well for DBS inclusion criteria for DBS being applicable. That is a good alternative option. CBT, contact to psychiatry, possibly also bringing in quetiapine. We also already talked about the antipsychotics here, or antidepressant treatment. Really depends on the patient, in my experience. I think some respond really well. If there's a psychiatric comorbidity involved as well, the psychotropic medication is a good option, but I've also seen studies where it helped 0. So I think this is a bit case-to-case dependent. So that was me. Thanks a lot.
Thank you very much, Miriam. Excellent. Do we have comments, questions? Yes.
Thank you for your excellent work, but I would like to ask you about the definitions, because I think that now this is the hot topic, ICD and dopamine agonist phobia, which we experience after levodopophobia. And I think that in the majority of cases, maybe not majority, but in some cases, it is exaggerated a little bit. We tested patient for DBS last week, and he reported us 500 sexual intercourses last year. You know? So we decided to call his wife, and she said it's his normal behavior. We did like this, so it's not a hypersexual behavior. What about the eating disorder? Because he reported they eat compassionately sweets. No, it's normal for many years. So I think that the problem of definition is very crucial to make the diagnosis. And I remember the papers by Gila Bonner from Israel. She reported the patients referred to the specialist in sexual specialist, yes, and among 4 patients reported as with hypersexuality, only 1 had such a problem, and in 3 there were different problems. So what about the definitions and the numbers in cases reported? Because it is growing and growing number. Yes, I remember 13-15%. Now we can read in the papers that this is over 40% of patients suffering this problem. Is it really like this? And the last question is, you reported in the Swedish registry that pramipexole are the main culprits, but also you mentioned aripiprazole, and that's what was strange for me. Why? Why is that?
Okay, I'll start with the cutoff for when is an ICD and I agree. I recently performed a scoping review, and it's really hard. Like a lot of different studies use a lot of different cutoffs. Is it enough to report a lot of snacking at night? Is that binge eating? Or is binge eating when I completely lose control and gain a lot of weight? And I think in all of these behaviors that is really difficult, because we end up with prevalences from anything from, I think, 5% to 45 or even more. I personally end up somewhere between 10 and 15 after reading a lot of studies and maybe sorting out the ones that are very, very sensitive to behavioral changes. I would say as a clinical advice, for me, the biggest, we usually work in psychiatry with, is it a severe impact on life? Has a detrimental impact? With, as you say, like with 500 times intercourse per year, it doesn't have to be a problem. I guess it's like, depends very, very much on the person's situation. Other people might suffer a lot from much less severe behavior. So I think that for the individual patient, that should be the guideline, is how is the impact on life? Do I need to do anything about it, or is it fine? Is the person? I remember reading some questionnaires where I think spouses and patients were very happy about some changes. So it doesn't have to be negative. So I think that would be my main advice to look at the negative impact here. And then aripiprazole is a dopamine stabilizer in psychiatry, atypical antipsychotic. That is a partial agonist, which is supposed to be in schizophrenia level out the dopamine, so bring up the levels when it's low and bring down the levels when it's high. So we assume it also has dopamine agonist effects. Plus, we of course also meet a very vulnerable patient group here. The psychiatric comorbidity is really a huge factor here. Usually drives ICDs a lot. So it's been researched very little. It's actually one of the goals we have now in psychiatry, is to also start looking more into aripiprazole. But the case reports are quite clear that it's just that antipsychotic. They've often co-screened it with others. I think there's an FDA warning about it since maybe 10 years back. It's in the prescription. So it's, I think definitely much more research needed. We can, on that side, we can dream about what's been done in Parkinson's patients and dopamine agonists. So it would be nice to have it broader. But I think, in general, it's also a dopamine agonist in many ways. And, needs to be treated with that risk profile.
Any other questions? Otherwise, thank you very, very much.
Thank you.
And we move to next speaker, and we are very happy and proud to have Professor Irina Rektorova from the Czech Republic here. And you are going to talk about imaging, MRI imaging pearls for Parkinsonism. Most welcome.
Thank you very much, Per, and thank you for the invitation and the other organizers for the invitation to this meeting. So as it has been said, I will touch upon MRI imaging for Parkinsonism. I have nothing to disclose with regard to this talk, and I will try to talk about imaging in Parkinson's disease and in dementia with Lewy bodies, how MRI can help us in early diagnosis and stratification of subtypes, imaging symptoms correlates very briefly, just some examples, and imaging for atypical Parkinsonian disorders shortly in the end. So you've heard about biological classification or definition of Parkinson's disease or neuronal synucleinopathies, and where is imaging in this classification? It is probably to define and quantify neurodegeneration. So with respect to imaging for neurodegeneration on the whole, most of the studies have been done in nigrostriatal degeneration using SPECT, DET scan, or PET. It has high sensitivity, but it's not specific, as you know. Then it's cardiac denervation, as evaluated by MIBG scintigraphy of the heart. It has moderate to high sensitivity and specificity. And then probably very interesting and quite a hot topic, PD-related metabolic patterns, but they are not widely available to be used in individual subjects, although it may come in the future, maybe. So I will touch upon MRI in this regard, and not only in Parkinson's disease, but also in dementia with Lewy bodies, and especially pre-dementia stages like MCI with Lewy bodies, which is the most characterized prodromal subtype of DLB. Last year, we made a review with Hendrik Thijs, Nicola Pavese, and Thilo van Emeren, what would be the best imaging biomarkers in prodromal and earlier phases of Parkinson's disease, using various sequences like quantitative susceptibility mapping, dorsal nigral hyperintensity, by susceptibility weighted imaging, then neuromelanin sensitive imaging, and free water imaging. So I will briefly touch upon those. And here they actually examine macrostructure or microstructure of substantia nigra. The first one is susceptibility weighted imaging, which evaluates dorsal nigral hyperintensity. It is actually hyperintense ovoid region that resembles swallow tail or tail sign. This is why it is called swallow tail sign. So it is a hyperintense region on the dorsolateral part of the substantia nigra. And it quantifies or evaluates nigrosome 1. Unfortunately, this is not quantitative analysis, but rather qualitative imaging. So the answer from this is only yes or no. On the other hand, the changes means loss of the sign, which is typical for Parkinson's disease, but also in other Parkinsonian degenerative disorders and DLB as well, they are present early on already in 2/3 of isolated RBD patients. Dorsal nigral hyperintensity seems to have very variable sensitivity and specificity. According to some studies, extremely high. According to other studies and some reviews, the sensitivity and specificity was around 80 or less than 80%. It can separate Parkinson's disease from healthy controls, but not Parkinson's disease from other neurodegenerative Parkinsonism. This is a review done in dementia with Lewy bodies. It's a review and meta-analysis where 63 patients with DLB as compared to other groups were evaluated with 3T scans. And you can see that the overall sensitivity and specificity is again around 80%. So the authors actually summarize that iron-sensitive MRI, in this case, this swallowtail sign or loss of the swallowtail sign might comprise a supportive biomarker for the diagnosis in DLB. So the beauty of it is that you can assess it in every individual subject. But harmonization, even for the sequences using this method, needs to be done. Then, if you want to really quantify iron in the brain, there are other techniques available, and particularly quantitative susceptibility mapping, which is a multi-echo gradient sequence, and we have clinical pathological studies, so we know that it really depicts iron in the substantia nigra pars compacta. It's probably better than just R2 star relaxometry imaging, and it's again present already early, already in patients with isolated RBD. And according to some studies, it can also differentiate Parkinson's disease from other atypical Parkinsonism, like PSP or MSA with Parkinsonism, because there we can find iron deposition, meaning increased signal in various structures outside of substantia nigra, as you can see here on the slide. So this is to show that isolated RBD is somewhere in between healthy controls and Parkinson's disease with respect to the signal in substantia nigra, and it's the same with MCI with Lewy bodies. So you may see that RBD patients and MCI with Lewy bodies are somewhere in between healthy controls and probable dementia with Lewy bodies. And then what I found quite interesting is this study. It is a retrospective study of 27 subjects with both in vivo MRI and post-mortem data. And it's not only PD, but also patients with Alzheimer's disease and other atypical Parkinsonian disorders. And this study has shown that the correlates of susceptibility MRI identifying iron in the brain also relate to glial density and tau. So that's quite interesting to know. Now I will switch the gears to neuromelanin sensitive sequence, which is T1 FastPink echo sequence. And the beauty of it is that we can depict and evaluate not only substantia nigra, as you can see on the left side, but also the noradrenergic structure locus coeruleus that you can see on the right side. We know that dopaminergic and noradrenergic neurons contain pigment neuromelanin, and that neuromelanin is associated with dopamine and noradrenaline metabolism. And the source of the contrast is iron, which is paramagnetic. And therefore, in this sequence, actually, we look for decreased signal in substantia nigra and locus coeruleus. And when assessing it, we should also know that there are some dynamics of the neuromelanin changes in the brain with aging. So actually the highest level of neuromelanin are at the age of around 60, and then the neuromelanin decreases again. But in Parkinson's disease, which is depicted with red, for example, here, these changes come up already at the age of 55, and they the loss of the signal progresses much quicker than in age-matched healthy controls. And there are studies now showing that automated quantification can be used with quite nice area under curve and very nice sensitivity and specificity. And some studies, like the study from Stefan Leherisi group, shows that neuromelanin changes when you look into subparts of substantia nigra may differ between Parkinson's disease and atypical Parkinsonian like PSP. So normally you mostly look for sensory motor part, which is depicted in green, but you can also look at associate part of the substantia nigra, which is depicted in red. And if you concentrate and measure just this part, you will distinguish PSP from Parkinson's disease. And then the locus coeruleus that can be also measured by neuromelanin sensitive sequence. It seems to have quite nice sensitivity and specificity already in RBD patients when you look at single scans. So this visual analysis again had very nice sensitivity and specificity, and it was performed by neuroradiologists who were blind to the clinical diagnosis. And you can see that usually you can see decreased signal on the sequences. We measured, we quantified the signal in locus coeruleus, and we actually quantified it in caudal, intermediate, and rostral part, and we could see that it was especially caudal part of the locus coeruleus on the right-hand side, which distinguished MCI with Lewy bodies from healthy controls, and it correlated with some cognitive outcomes, especially visual memory. but it also correlated with the SCOPA score and sleep scale, which was not a surprise. Interestingly enough, we had plasma biomarkers of Alzheimer's disease copathology, because we know that it's very common in dementia with Lewy bodies and even in MCI with Lewy bodies. And we did not see any effect of plasma PETA-181, in other words, Alzheimer's disease copathology, on the correlation between the right locus coeruleus signal ratio and memory score. So it was not caused by Alzheimer's disease copathology. And finally, imaging substantia nigra microstructure using diffusion-weighted imaging, in this case free water imaging. I think all of you heard about it because it's a hot topic. It's by tensor diffusion model that depicts increased free water in the substantia nigra already in early Parkinson's disease, and specifically in those areas of the posterior substantia nigra that are depicted in orange and red. And it has been shown that these changes correlate with putaminal dopaminergic deficiency. Then there are some longitudinal studies available as well, and free water imaging can be assessed not only in substantia nigra, but for example also in cholinergic structures like nucleobasalis of Meinert or in thalamus, and especially thalamic diffusion-weighted imaging using free water imaging was a promising progression biomarker in early PD with identifying cognitive decline later on during the 3 years progression of the disease. And there are also automated imaging techniques like automatic imaging differentiation for Parkinsonism using 3 Tesla diffusion MRI, free water imaging, and support vector machine learning. And you may see the training and testing data sets that were quite high, including PD, PSP, and MSA. And free water was assessed not only in the putaminal structures and cerebellum, but also in white matter. And you can appreciate that the sensitivity and specificity for differentiating Parkinson's disease from MSA and PSP was very high using these automated methods. And some patients had post-mortem autopsy, and it has been shown that this machine learning technique even predicted post-mortem neuropathology in a high proportion of autopsy cases. And another longitudinal study of free water imaging, in this case in dementia with Lewy bodies. So you can see that free water imaging can be a very good marker that monitors the disease progression in specific regions implicated in visual spatial processing, but also motor functions. When we use MRI, we may also look into patterns of atrophy. There haven't been very many specific atrophy patterns described in PD, but this one is the one which works probably by Alan Duggar's group and Canadian authors, which uses deformation-based imaging. The result of it is actually deformation of especially subcortical structures as compared to healthy controls, which is evaluated by Z-scores, like in neuropsychological evaluation. So this works quite well, and you can see that there is a high correlation not only with motor features but also with non-motor features, particularly with RBD and with SCOPA out, but also with biomarkers and cognitive decline. And this is a famous study which classified patients based on cluster analysis from PPMI study in de novo PD patients and subtyped it to mild motor predominant, intermediate, and diffuse malignant subtypes based on not only motor symptoms but also REM sleep behavioral disorder presence, autonomic symptoms, and cognitive functions. And when using the deformation-based imaging, it could be seen that those who had high Z-scores of deformation were present in those who progressed progressed very quickly, and they were the malignant subtypes. With respect to MRI, T1 structural sequences, and prodromal DLB, first studies showed insular thinning, which was a good marker, but later studies showed that actually it's occipital atrophy in posterior cortical regions that is more sensitive than insular atrophy for differentiating probable DLB and healthy controls. And I also wanted to show you this. This is from EDLB cohort, result of this big study of more than 400 DLB patients using visual rating scales, but also using regional gray matter volume and cortical thickness. And you can see that the overall atrophy, but especially in the frontal gyrus, is much higher in males as compared to females. But then it progresses more quickly in females, while it is quite stable in males with dementia with Lewy bodies, converging, both sexes converge around 75 years of age. And with respect to clustering and subtyping, this study found 3 subtypes of dementia with Lewy bodies based on demographic and clinical features, but also based on Alzheimer's disease and cerebrovascular co-pathologies and cognitive decline over 3 years. And there is one cluster which is mostly cortical in blue. There are older subjects with higher load of white matter lesions and faster cognitive decline. Then there is a fronto-occipital subtype, which is intermediate, and subcortical predominant subtype, which is related or associated more with cognitive fluctuations. And I've already mentioned visualization nucleus basalis of Meinert using free water imaging, but we may also use structural MRI to assess basal forebrain cholinergic regions, and you may read many reviews and get to know that nucleus basalis of Meinert volume has been consistently reduced in cognitively impaired PD as compared to those who were not cognitively impaired, and also could serve as a biomarker and prognostic indicator for future cognitive decline. But not just the nucleus basalis of Meinert, but also integrity of white matter that projects from nucleus basalis of Meinert, this cholinergic white matter that is very much and strongly associated with cognition and attention scores, even more than assessing nucleus basalis Meinert. And this is another study actually showing similar results. And last but not least, I would like to briefly touch upon co-pathologies. So we know that in dementia with Lewy bodies, there is hippocampal preservation. This has very good sensitivity, but the specificity is quite low. Why so? Because in about 80% of all DLB subjects, there is already Alzheimer's disease co-pathology. And what has been shown that atrophy in mesotemporal structural regions is associated with memory loss in these subjects and also with tau pathological load, as in Alzheimer's disease. However, it has been shown that posterior hippocampus, depicted in white here, is spared in DLB as compared to Alzheimer's disease. So it seems that DLB modulates tau spread in mesotemporal structures, which I find quite interesting. And when talking about co-pathologies, other than Alzheimer's disease co-pathology, there is also vascular co-pathology, which is higher than in Alzheimer's disease, but lower than in vascular dementia. This is again the study by EDLB group. When talking about symptoms correlates and using MRI and fMRI, this is a study using voxel-based morphometry from our group. Actually, what we did was pentagon drawing on the tablet, and in blue is depicted drawing of the intersecting pentagons, and in red is the movement above the tablet. And Shannon entropy could evaluate it very well. And when using voxel-based morphometry, sorry, there is no pointer, so we could see that these changes were correlated with atrophy in the superior parietal lobule, and also this was correlated with attention Z-scores. Another example is in patients with Parkinson's disease who have hypokinetic dysarthria. We looked into articulatory network and could see using multimodal imaging that there are correlates with, for example, rhythmicity of speech. And it's especially auditory feedback area that has been related to articulation, and this is just an example of a study where we used RTMS, repetitive transcranial magnetic stimulation, to treat hypokinetic dysarthria in Parkinson's disease, and we were successful. That was 2 weeks treatment, and then we looked after 1 month at the results, I mean immediately after the stimulation, 1 month after and 2 months after, and you can see that the best results, behavioral results, were 1 month after the stimulation. And we could also see the correlates using fMRI during speech in areas that are connected with this auditory feedback area in the posterior temporal cortex. So it was seen higher fMRI activation in orofacial motor regions as well as in caudate nucleus, and the connectivity, resting state connectivity, was also increased with stimulation. So I'm just showing it to show you that MRI and fMRI in particular can be used to measure effects of any treatment. And this is another fMRI study that presented connectivity from dorsal striatum in patients with MCI with Lewy bodies, and it was increased to cholinergic structures in temporal lobes and correlated to various cognitive outcomes. And finally, I will only briefly touch upon MRI markers of PSP. I think you all know these markers like Hummingbird sign on sagittal slices or morning glory sign on axial slices, which depicts atrophy of the mesencephalon. This is very nice. These signs are highly specific, but unfortunately they are not sensitive enough, or they may be sensitive only later on during the disease progression and only in the Richardson type of PSP. So there are other ways how to measure changes in the brain, and one of them is planimetry, measuring so-called MR Parkinsonism index, and now MR Parkinsonism index 2, where you measure actually the plane of pons and mesencephalon and superior and middle cerebral peduncle. And now it is also multiplied by third ventricle width to frontal horns with ratio. And this is very sensitive and specific to differentiate Parkinson's disease from PSP, progressive supranuclear palsy. And when talking about MSA, we again have markers like looking at atrophy of pons, but also of putamen, cerebellum, and midcerebral peduncle, or other techniques like looking into putaminal diffusivity, which is increased, and decreased putaminal signal on susceptibility, weighted imaging. So these are all the markers that you probably know that again have quite nice specificity, but much less sensitivity. But nowadays, automated putaminal to infratemporal atrophy can be used with much higher sensitivity and specificity. So how to use imaging for diagnosis and differential diagnosis in clinical practice for MRI. When we have degenerative Parkinsonism, if it's clear, it's clear. If it's unclear, we may use dorsal Nigra hyperintensity MRI or neuromelanin sensitive MRI. That is what has been proposed by the Neuroimaging Study Group of the Movement Disorder Society. If it's clear, then it's probable Parkinson's disease. If there are some red flags, you may still do free water imaging or planimetry to differentiate other atypical Parkinsonism disorders, which are not Parkinson's disease or dementia with Lewy bodies. So, take-home message, what I'd like to show you now, that for differential diagnosis of PDN atypical Parkinsonian disorders, you may use MRI planimetry, but also automated volumetry and diffusion, especially free water imaging. With MRI, it is nowadays possible to assess cholinergic structures and even cholinergic white matter, noradrenergic structure like locus coeruleus, and of course dopaminergic cell loss in substantia nigra using relevant sequences that I showed you. And probably imaging brain microstructure of substantia nigra and other brain regions will be the way forward in near future. However, we need harmonization of all these techniques, and this is what neuroimaging study groups works on at the moment. But I think all these imaging techniques will be hopefully soon in clinical practice, which might partially or maybe totally, I don't know what to say, but replace PET and SPECT, at least for clinical practice. Thank you for your attention.
Thank you very much. Most impressive. Do we have questions, comments? Yes, Lars?
Thank you, Irina, for a wonderful talk. Just a stupid problem I'm always facing. We have many, many private MRI institutes giving patients wonderful, bright, colorful pictures, and then they're coming and saying, well, I never knew that I have Parkinson's disease, but a neuroradiologist told me. And so sometimes we're a little bit faced with some fancy factors that I've never seen before. On the other hand, it's really, maybe it's kind of the bored Mittelhessen-Marburg style of people, but I'm sometimes really, it's hard to get our neuroradiology to get on an everyday level these parameters on each and every patient in our university clinics. So what's your suggestion? What did you do kind of to establish this on a regular routine level?
Thank you very much. This is a very important question. Actually, we try to communicate with our radiologists to have specific sequences for Parkinson's disease, for epilepsy, for stroke. So they know what to do. So, for example, our radiologists in clinical practice do not use neuromelanin sensitive, unfortunately. We use it only for research. But doing susceptibility weighted imaging and look into dorsal Nigra hyperintensity, that swallowtail sign, is very easy to do. And it's helpful. I'm not saying it's 100% helpful, but it's helpful. So it's possible to do. So it depends on how you communicate and what sequences are totally necessary to be done in, let's say, Parkinson's disease and Parkinsonism. Yeah.
Right.
Hi, Irina, great talk. What is your view on the midbrain bonds ratio for the degenerative MSA, PSP type? Do you use that?
Yeah, we used to use that Quattrone software, and it works very well, I must say. But unfortunately, this software is not that well known. It's freely available, by the way, so it's possible to use it.
Angela?
Thank you for the great talk.
I don't know if this works.
I think it's on. Yeah.
Thank you for the great talk. I just wondering if you think there is a need for a better or improved correlation studies that anchor the changes that you see in the imaging with the like postmortem pathology. And I understand this is very, very difficult, but I was also thinking that this kind of exercise could be undertaken also with animal models. So we could use imaging and correlate to pathologies that we can very accurately determine. What do you think about this?
Yeah, I think it's a very important point. And we actually did and published some studies. I mean, my postdoc, who I'm not in animal research, but he is, and he did some studies in mice overexpressing alpha-synuclein and also in rotenone models of Parkinson's disease using diffusion kurtosis imaging, so diffusion-weighted imaging, let's say, the correlations were very high. He was even able to show how alpha-synuclein seeds into the brain in that rotenone model using that technique. So it's possible, yes. Mm-hmm. And more studies are needed, of course.
Any more questions? Otherwise, thank you very much. So Sarah Nicholas Mostyn is a very special person for us, and we are very proud and happy to have you in the audience with us today. Later you will also hear more from Sir Nicholas himself, but now we will hear a lecture with your name, Sir Nicholas Mostyn lecture, given by our very close and dear friend, Ray Chowdhury. And the title of the talk itself is Non-Motor Parkinson, the same old or anything new? Question mark. Please, Ray.
Thank you, Per. Thank you for asking me, and it's a great pleasure to have Sir Nicholas here as well. I put the question up as non-motor. We've been hearing a lot about non-motor, and I'm pretty sure you're quite bored with hearing about the same things over and over again. I thought I would like to see if there's something new, particularly as Sir Nicholas, any consultation with him challenges me extremely because he asks questions which I sometimes cannot answer, most of the times. So this talk will focus a little bit on it. I could tell you there's not a lot new, so that could end the talk now. And it'll be a hodgepodge of different things, but largely clinical and relevant to Sir Nicholas's journey with Parkinson's. So I think when I tried to look into this about non-motor Parkinson, is there anything new? I think I came to this. Firstly, is that we have now a different concept of Parkinson. It's no longer regarded as this old person, usually an old white person who's very stooped and stiff, so the very definition of bradykinesia, to something that's quite dynamic and mobile. And we know that because patients fluctuate from a movement state to off state, etc. But interestingly, there is also the bottom line of that blue heading is autonomic, psychiatric, and/or cognitive symptoms. So these are also non-motor. So in fact, the concept of non-motor is now very much ingrained in our perception of what is Parkinson's. And that really takes us to the whole point that we really need to focus a little bit on our patients and their carers. Because many of these non-motor symptoms, and you'll hear about this later, the iceberg, the hidden part of the iceberg, is actually best described by the patients and often their carers who are affected by these problems. Now, how does it then, what is there new about it? We heard beautiful talk on prodromal Parkinson from Annette Schrag, and I thought we'd just put up this review that we did not long back, earlier this year, where we sort of tried to redefine the actual, maybe make it clinical, the prodromal stage. Of course, you've heard all the markers and so on, but what does it mean in clinical practice? Apart from all the problems that it brings, we again talked about the ethical issues in that beautiful paper in neurology by Annette and her team. And we have therefore an at-risk period, a preclinical period with all these different biomarkers emerging. But what interests me is the prodromal period, because that's largely non-motor in nature. And again, you saw that analysis that if you put all of these together, all these different non-motor symptoms, you're going to get a higher indication of who's going to phenoconvert to Parkinson more quickly or in a more predictive manner, which is very important if you're running any neuroprotective trial, for instance. And one of the two of these things amongst the different panoply of non-motor symptoms, the ones that are of interest, are coming up of interest, is color vision and also urinary dysfunction and patterns of musculoskeletal pain. And I think we will have more research on this coming out, that specific types of color vision, particularly red, green color vision impairment, along with musculoskeletal pain issues focused around joints and also urinary dysfunction, the three together might form quite a powerful predictor of Parkinson in future. And if you look at the literature, some of the stuff will indicate that. And in fact, if you look at these other studies, and that study which she showed, you can also see very nicely how these things, these symptoms can predate Parkinson's for many years. So in a NET study, you can see depression, anxiety, insomnia, and fatigue were present in patients who developed Parkinson's even 10 years or 15 years before their diagnosis was made. And the same sort of pattern seems to be true for the issues around color vision in particular. And therefore, I think it'll be interesting if somebody takes this on and looks at it, because it'll be an interesting topic of research, apart from all these biomarkers and other areas. Staying on with the issue around epidemiology, and a very vexatious topic, I would say, about insecticides, pesticides, which has been very topical now. There's now an association with hyposmia, depression, major depression, and anxiety, and living near a golf course. And this raises alarm bells in many people, but I have to say these are golf courses in the US. And why is this important? Because golf courses in the US use some specific products to make the grass look greener, and they are very potent anti-dopamine agents. So these authors, and of course Ray Dorsey is part of it, who's really, that's his thing, from the Mayo Group, has suggested that if you live within 3 miles of such a course, you might have a significantly elevated risk of developing Parkinson, which is often manifested in a prodromal stage with hyposmia, along with also periods of depression. And this was discussed in a recent meeting that we had in Italy, where one of the authors was actually there. So whether or not this would be true for anybody living near a golf course where such sprays are not used, we don't know. But more worryingly, and this might be relevant to this evening, is this. There is some evidence emerging that French red wine consumes or uses a lot of pesticides, sprays, and there is at least one paper suggesting people who have large volumes of French red wine intake can have a higher incidence of Parkinson's. Is this true? That'll make our life really miserable, unless you go to non-French wine, which is also quite advocated. The Southern Hemisphere wines, South Africa, Australia, Chile, California, perfectly drinkable, but this is something to think. California is pretty good. Okay, sorry. California is slightly higher up. Agreed. Napa Valley I was talking about. Okay, so that's, I think, quite interesting. More areas of research. Hyposmia and the link with red wine, the link with golf course, perhaps something new. Now, another area, constipation. Now, Valentina Letta, who's in the audience, did this very nice study with Daniele and many others. You'll realize Dan Weintraub is involved. And she did this study, which I was terribly skeptical about when she suggested this to me. Why are you doing this? I said. But anyway, she wanted to analyze PPMI data, as everybody does. And we had two cohorts. We had the PPMI cohort and Nils cohort, which is our own non-motor longitudinal cohort. And she found, and Daniele and Valentina, that using a predictive modeling, that constipation, which is not functional, I mean drug-induced, is associated significantly in both models with cognitive impairment in untreated Parkinson. We know there are many models we've already seen which are predictors, but this was quite interesting and goes back to a much older study from the Hawaii epidemiology group, Ross, who first suggested that the frequency of bowel movements and the future risk of Parkinson's disease, for instance. So this seemed to support that, that study. And then subsequently, this year, there is a meta-analysis that's been published, which does confirm this observation. And therefore, it seems that if you look at all the different studies that is looked at Parkinson's and in idiopathic cohort, that constipation, which is unexplained, could be a strong predictor for not just the cognitive issues, but as you can see, what these authors said, that they can mark the cholinergic subtype, which Carolina mentioned earlier, and also the noradrenergic subtype. So again, this is very interesting, I think, because we need to find these symptoms which we can actually identify in clinical practice and then have some more granular research looking into all of that. So I think in that respect, this is, I think, quite an interesting shine a light into the predictive modeling for Parkinson's for future. There are other symptoms, but I chose this because I think this is of interest and seems to support from these independent data sets. There are some other interesting things about metabolic syndromes. Now, many of our wellness experts, and I know Indu is in the audience, and others are very focused on wellness. Now, wellness is defined by many things: mental wellness, physical wellness, social wellness, cultural wellness, etc. But metabolic wellness is very important. And we now know, and we've always known, that if you had diabetes or if you had other metabolic disorders, your Parkinson's syndrome might be behaving a bit differently. But in this community-based study, 467,000 patients, Zhang et al. Looked at those with metabolic syndromes, and that's why the non-motor comes in, because they have all these diabetic and other types of symptoms. And the risk goes up specifically for Parkinson's, particularly when you have some genetic contribution to that too. So you have gene, so maybe you're carrying a LRRK2 mutation, or you're carrying some other known Parkinson's mutation, and you have a metabolic syndrome, and the non-motor symptoms that are associated with it, your risk of Parkinson goes up substantially. The sort of implication is that if you can modify that with your lifestyle, and this is where exercise, sleep, water, etc., intake, etc., comes in, then you might be able to modify this as well. So it adds more weight to the whole lifestyle-based advice that we should all give to our patients, or follow it ourselves if we don't want to get Parkinson's, perhaps. So that, I think, was very interesting in terms of really further work that probably needs to be done in this sense. Now then, there is the renal function. Does it have a role with Parkinson's? And interestingly, while we know that there's a big gut-brain hypothesis, from alpha-synuclein in the gut propagating to the brain or other way around, there is now a recent paper in Nature Neuroscience looking at renal function in Parkinson and the propagation of misfolded alpha-synuclein from kidney to brain. So there seems to be another pathway. operating here. And this is very interesting because a separate study suggests that if you have a renal function is abnormal in your Parkinson, you've got other symptoms which are suggestive of kidney failure, the Parkinson's also can behave in a negative way. So, and PD incidence increased in patients with chronic renal failure. So in terms of looking at the holistic whole person picture, this might be another area that we might have to think about how the renal function, which we haven't really investigated in detail in Parkinson's so far, might be of relevance in terms of the pathophysiology. It's a very nice paper. You can look at the pathologic propagation, and they look at the phosphorylated alpha-synuclein deposition in terms of the propagation from the renal to the brain axis. In relation to this, we did a study with our Chinese colleagues and our Singaporean colleagues, and that looked at, and we published this year, and Caroline and myself were involved in this work with the group in Shanghai and in Singapore. And what we did was, I think it's, oh, this has gone the other way around, sorry. This is the wrong one. I corrected this. But anyway, never mind. I will explain this. So we had two cohorts, essentially. We had a discovery cohort, and we had a validation cohort. Well, they had. We didn't have it. But we were providing the insight into the study. And then we wanted to look at some simple blood tests that can look at prediction of Parkinson's. We know all of this stuff. We know CSF, we know brain, we know expensive imaging. But can we do something which is relatively easy for people to do in the blood? And we wanted to look at several different parameters, which has been associated, glycosylated hemoglobin, CRP, uric acid, etc. And also look at some inflammatory markers using a very sophisticated technique, which I can't remember exactly what they were using, and then using some very fancy modeling to look at the prediction of certain motor and non-motor symptoms, which is why I put this up, particularly hallucination, psychosis, and dementia. And what emerged from this large study in two different cohorts independently, that plasma fibronectin, which is a marker of inflammation, and it has very strong correlation with inflammation in the body, appears to be in both these cohorts an independent marker for these disabilities. So I think we might, and this is fairly easy to measure, so it might be worth to think in future whether fibronectin could be a marker for cognitive impairment and or hallucination even, or psychosis in Parkinson's based on it. We are now trying to start a more prospective study on it. So I thought I'd put that up. And you can see the data in the Kaplan-Meier curves in both the discovery cohort and the validation cohort, that there is a separation out of the normal versus where you hit those disability milestones quicker. So that's we're doing more that dealt with the prodromal and the biomarker sort of thing. We heard a lot of other talks on it. Another area, I think, which is of great importance is early onset Parkinson. Now, an old paper, this one from Uday Methane's paper, he's from Bangalore. He said, this is an old movement disorders paper, saying that early onset Parkinson's, juvenile, young onset, are they different? But he pointed out that in many emerging countries which will bear the brunt of Parkinson's in the next 20 to 30 years, and that is Africa, Asia, and parts of the Latin America and Middle East, will have a large number of young onset patients. Young onset patients meaning those with Parkinson's below the age of 50, or cutoff being 50 to 55, let's say. It's estimated, where the Western population estimates are about 10 to 15% young onset. In these countries, particularly in India, this is a recent paper from Pramod Pal, which is in the middle, they estimate the numbers might be 40%. So imagine the societal impact of that. Now, why is this relevant to non-motor? And this is a, again, recent review that we published this year with Christian and Carolina led on this. looking at the early onset Parkinson's patient and their non-motor profile. Early onset Parkinson's patients have some very specific non-motor profile, and we must be aware of it because they need different personalized, focused management strategy, and one size doesn't fit all. And what are these? So it's a difficult slide to probably look at, but you can see this. In early onset Parkinson, they have a different pain perception. They often or might have the DRD2 polymorphism, which actually makes pain perception different. In other words, the pain perception might be increased. They might have more central pain syndromes. In early onset Parkinson patients, they have high rates of anxiety, high rates of suicide, depression, stigma. So I know Anna and others are working on stigma. If you really want to look at stigma, you should focus on early onset Parkinson's patients, particularly in certain different ethnic groups. Because in many countries, like in Africa and Middle East even, or in the Indian subcontinent, people often do not talk about Parkinson's because they are stigmatized. They're not given jobs. They're taught to have a curse and so on. And that is very relevant to early onset because at that stage you should be working and fit and active. So psychosocial mental health issues, sexual issues, as well as, interestingly, as you can see, we talked a lot about impulse control disorder. These patients also have high rates of ICD. They have high rates of dopamine dysregulation syndromes. And dysautonomia and RBD is also relatively common in this group if you're carrying the GBA1 mutation. So you can see the non-motor profiling of early onset Parkinson. I would suggest if you see early onset Parkinson, you non-motor profile them straight away because that's going to be quite different to the late onset Parkinson. So I think that is quite an important thing. If you have access to genetics, it's also interesting because genes in this particular group can actually mark certain susceptibility to excessive daytime sleepiness, but perhaps more importantly, susceptibility to cognitive decline and also impulse control disorder. In terms of cognitive decline, and we heard about this earlier, it seems that the glucocerebrosidase mutation might carry a higher risk, as does, of course, ApoE, whereas LRRK2, as we heard again, might be sort of protective. Now, we don't really know the relative answer to that. I know there's a large review on LRRK2 published recently, but another interesting thing emerges that if you carry the MAPT mutation, you get the posterior MCI, which is the one with the intersecting pentagon problem, the lexical fluency problem that you saw in the stepped care paradigm. Whereas if you carry the COMT polymorphism, which is quite common, you might get a benign frontal MCI. So again, we might want to look at this, and this is relevant in the early onsets. If you want to look at the more genetic paradigm of this group, it might be worth looking at these sort of genetic markers in this particular subset, apart from looking at their special non-motor profile. Now let's go to the assessment of non-motor symptoms. Now this goes back, the history lane, this is going back to 2000, when we formed this group, the non-motor group, and there's some pictures from that time. A very young-looking Christian Fallu Pecurario there in Royal Society of Medicine, in one of our first meetings, along with many others. Per and Pablo, of course, were the founder members. And one of the things we did, in spite of very stiff opposition from established societies, to develop the non-motor questionnaire. We were said, why do you need this? It's not that relevant, etc., by many bodies. We nevertheless went ahead, and pharma supported us. Otherwise, we wouldn't have had the money to do this. And we developed the non-motor symptoms questionnaire, which was essentially the first tool and remains the only tool till now for empowering patients. Some of you will be familiar with this. This is a 2006 paper. And the questionnaire has 30 items. Very simple, yes, no, yes, no. It takes about 5 to 10 minutes to complete. Now been translated to over 30 languages. And it has those domains. those different domain, gastrointestinal, urinary, sexual dysfunction, etc., etc. Where are we with that now? Well, I'm very happy to say that the Movement Disorder Society took this on and commissioned us, which is Annette Schrag, myself, Dan Weintraub, and Pablo, to develop an MDS-endorsed non-motor symptoms questionnaire based on the original non-motor symptom questionnaire, which has just been published in Movement Disorders. The paper is out now. Dan led on it. Data was collected from our center, Annette Schrag Center, and Weintraub Center. The difference between the original to the MDS-NMSQ is in the different domains. We've added orthostatic hypotension domain. We have added a sleep and being awake domain. We've added a pain domain, etc. So it's become a bit more bigger. It's still quite well. The validation data looks very good. You should give this a try. Now, MDS will now circulate a linguistic validation program. Anybody wants to validate in your own language, you can do so, but you have to go through MDS because they own the license for that. And this, therefore, covers 13 domains, 52 symptoms, takes an average 10 minutes, and you can it's validated for remote administration. So you can actually do it on phone if you need. So it's actually quite a useful thing, although I still think non-motor symptoms questionnaire is still equally valid, and many people will continue to use it. In relation to the NMSQ, the most recent validation, and this is, this is the scale. So the MDS, NMS, and the MDS, NMSQ are now partners. So you can use, if you don't have time, you can get the patient to complete the MDS, NMSQ. If you have time, you can use the MDS, NMS. This obviously takes more time to do. This is the Polish validation with Professor Slavek and Karolina and others. They've just recently published it. Nice to see that this data fits with the general data of non-motor symptoms questionnaire that we have. You can see the burden of non-motor symptoms. This is very telling, because a lot of people still say, well, it's mild disease, it doesn't matter. Well, it does matter. You look at mild Parkinson, you've got a burden of non-motor symptom, which is not dissimilar to severe. And that just brings that non-motor symptoms are not time-dependent. They can happen at any stage, and of course we know prodromal stage is really full of non-motor issues. So, and the patients, as you can see, the endorsement using the 7-point questionnaire, the patient responses were almost 100%. So it's a fairly easy paper to look at. Here we're using a Polish cohort, obviously with the study being in Poland. Okay, so that's the assessment. Let's talk a little bit about subtypes, because anything new there? Per Borghammer is in the news. So this is the New Scientist paper, which came out a few months back. I was quite surprised because I look at it. I was quite drawn by this diagram. And it says, Per Borghammer's aha moment came nearly 20 years ago, it said. The neuroscientist, and then it goes story of how he developed the body first and brain first hypothesis. I would like to argue that the body first, brain first hypothesis actually is derived from Anna Saabier's original paper, where they describe the 7 subtypes of Parkinson's. If you look at that paper, you'll see that she describes the body first very clearly and the brain first. So there's the Park cognitive group and the Park non-cognitive group, which is the body first group. So it's a coalescing of those ideas, but more defining it more. So if we agree to that, and you again heard about that from Annette Schrag's talk, is there anything new there? Well, this is a review again with E.K. and Lewis that we did. And we tried to look at subtypes in approaches and clinical definitions for implications. Here you have some interesting issue. If you have a Parkinson with tremor-dominant condition, so tremor is the main problem, there appears to be an association with hyposmia. And we will put it to the test by asking Sir Nicholas about it, because Sir Nicholas presented with a lot of tremor initially. Whereas if you have the more PIGD type tremor dominant, akinesia dominant syndrome. You get a whole different sort of profiling of Parkinson's, mainly with depression, apathy, sexual problems, and the cognitive issues. And then you can divide them up into cholinergic, serotonergic, noradrenergic, etc. The serum uric acid, I think, needs to be looked at more. Could be a marker in the tremor dominant, in the hyposmic group. It's a very easy test to do, and it's a lot simpler than some of the sophisticated markers that we've talked about. So it's an interesting area that we can look at. And if we look at the non-motor spectrum, we've already talked about this earlier, that essentially they break down into three. Of course, there's an overlap. Everything in Parkinson overlaps. But cholinergic, noradrenergic, and serotonergic appear to be going in three discrete areas. They're very recognizable in the early stage of Parkinson's. What we do not know is that then if you institute subtype-specific therapies so early on in the condition, what happens to these patients in the long run? We don't know that. We don't know this natural history, and studies like that needs to be done, and we are actually doing that as we speak, trying to redefine these syndromes in clinical practice and following them up. But it's worth remembering that and trying to classify that as much as possible. I will just delve on this a little bit more, because here comes the general advice that is true for all of these patients. We call it the vitals prescribed. And in fact, this was developed with Nicholas, with the wellness work that Indu has been leading on. And what are they? You heard about this already, but I'll just go over that very quickly. They are 150 minutes of bespoke physical exercise. It doesn't actually have to be that you have to wear gym gear and go to the gym and pump iron. No, it means any form of physical exercise which is culturally appropriate and which you can do. But you have to remember that you must treat the apathy before you prescribe exercise. Because if a patient is apathetic, and you say, go and do exercise, they're not going to do exercise. So it's very, very important to address that when you're asking about physical exercise. There is growing evidence on 2 liters of water. You'll hear about Simproof and probiotic from Valentina. And what I would like to focus on in the last part of the talk is a little bit on sleep, which is a crucial factor for wellness in Parkinson because of its glymphatic activation. So we have done now, just published this sleep medicine clinic where we had a large number of colleagues who submitted some fantastic papers. We actually managed to get 14 papers within a 7 months period, which was quite amazing. And in that, there are several chapters, and one of them focuses on excessive daytime sleepiness. I'd like to stay with that a bit because it's really very important and we don't seem to spend too much attention on it, and this is perhaps something that's new. Of course, there are many genetic markers for, as you can see, GBA mutation has excessive daytime sleepiness propensity. MAPT, increased excessive daytime sleepiness, etc., etc. So mainly those two genes. So is it that you find excessive daytime sleepiness? Can you do some genetic analysis on these patients? But why is that important? Because if you look at the non-motor subtypes, and this is again work sort of led by Valentina and Anna, you can look now differentially the cholinergic, noradrenergic, and the serotonergic subtype. When you look at the excessive daytime sleepiness angle, you're really looking at the serotonergic aspect, and that's been shown in imaging studies with DAS-B as well as other imaging studies. Why is this important? Well, you've already heard about the problems of falling asleep while driving, and we wanted to look at it, and we're now doing a prospective study about several centers that we have together, how many patients might have dozed off while driving, if they are driving, or there is some evidence about patients also swimming alone and having this problem while swimming and drowning. And this paper is now currently in press, that we found that up to 40% of patients surveyed on this particular survey, and you can see there were many centers involved around Europe and Middle East. About 40% were never asked about the risk of driving, even though your Epworth score was very high, which might be due to also sleep apnea in some cases. So I think it's a really important point to keep. There's doing the Epworth score, particularly younger onset patient or anybody who's driving, is really crucially important. And I think we'll have more data on this as time goes by. The excessive daytime sleepiness, can we do anything else about these patients? Well, this review from Christian shows that essentially there are a lot of lifestyle type issues that you have to take in EDS. However, there are two drugs that are now currently being looked at, pitolisant and solriamfetol. Solriamfetol has already been used, and there's some further studies that are carrying on to see whether these two drugs, along with possibly higher active and a modified control release formation of modafinil, might be effective in this group of patients. Anything else? Well, of course, lifestyle. And this is work, again, led by Indu. You can see that there is a whole range of non-pharmacological interventions. They can all help. But amongst them, I think perhaps the most promising, and it's actually, there is a session on this in the MDS Congress coming up, is light therapy. Using different luxes, blue light therapy, bright light therapy, etc. Along with, there is also growing evidence of diet and exercise. And I think all of these aspects needs to be looked at in future. But I think that's really exciting that we're bringing in the lifestyle along with pharmacological treatment. There are also growing emergence of using cannabinoid for sleep. And we might even discuss that in our interview with Nicholas Mostyn later on. Another area which I think will become very prominent is the glymphatics. Glymphatics are a crucial part of sleep. When I tell patients that you must have 6 hours of sleep, I say it's a prescription. It's not a choice. You must try it. Some patients can't because of various different reasons. However, 6 hours, it doesn't have to be one go. You can do it if you have a little nap in the afternoon, etc. It's all fine. That will then look at perivascular. You can look at perivascular space with imaging. You can look at the LPS index. Whether or not this becomes quite normal management in Parkinson's, particularly with sleep dysfunction, would be interesting to see. But there's some work coming out on this and the role of the glymphatic system and lack of sleep in Parkinson's. Staying with neuroimaging, there are some further developments in relation to the different subtypes. You can image, and I'm not an imaging guy, but this is nicely reviewed, so I put this up. You can image the cholinergic system. So if you're skeptical and say, what is he talking about cholinergic? What is this? It's cognitive. No, you can actually look at the cholinergic system and show cholinergic preferential dysfunction by PMP PET, or more recently FeO-BV PET or donepezil PET. Similarly, you can look at the neuromelanin we heard about from Irina, but also there are noradrenergic PET ligands available if you want to hone down on your noradrenergic subtype. Similarly, DASB, which is shown there, is one of the keys of the serotonergic dysfunction. But these are quite restrictive. They're only available in tertiary centers or research centers. Its general availability still remains to be seen. But there are these issues, and perhaps there'll be development, and there'll be a lot of work that's being done there now. Finally, is the issue around also other Parkinsonian syndrome, and taken from the same volumes, very nice review from Professor Slavek, showing the patterns of different sleep disorder also vary between the different Parkinsonian syndromes. We've just picked up DLB here, for instance. DLB patients have RBD, hypersomnia, insomnia, as well as RLS. But standing out are the cognitive fluctuations and nocturia. So cognitive fluctuation is also very interesting, and one of the questions that was asked this morning was a differentiation between cholinergic and dopaminergic apathy, where cognitive fluctuation is largely related to the dopaminergic dysfunction, because that's why they're fluctuating on and off with the motor fluctuation status. And that's quite common here, and staying with fluctuation, there is also the autonomic fluctuation. This is another review that just brought out in JPD, from Eero and Carolina and others, the autonomic fluctuation and the sensory fluctuation. One of the key symptoms of autonomic fluctuation is hyperhidrosis, excessive sweating. Patients suddenly are drenched in sweat. Whenever that's happening in patients, it's worth thinking about non-motor fluctuation, particularly if that is related to levodopa dosing. And very recently I had a patient who exactly had that anxiety and sweating attacks linked to the declining level of dopamine, essentially. So these are very important points to recognize in clinical practice, and same with pain, because you can overcome these by good quality continuous dopaminergic stimulation or longer-acting dopaminergic drugs. So they're actually treatable. And how can they be treatable? Well, this table tells you retigatin patch can be effective, safinamide can be effective, opicapone can be particularly effective, and I'll show that in the talk later. Subcutaneous apomorphine infusion is absolutely fantastic for treating fluctuation, non-motor fluctuation. Shame that nobody's actually done a specific trial on that. We have data on levodopa infusion. Per showed the duodenal gel. Its efficacy on the non-motor function is largely driven through its effect on the non-motor fluctuation. And then we have, of course, also phospholevodopa and lesigon. So these should all, in theory, be able to tackle this huge problem for our patients. They have a huge impact on our patients, these fluctuations. And here's a further list of those. I won't go into the details of that. I think I would show you some videos, actually. There's one there. Here's a lady with, you can even see from that, she has this terrible dystonic off, left side, but severe pain, hyperhidrosis, and complete mental disintegration, really. She just doesn't want to live. And that's her, along with the tremor. And she's young, and you can see the pain in that. And you can see her post-apomorphine complete disappearance of these symptoms. So you see the powerful effect of a dopaminergic drug on these non-motor symptoms. Here, they're being driven by non-motor fluctuation. And similarly, I'll show you another patient. Here is a patient who has, and this relates to some of the question that was asked previously. This guy was started on phospholevodopa. He developed psychosis, paranoid delusions, but we drastically cut his night dose down, 70%. It all resolved. And here you see him in that level. And he had severe apathy. Again, he didn't want to live. So if I heard so much about this pump, I came to have this done. I'm feeling like this. What's the point? There's nothing else. But when we do that, you can see him slightly dyskinetic, but he seems very, very well, and the psychosis resolved. So again, just the pointer is, our modern perception of non-motor symptoms is that you can actually handle these fluctuations quite well by focused, targeted therapy. Staying on with that, Per already mentioned, there is also evidence emerging from this. You saw from Professor Slavik's paper that nocturia is such a big problem for many patients. What do we do about it? You know, you were saying, are you improving your sleep? But if you're getting about 5 times at night, your sleep is not going to be that good. But there seems to be growing data, and we've done this post hoc analysis from the double-blind placebo-controlled study and the open-label trial, showing a clear effect on phospholevodopa and phoscarbidopa on urinary function. I think you'll get the same effect with lesigon once that's looked at, because it's essentially cutting out the urinary non-motor fluctuations. And staying on with that, there is also this very nice paper on GBA variants and the use of the EPIC study, the use of levodopa-carbidopa intestinal gel. And this is very interesting because this study is signposting those who carry the GBA1 mutation to saying that actually in these patients, levodopa-carbidopa intestinal gel or even levodopa-carbidopa and entacapone intestinal gel might be a good option because they seem to do better because in relation to their some of the non-motor symptoms, particularly ICD, depression, anxiety, hallucination, and psychosis. So this is really quite an interesting point that now that even genetic refining of your cohort might be a better targeting the advanced therapies in a certain way. Not just that, very quickly, OASIS study, I'll talk about that later. This is just out from Joaquim Ferreira, showing that opicapone, used judiciously, has a beneficial effect on sleep in Parkinson's. This is particularly takes out the disturbed sleep domain of the PDSS2. And it is true really for all other forms of infusion therapy. But interestingly, in these two reviews, we show another something interesting which you may or may not be aware of, is the noise factor. It is now becoming clear that the levodopa-carbidopa entacapone gel pump, the noise is, you can see that if you look at the noise recording test versus the CAD legacy pump, which we use in duodopa, is very substantially different. As a result, there appears to be a much greater potential for that sleep benefit because the noise has an effect on patients' sleep. This has not been looked at that much. Okay, very quickly, further data that levodopa-carbidopa intestinal gel also has an effect on nocturia, as you can see there, sleep refreshment, and finally, sleep onset and maintenance. So I will not go into the next. Okay, there's one more. This is about emerging infusion therapies. What are the ones that, I think the point I was trying to make here is the new non-motor symptoms are also emerging as side effects of these therapies. We've already talked about psychosis, but you can see that hypotension, punding, and DDS have all been reported, and we need to be aware of that. I will skip over this. So I think this is my last slide. If you want to hear more about this, next year we are launching the Knight and the Professor series with Sir Nicholas and myself. And I think I'm always guided by patient's voice. So I think it would be a good chance for us to discuss, and we'll invite various people to come and talk to us about many of the issues that I've touched upon. And I think that was a summary of the non-motor advances in my view. Thank you again, and I'm grateful to many people here. Thank you very much. Sorry, it's rambled a little bit there.
Thank you very much. A wonderful overview. One comment?
Franziska Richter from Germany. So you talked a lot about using the non-motor symptoms like to predict, right? And you talked about the treatment. For me, it's also very interesting to consider them as part of the causation. So if you have constipation and alteration of the microbiome and the gut-brain axis is actually happening, you could also increase progression of synucleinopathy. We see this in the animal models. Same for sleep, right? Sleep disturbance if it's early, if you don't sleep well. Mm-hmm. So if that's the case, if actually a lot of those symptoms contribute also or spur the synucleinopathy, would you expect to see less progression of disease with your beautifully improved treatment options now you have for non-motor symptoms?
Yeah, it's a very interesting question. I think we need to do a proper, controlled longitudinal study. You're absolutely right. We're so focused on molecules and neuroprotection, which in my view, they've failed 39 times now. But we're still carrying on. It's much more important, I think, to look at a holistic angle and then look at its effect on progression in Parkinson's. We're seeing that more and more. Perhaps physical exercise has the most robust data on it in animal model and in humans. So I think you're right. We need a combined approach where we put in Simprove, physical exercise, sleep, along with perhaps some useful medications, even metformin, perhaps, and then look at the progression data in these patients. Yes, it would be interesting to look at.
Regarding the exercise, so actually we have a paper coming out showing that if you do too much exercise in a model of synucleinopathy, you get an increase of stress in the animal, which increases mucogliosis in the hippocampus. So just as a little warning too, right, because we always promote this, I think it should not be stressful. So you said that you should treat first apathy and, the patient should be motivated. It should be a positive experience.
I agree. I actually tend to prefer the use physical activity. So I don't actually use the term exercise because people then go completely wild and exercise like hell. That doesn't help because you're burning out the dopamine reserve. So you need to have that threshold, which varies from person to person. So physical activity, and you're absolutely spot on there. And also the point I made was the management of apathy. You cannot prescribe physical activity to somebody who's apathetic. So, all of these issues, but we're learning, I think, from that angle.
Many thanks, Ray.
Thank you.
Great.
Thank you very much. And now we'll have the first industry symposium, and it will be Per Odin who will speak about LASIK therapy and recent results. And this is the Britannia Symposium.
Dear colleagues, back to the pumps. And this time we will focus on LASIK, levodopa entacapone carbidopa intestinal gel, which, as you know, came on the market in the first country, Sweden, where it was also developed in 2019, and is now spread in more than 20 countries in Europe and is still spreading. First, some disclosures. So what we will do, we will have a look at the ELEGANCE study, which is the latest and the largest study with this treatment. Look at the rationale, the aims, the objectives, and the study design. We will then talk a little bit about the effects of both LCIG and LASIK on non-motor symptoms, on sleep, and on quality of life. We will have some results from the ELEGANCE interim analysis, which was published, like you might have seen, in March this year. And also have a look at the effect of LASIK on sleep, an ongoing study that we are performing in Lund, Uppsala, and PEX, and some implications in the end. So when LASIK came on the market in 2019, there was not much published information about the treatment, really, but that has changed a lot during the last years. We have got pharmacokinetic studies. We have got a large number of national and single center real-world studies. And now we get the ELEGANCE study, which is then a bit similar to the GLORIA study, a big registry study on efficiency and safety of LASIK in patients with advanced Parkinson's disease. So it is a large-scale, multi-country, multi-center, open-label phase 4 study. So a phase 4 observational study documenting real-world information on long-term efficiency and safety of LASIK from a large cohort of advanced PD patients who are prescribed this treatment in routine clinics. And apart from the normal efficiency and safety measurements, there will also be patient-reported outcomes, and including also satisfaction with the pump infusion system. So primary objectives are the long-term efficiency, of course, reduction of off-time, improvement of good on-time, safety profile, and then non-motor symptoms, quality of life, healthcare utilization, patient satisfaction, and a global impression of improvement from both the clinics and the patient. It is the study itself consists of, as you see here, 5 visits over 2 years. So we have a baseline visit and then about every half year a new visit. And we follow then the daily dosing of Lasig and our concomitant therapy, NAR stage, motor symptoms, non-motor symptoms, quality of life, sleep, assessment of improvement or worsenings from clinician and patient satisfaction with the pump and healthcare utilization apart from adverse effects. So the interim analysis is now published, and what we see here is then the reduction of off time, which is sort of what we would expect with our experience of pump treatments. Here it is 3.5-hour reduction of off time to a 3 to 6 month follow-up, and 3.45 hours reduction of off time compared to baseline after 6 to 12 months. So a very significant reduction, and only about 1.7 hour remaining off time as a mean. There was actually not all patients coming from peroral treatment in this study. Most of them came from peroral treatment, but some also came from other pump treatments. So there was a small group of patients who went over from another pump therapy. And actually, as you see here, they also got an improvement of off time. It has to be analyzed, of course, why on a more individual basis. So how is it with effect on non-motor symptoms? Well, we have looked on pump effects on non-motor symptoms in my last talk, and we just take an example here, the Gloria study, where we remember that we had this very nice and stable effect on non-motor symptoms, total score over the first 2 years of treatment with LCIG. And here we also see the subscore developments, where we have a very nice effect on sleep, but also on mood cognition domain and gastrointestinal domain, and on the mixed symptom domain. And also from the EuroInf2 study, we have learned that this type of broad effects on many non-motor symptoms happen both with DBS, with LCIG, and with apomorphine pump treatment, with improvements of both the non-motor scale total score, but also many subscores. And the scores that seem to repeatedly react very well are sleep and mood. And this contributes to an improvement of health-related quality of life to a similar degree with all these treatments. And now we have with this Lesi Park study from Spain, we have also information on non-motor effects of Lesigon. So this is a multi-center longitudinal retrospective observational study in 73 patients from 21 Spanish centers. They had 14 years of disease and half a year of Lesigon treatment. And 2/3 came from peroral treatment and 1/3 from other pump treatments. And there was a baseline investigation and 2 follow-up time points. And you see to the right here, you see the effects. So effects concerning non-motor symptoms. There were effects seen with impulse control behavior, with depression, with anxiety, with sleep, and constipation, and also pain. So relatively similar to our earlier experiences with non-motor symptoms effect of pump treatments, maybe even a bit broader than most studies. A special focus, as we have said, with the pump treatments and DBS has been the effect on sleep. This is the DUO Globe study that we have looked on earlier. And we remember that we had over 3 years here a very nice and stable effect on sleep improvement, and even increasing effects on daytime sleepiness from LCIG treatment according to the PDSS-2 and the ESS scales. And here we see then correlations between these effects on sleep with NMSS and PDSS2 and ESS and quality of life. Again, underlining that these effects on sleep and on daytime sleepiness are probably important factors in the improvement of quality of life for the patients who receive pump treatments. So what do we learn from elegance in this respect? These are the components that are caught and registered in the elegance study. And if we look on sleep in elegance, we will see that there is a very good effect on sleep also with Lesigone, showing positive impacts on many aspects related to sleep dysfunction in the patient. So we have a PDSS2 score where the total score is improved highly significantly, both to 3 to 6 and to 6 to 12 month follow-up. And this concerns also the subscores for motor symptoms at night, PD symptoms at night, and disturbed sleep. And we see the same thing here, so it's an improvement with 7 points, both to 3 to 6 month and 6 to 12 month follow-up. And if we think about that, 3.44 is the limit for clinically important improvement. We realize that these are really clinically important improvements for the patients, the degree of sleep improvement here. And this is then a radar plot where one has taken clinically meaningful sleep subdomains from the PDSS2 score to see what improves really in sleep. And as you see, it is at both follow-up time points a broad improvement of many components in sleep. The overall quality of sleep is improved, the sleep onset and maintenance insomnia is improved, the nocturnal restlessness is improved, the nocturnal psychosis improved, nocturia improved, nocturnal motor symptoms improved, sleep refreshment improved, and daytime dosing improved. So many things seem to normalize when moving to Lesigone pump treatment concerning the sleep. Further in this study, one can see that there is also an improvement of health-related quality of life as measured with PDQ-8, which comes already at the first follow-up and remains stable at the second follow-up. An improvement with 13 points of the PDQ-8 summary index. And then, as we saw earlier, also the non-motor symptom scale improves with Lesigone treatment. We have an improvement here of 18 points to the first follow-up and 21 points to the second follow-up of the NMSS total score. And if we look on which components in the NMSS total score that improve, we see here that it concerns sleep fatigue, mood, cognition, attention, memory, gastrointestinal function, urinary function, and mixed symptoms. So a broad effect on many components of the non-motor scale. So what we are now doing is to look a bit closer on the sleep effect. This is a collaboration between Lund University, Uppsala University, and PEX University. So we are using polysomnography, and we are monitoring sleep in patients before they go into pump therapy with Lesigone, when they have established 16 hours therapy and when they have established 24-hour therapy, because we think that this comparison between 16 and 24 hours therapies has not really been done so far with any of the pump treatments. And so the primary objective is to look at the polysomnography, but we also use PKG to look at the sleep, and we also use, of course, scales for sleep quality and daytime sleepiness to see what happens. So far, only single patients data available, unfortunately, but we start to see tendencies in effect with improvement of non-motor scale total score as expected, improvement of ESS, daytime sleepiness, and improvement of deep sleep time. And at least concerning the deep sleep time, there seems to be a further improvement when we move from 16-hour treatment to 24-hour treatment, as which would fit, I think, with the clinical experience of many of us. There is a strange raise in the PDQ-8, as you see in one patient, but that was not related to the treatment. So what can we say? Well, we can say again that this is a further contribution to the data indicating that non-motor symptoms can really improve significantly with infusion therapies, that this improvement often correlates well with health-related quality of life and contributes to a better quality of life. And that it mainly seems to be effect on sleep fatigue, mood, and gastrointestinal symptoms of these treatments, even if the effect here seems to be even a bit broader, also on attention, memory, and urological domains. So again, we can say that probably non-motor symptoms, and especially sleep, can be seen as a co-indication for starting pump therapy for lesigon and for other pump-based Parkinson therapies. And thereby, thank you very much for your attention. Any questions or comments?
Adding entacapone to the levodopa, carbidopa, it means also the less or reduction of the possible neuropathy. Did you observe the also this symptom in the study using some, not only scales but objective outcome measures? It's
there is, to my knowledge, only a single, as in the elegant study, you mean? I think there is only a single report on neuropathy among these patients. So it can apparently happen, but the hypothesis is that the risk is lower because we give less amounts of L-DOPA because, as you say, we add entacapone. But it's probably too early to say to say that we have proven that the risk is lower. But hopefully, in the end, we should get some indication of that. Otherwise, as you all know, the big difference with the lesigon treatment compared to the duodopa treatment is mainly the infusion system with a smaller and lighter pump. If no further comments, I think we can move to the break. And yes. Ulrika knows everything about that.
Having a break, yeah. Just a little reminder before we take the break that everyone who is chairing or speaking in the session right after the break, please make sure that you come back here a little bit before we start, 3:30, to get your headsets arranged. Thank you.
And probably we should try to meet at past.
Yes. Okay, let's have a seat, everybody. Time for our second industry symposium. It will be Ray Chowdhury who is talking for our sponsor Bial. What's the role of COMT inhibitors in improving PD-related sleep disorders? So, stage is yours.
Thank you, Eureka. So this is a session sponsored by Bial, and I was asked to really talk on the role of COMT inhibition and sleep, and it follows on from Per's talk with Lesijon, although I will not. I'll focus on opicapone, which is the more modern oral COMT inhibitor that we have in clinical practice. So these are... Is it moving? Oh, sorry. Yeah, these are my disclosures. There's no specific conflict with what I'm going to be talking about. I'll come to the first general overview of sleep. You've heard a lot about sleep today, but there's a very nice review led by Christian that came out last year, sorry, not last time. And it basically summarizes the different sleep issues that you might get in Parkinson, from insomnia to daytime sleepiness to nocturnal lack of sleep refreshment, sleep apnea, and daytime sleepiness. And these are, I've got a couple of videos there that you can probably look at. This is a classic example of what happens is this gentleman who's there in a sleep lab with his wife, and he's got a mixture of RBD and periodic limb movements going, and also, shouting, nightmares, all of this stuff is coming in. So that's an aspect of sleep disorder. And then you also have this. This is a classic periodic limb movement of sleep, which is exacerbated if you ask the patient to rest. And you can see those. And these are treatable problems. But along with that, you can add sleep apnea. You can add the drug-induced sleep disorders. So it's a range of sleep problems that you can get. So when you're talking about sleep improvement, we need to really define it down. What do we actually mean by that? Now, how does sleep disorders impact on quality of life? This is a very nice study, very old study, but very famous study, the Priamo study from Italy, which was put together by Paolo Barone and Angela Antonini and others, 1,772 patients across 55 centers in Italy. And you can see that if you look at that diagram, which gives you Honenia stages 1 2, 3, and 4, that the sleep problems, 47.9% at stage 1, which is the earliest stage of Parkinson motor stage you will have, rising to 81% at stage 4. So not only is it present at the onset when we have people presenting to us, but also as time goes by, the prevalence and the types of sleep problems increase exponentially. And there was another very interesting question that was asked this morning by Angela about dopamine and non-motor symptoms. Now, the reason why I bring this in, because we'll talk about a dopaminergic drug, but do we have specific non-motor problems where we think dopamine might be actually an underpinning neurotransmitter? We do. Impaired color vision is partly driven by dopamine. Hallucinations, clearly dopaminergic to some extent. Pain, particularly the off-related pain. Similarly, anxiety and depression. And also, sleep disturbances have a dopaminergic basis. So you could very rationally think about managing sleep problems with dopaminergic replacement therapy, but aspects of sleep problems, not all types of sleep problems. And this is again complicated further by the whole spectrum of fluctuations. And here there are two papers, a very recent paper which I've already alluded to, which we put together with Alexander Stoic and others, with Iro and Carolina and other colleagues, and the more older paper where we've sort of drilled down into the fluctuations, and you can see that these can be very, very complicated. So even levodopa therapy itself can give rise to behavioral fluctuations, which can be related to psychosis, can be related to dysregulation syndrome, can be related to punding, metacognitions, which means you turn yourself off by the fear of being off, as well as providing sleep problems. So if that is linked to levodopa fluctuations, if you can soothe out the levodopa fluctuations, you should be able to help these fluctuations. And this has been the more modern aspect of it, is the 3 different types of non-motor fluctuations, the cognitive one, the autonomic one, the sensory one. And amongst that, it's really the autonomic and the sensory ones that impact on sleep. So if your drug is working on these fluctuations, you could argue that it'll help with the sleep problems of Parkinson. And this takes us back to a very nice study, probably the first study that looked at non-motor fluctuation in a systematic manner. And this was driven by Alexander Stoic, and we all collaborated with it. And you can see here, and beautifully, how the symptoms in on and off vary. And you can see in purple are symptoms in on, and in blue are symptoms in off. And this was also corroborated by video documentation at home. And you see that symptoms such as anxiety, depression, fatigue, all of it sort of gets worse when the patient's off. Happiness is reversed. In other words, when you're on, your happiness score is actually higher, which is sort of understandable. And you can argue that many of these symptoms which are aggravated in off, if you have a successful therapy that attacks the off, then they will be better. Now, this is where COMT inhibition comes in. COMT inhibition, as you already heard from Per, has an action in the periphery and in the central part. We normally give levodopa with carbidopa or benzarazide. We inhibit the decarboxylase, which will improve your dopamine delivery. And the COMT in the periphery will block the formation of 3-oxymethyl-dopa, which competes with dopa to get into or is an inactive metabolite. So if you reduce your 3-OMD, you're actually improving your dopa delivery. So conceptually, I don't understand why we don't use COMT inhibition anyway, because we are blocking the other one. Why not this one? But that's another question. In the brain, you have the MAO-B working on it, which is the formation of DOPAC metabolite. And the other side, the COMT is actually 3-MT with a methyl tyrosine. So that also has a negative effect on dopamine metabolism. So from the physiological metabolic side of things, COMT inhibition seems to be quite a reasonable, physiological and rational thing to use. And that's what we're doing with the MAO-B inhibitors, with the COMT inhibitors and the decarboxylase inhibitors. So does it mean then, by using this, by reducing the 3-OMD, by reducing 3-MT, increasing dopamine levels, can you help these non-motor problems of fluctuation? Let's look at some historical data. Tolcapone used to be a very nice drug, probably one of the best COMT inhibitors before it got pulled for hepatic dysfunction. But at that stage, there were some studies, and this study shows after the non-motor scale was developed, they used the NMS scale, and as you know, it has 9 domains. And what it showed in this 4-week open-label 100 milligrams 3 times a day tolcapone study, that it improved 3 specific domains of sleep, 3 specific domains of the non-motor scale. One is sleep and cognition, second is mood, and third is miscellaneous, pain and sweating. These are the 3 things it came out from that study. These are related to fluctuations, these particular symptoms. Okay. How about another COMT inhibitor, which is entacapone? So entacapone, for instance, also has benefits on sleep. In that paper review that I showed you from Christian's work, one of the things you see is how sleep improves with various enzyme inhibitors. And this is again shown here. If you look at this study, which was a 3-month study, given entacapone at night time, I still use it in some patients, you have some very specific sleep improvements. And it would be very interesting to see if this is replicated with Lesijon. For instance, overall sleep quality, sleep onset insomnia, sleep maintenance insomnia, distressing dreams, nocturia, and sleep refreshment are the specific things that stand out in this particular study just by adding entacapone to your levodopa. Okay, so there is another. So we had tolcapone effect, we had entacapone effect. And then let's look at opicapone. If you look at the different drugs that have been suggested for managing non-motor fluctuation in this review, opicapone features in that. This is based on 2 large studies, the BIPARC-1 and BIPARC-2 studies, and the OptiParc sub-analysis, which I will come to in a minute, and try to convince you that this is a good drug for addressing some, but not all, part of sleep problems in Parkinson. So let's look at the BIPARC-2 trial. So this was a phase 3 study, 1 year, open label, which was published in a fair while back, actually, in 2015. They used the non-motor scale, and again, you see the same signal. The same signal you saw with tolcapone, the same signal you saw with entacapone comes out here in an independent sample. What are the same simples? You see the significant improvement in domain 2, which is sleep, domain 3, which is mood and cognition, mood mainly, and domain 9, which is sleep and hyperhidrosis. All fluctuation-related symptoms are showing very pronounced symptoms, and this was in a large number of patients. So it's confirmatory of those previous studies on COMT inhibition and sleep. If we look at the OptiParc study, which is a phase 4, 3 months open-label study, again, you see something very similar. Firstly, if you look at the mean score of non-motor score, NMSS, that goes down, highly significant change of 6.8. Remember, about 3.8 would be a reasonably good, is the cutoff change. But if you drill down to it a bit more granularly, again, you see involvement in those 3 domains: sleep, mood, and pain and hyperhidrosis. So now 4 different studies, all coalescing towards the same observation. How about radar chart? So this is the open PD study, which is another phase 4 trial, 6 months open label data. Same data is replicated. The non-motor score scale is reduced by about 28%, highly significant value. And if you do the radar plot, you pick up specific effect on urinary symptoms. We know urinary urgency is a symptom of off-period. Sleep and mood, again, similar to the other ones, and miscellaneous, which is the pain and the hyperhidrosis. So the same picture is emerging from all these different trials in different patient groups. Now, the other things, if we now summarize this, therefore, what do we see? We see that, therefore, the BIPARC-2 data I've just shown you, OptiPark study, open-label tolcapone. There's the entacapone study. And you heard from Per's talk that intestinal infusion, both now with levodopa, carbidopa gel, as in DuoGlobe study, or the levodopa carbidopa entacapone gel, which is the elegant study, both show an improvement on sleep. Is there any comparative data on sleep efficacy between entacapone and opicapone? Because in some countries, you may not have opicapone. So can you get by using entacapone? The answer is, even though one study showed in 3 months that there might be some benefits with entacapone, it may not be true to the level that opicapone helps. Now, this is some work that we did. This is Valentina led on this study, which we published in 21, where we looked at a convenience sample, patients who were on entacapone versus opicapone, and we looked at just a naturalistic follow-up data, and 18 patients were on entacapone, 17 were on opicapone, and we looked at some finite endpoints, especially the non-motor symptom scale, given the data that we had. What did we find? And remember, this is a real-life cohort. This is what you see in real life in your clinics, so we're not making any other adjustments to them. But the interesting thing here is, you see in your graph to your left, is that the entacapone group, which is in red, their non-motor score during this follow-up period gets worse, whereas the opicapone group remains stable, in spite of all the peripheral adjustments, which were adjusted to reduce the variance as much as possible. If you look at the PDSS, the Parkinson's Disease Sleep Scale, you have a reverse thing, because in PDSS, if your score goes down, means you're worse. And the usual cutoff is about 85 to 90 in the PDSS, the old PDSS. So here we see exactly that. The entacapone group gets worse in red. The opicapone group shows a trend towards improvement, but remains certainly stable. And if you look at the stability differences, that is actually significant. So what's this telling us? That yes, even entacapone might be a good option, but somehow opicapone seems to be a better option in this open label study, which has many limitations. We understand it, but the signal is there. Now, we have some further update on this. This is the OP sleep study, which was then conducted again with Valentina, and it's currently, the data is in preparation. This was a one-year study where we looked at a convenience sample, again, 20 patients initiated on opicapone, and we looked at 3 parameters at V1, 4 months, V2, 8 months, and V3, 12 months. We see a very similar replication of data. If you pick out the small 4 months data, that's shown at the top, you see that there is again, a similar data on the NMSS. Sleep and fatigue domain goes down significantly. Improvement on PDSS, but interestingly, Epworth sleepiness score doesn't get worse, so the patients do not have excessive sleepiness. And if you look at the 12 months data, which is shown in the table, it's very recent analysis, so we haven't done the full analysis. You can see UPDRS3, non-motor scale, PDQ, quality of life, PDSS, and Epworth, all of them remain stable with opicapone over a 1-year period. Very similar data to the one that I showed you before. And some example that you get is, for instance, you see this patient. The video is of not very good quality, but look at his foot. And this is pre-opicapone. You see those quite disturbing, painful dorsiflexion of the foot going, which is sort of spectrum of the periodic limb movements of sleep spectrum. These sort of things completely stop when you give opicapone. So if your sleep dysfunction is linked to these motor problems at night and fluctuations, opicapone clearly sorts that out. But if your sleep problem is related to nightmares, or it's related to perhaps sleep architecture issues, it'll be more difficult to try and address this. So that becomes the sort of take-home message from this in a way. Now, the other thing about COMT inhibition is that it is very racially diverse. So COMT inhibition, COMT enzyme exists in different alleles, high activity, low activity, the RS4703 polymorphism is a faster deacetylator. So if you give levodopa to these patients, they'll break it down faster. And that has racial variations. So above everything, opicapone is one drug or COMT inhibition that you need to really show, if you want it to be used globally, that it works on all different races. And we have done some work on it because this is a real issue. We have written on it how the ethnicity gap needs to be plugged, because often when we did this first paper, which is to your right, we found that there was a real lack of having ethnic data in many drugs that's been licensed, making its validity in the non-white population or non-Caucasian population rather doubtful. So do we have any data for opicapone in different races, and particularly on sleep? Yes, we do. So this is work led by Vinod from our Dubai group, where we looked at a 12 months real-life study and look at the Emirati population. And probably at the moment, the only study there is in this large group, apart from a study in the Japanese population. You see here we have the baseline data, the 6 months data, and 1 year data. And you have this very robust improvement on the non-motor symptom scale, total, going down the value from 107, changing, and the MDS-UPDRS also going down quite substantially, showing this highly significant changes. And that's concurrent with these changes in the PDSS, the Parkinson's disease sleep scale. So it seems to be working also in this racial group. So it's a good endorsement of its use in different population bases, if you would, because otherwise you could argue, well, my COMT activity is not that good, so will this drug work on me? It does work on it. Lastly, I want to just highlight for you the OASIS trial. This has recently been published. It was led by Joaquim Ferreira with Claudia Trenkwalder and others. This is an exploratory trial looking at all of this data, synthesizing it all together and putting it all together. Exploratory, open-label, multi-center study. So while it's open-label, the strength, it's multi-center. And this is the protocol. You can see that there's a screening. There's a 6 weeks of open-label, 50 milligram opicapone. This is very focused, unlike our real-life study. And then there's a safety follow-up period. Main endpoints were looked at is the PDSS-2, which is aimed for sleep changes in clinical trials. In that situation, you should really be using PDSS-2, along with various other surrogate secondary measures. So let's just go through the main scores. Yes, PDSS-2 score again shows a significant improvement. You can see the baseline score of 26.9 dropping to 19.2. So it met the primary endpoint. And that change was 7, almost 8 points, where you know that the clinically meaningful change is about 3.4. So it surpassed the cutoff quite substantially. Now, where did these changes come from? The PDSS-2 allows us to divide the Parkinson's sleep problems into 3 different groups: disturbed sleep, motor problems at night, and PD symptoms at night, which are more architectural issues. Surprisingly, although we were wanting to look at we were expecting a priori that there will be a motor problem at night would be the main effect. The main effect actually was noted on disturbed sleep, which overlaps, of course, with the motor problems at night. What leads to disturbed sleep in Parkinson's, according to PDSS-2? And that is shown here. So you see a significant improvement in difficulty in falling asleep, which is sleep onset insomnia. You have improvement in difficulty staying asleep, sleep maintenance insomnia, getting up at night to pass urine, another signal, nocturia is improving, and tired and sleepy after waking up, which is sleep refreshment, so it's improving that as well. So those are the 4 parameters that the opicapone seems to be working in this very focused, specific study. And as you can see, the greater than 30% improvement in sleep initiation, quality, restorative sleep, maintenance. And there comes another point, tremor on waking. Now, you'll hear from many patients, and I've been particularly impressed by the effect of opicapone on tremor. And you'll probably we will probably discuss that in Nicholas's interview, because Nicholas Mustin, who came to me, had a very bad tremor initially, and once we started using the opicapone, that virtually disappeared. And you can hear that directly from Nicholas, and we have actually PKG measurements of it. And it seems that the tremorolytic effect of opicapone has a beneficial effect through the night, as it's shown there and is picked up by the scale, and turning or moving at night. So sleep akinesia also improved, although they're not that dominant in terms of the whole domain-based analysis. But those things improved, and if this was a larger study in a larger number of patients, I think that will become significant. So the OASIS, if we look at the NMS score, and there the MDS NMS was used, the new version of the non-motor scale. Again, you see improvement from baseline to the 6 weeks analysis in the sleep and wakefulness domain of the MDS NMS and the total score. So it's not just the PDSS-2, it is reflected in the sleep and wakefulness domain of the non-motor scale, the MDS NMS as well. So I think that was, again, further proof that you have this greater than 30% improvement also in the NMSS items, particularly insomnia and unintentional daytime sleep episodes. So very interesting, therefore, is that by adding opicapone, you're also possibly reducing this narcoleptic type phenomenon that occurs, and this clearly needs further studies in future. So conclusion would be that this summary of studies, almost like a portfolio of studies from the whole COMT inhibition family, but now drilling down to opicapone, shows that we have real challenges of sleep at Parkinson's, significant nighttime and daytime issues. You saw that in my first slide. There are many issues such as restless leg, nocturnal akinesia, early morning off in particular, sleep maintenance, insomnia, as well as motor dysfunction through the night. And adding opicapone seems to be a reasonably simple strategy to try and prolong the levodopa effect and see if these fluctuations that are occurring and the symptoms that are occurring at night are fluctuation related, and if so, are they help. So I use this now as a routine for patients with sleep dysfunction, and if it doesn't work, then you can look into other causes of sleep dysfunction in these patients. So I thank you very much.
For a very interesting talk and very impressive data on the effect of COMT inhibition on sleep. But I'm a bit confused about what the mechanisms are, because you mentioned prolonging levodopa effect into the night, but if with opicapone, which is a very good COMT inhibitor, it's the best, I would say, and irreversible, you still just double the half-time of levodopa. So are there other explanations?
Yeah. I think we need some more detailed architectural studies, which we don't really have at the moment with COMT, because we know that the COMT has its own effect on sleep and interruption. The overactivity might lead to sleep architectural problems. So whether that's also assisting the motor effects at night is difficult, because we picked up, if you look at the OASIS study, it actually helps with sleep onset insomnia. The sleep onset insomnia is not directly related to dopaminergic function, so that might be specifically COMT driven, but I do not know exactly what might be underlying that.
I mean, it's a peripheral inhibitor after all, and you could argue that it has something to do with 3-MT, perhaps.
Possible.
But the other option is to say that, okay, this is just a reflection of improving in fluctuations during the day.
Yeah, I think that's reasonable, very reasonable to conclude. But it seems to be pretty consistent effect. I think that's the interesting thing. So further studies are really welcome, yeah.
If there are no more questions, then I think we say thank you very much for your talk. And let me introduce the chair of session number 3 today. It's Keimars Ashkan, Professor of Neurosurgery at King's College in London.
Thank you
Welcome.
very much. It's a great pleasure to be here and to be able to chair this session. As a neurosurgeon, I always feel very privileged to be invited to a neurology meeting, so it's great to be here, absolutely. So I do a lot of deep brain stimulation, and therefore particularly look forward to the first talk of this session. It's a double act by Professor Lars Timmerman and my very good friend Haydar Afzari about non-motor hats of deep brain stimulation. So Lars, you're going first, I believe. Thank you.
Yeah. So, thank you very much for the invitation and the opportunity of talking about deep brain stimulation. I feel very pleased to be here in Sweden. 1/8 of myself, I don't know which part it is Swedish, but this part feels so much home that many people talk in Swedish to me. Thanks again for the great invitation and the great organization. And I feel particularly proud a little bit also to talk today, not alone, but to have Haydar Afzari on my side. And we both try to manage. And it's like singing on a conference or singing on a family event where you have not kind of probed so many times. So probably a very similar thing today. So our topic today is the non-motor hat of deep brain stimulation. So we'll start off. This is the next button. And so this is my disclaimer. I served as president of German Neurology, which means the strongest and hardest codex, I think, within this galaxy, so no relationship with any industry. And how about you, Haydar?
These are my disclosures. I think none of them interfere with the topic of our talk today. And I just want to take the opportunity to thank you, Per and Ulrika, for hosting us and also for, together with Ray, for organizing this. It's a particular pleasure for me also to work with my old boss and now close friend, Lars. So, yeah, wonderful. Let's go, right?
Yeah. And we have talked so much about pumps and medications and COMT inhibitors. Now it's time to something real, electricity and surgeons. So let's talk about deep brain stimulation. And I brought you a patient from us from Marburg. And this guy is owning a pharmacy, or to be honest, he owned 3 pharmacies. And he has Parkinson's disease with severe fluctuations. And he was more or less in 2 different statues. Either on the left side, and you see his motor function was very bad, but he was sweating like hell. Like when I was running in this morning, you said, is it raining? So, he was sweating, he was very bad in anxiety. Oh, he was like this. And he was very spendable, good mood, being in the carnival committee. So a little bit on the hyper session. And Daniel, if you could click a little bit further on. And we thought this back and forth is not really good. We operated together with our great neurosurgical team from Christopher Nimsky. We dosed down the medication and he was much better. No gambling anymore, no hypersexuality. He needed much less medication and was in much better mood and was even financially better. So, a huge impact on motor symptoms and non-motor symptoms. And this was something that our German group, led by Günter Dorschel, and I had the pleasure and honor of participating, that we could show that obviously there's a huge impact that is more than simply continuing with this medication. And this was our first paper where we continued in a randomized fashion, either with the medication as it was before or with neurostimulation. And we looked at the PDQ-39 and we found that not only mobility but also activities of daily living, but also some non-motor aspects like emotional well-being, stigma, bodily discomfort, they were simply better. And we were asked by our patients, and in particular the young patients, why do you operate now? Since my wife is gone, my job is gone, my friends are gone, you should have come earlier. Very similar discussion that we have had this morning. And what we did was then the early STIM trial, and I was also proud to participate with my group at that time at Cologne. And what we did is that we said, well, when the first complications occurred after year number 4, we looked what is going on if we either really make it a true best medical treatment over the time of 2 years, or when we make neurostimulation, what is happening with the PDQ-39 with quality of life. And what you see is really a very tremendous difference. We could improve, even though they were quite good. They had some fluctuations, maybe some wearing off, but not so much. And what we found in these patients was that many items that were motor-driven, like mobility and activities of daily living, were much improved, shown here in the bars going up with neurostimulation. And with medical therapy, we could keep them stable over 2 years, which is something, we discussed this before this morning, but it's certainly not everything we want. However, those were old stimulators. And now we have new stimulators that allow tuning of devices by different sub-areas. And I was very lucky of getting kind of into contact with these very early on. And so one of the first patients was really something where we learned a lot. What the difference is compared to old stimulators is that you can change in different areas the amount of current you give and thereby target certain sub-areas. So this was a usual gentleman with akinesia and with some tremor. And so we started for the akinesia with the middle contacts, and this was getting better, and he felt better. And then he developed some tremor, and we thought we have to get some fiber bundles that are going a little bit higher. So we introduced another contact, and the tremor was also getting better. And then he was, from the motor side, very good. But his wife was saying, well, he's so apathic. He's not interested anymore in anything, not even in me. And I said, well, why not stimulating a little bit on the lower sides, within the limbic loops of the subthalamic nucleus? So I put something like 1.5 milliamps on the lowest contact. So next morning she came in and said, now he's too interested. So I was pushing him down a little bit and said, well, the great thing is we can target different sub-areas. However, it means that we have to understand what we are doing there and in which areas we are. And this is where we are going now with digital deep brain stimulation. And this is now what we are trying. We are trying to go into different sub-areas and to fiddle around to find a perfect solution for this individual patient. However, everything was looking on UPDRS, on motor. And this was something, I think, Ray, this was in Kiel, when we met on our both way out to the taxi, and we always missed the taxi because Ray told me, oh, we have this fantastic new scales about non-motor. And I said, nobody has ever looked at this in DBS. And everybody says, well, motor, motor, motor. So we said, we need somebody really industrious, somebody who can go through valleys, who is very cool in this. And suddenly, Heda came up. A little bit younger than now. So we asked Heda to look into this, and we came up, Heda, with a couple of core research questions. We wanted to know, is there a change with respect to STN-DBS, either by direct stimulation, or by reduced medication, or by changed behavioral patterns? Can we predict maybe the outcome of DBS? Or could we use the DBS with current steering to fiddle around and to get a target on different non-motor symptoms? And maybe do we change our patient selection as we've seen before for pump therapies when we consider these aspects?
Now we switch. And so this was basically the conceptualization, and Lars and Ray also were involved in the organization of this work, which I will present to you now. An update on our work of the Parkinson's disease non-motor group DBS research line. We're doing, since I think 2014-15, we're doing an ongoing prospective controlled observational study with a 5-year follow-up of patients. And the main lines of research, as Lars just pointed out, is to look at the clinical efficacy on non-motor symptoms, and also to look at prediction analyses and also stratification of outcomes, which I will show you in a minute. Over the years, these centers were involved in some shape or form in our research, and we have currently enrolled 490 patients, but our aim is to continue with this, because the more patients we have in our study, the more specific you can do some phenotyping and look at specific biomarkers also. And we started with this publication, which basically was a proof of concept. We showed that we could improve non-motor symptoms with STN-DBS in this case, and this was a rather small cohort at the time. We had 35 patients at the time, and we looked at the non-motor symptom scale. So this is total non-motor symptoms. One may argue, okay, so that's a bit, unspecific. What's the mechanism with which you modulate things? But on the other hand, if you have an improvement of motor symptoms, this is also tremor, bradykinesia, axial symptoms. This is also not very specific, and I think that's the charm of looking at it this way, because you can show a global effect. So we continued this line of research. I would like to give you updates on two specific questions that we are working on now. You've seen this slide in the earlier talks today. And as we know, brain first and body first PD, this concept also includes that patients, they have a different motor presentation. So the body first PD is considered to have a more symmetric onset of symptom and presentation of symptoms, motor symptoms, while the brain first PD is more asymmetric in the motor symptoms. And we were interested in this issue, and we looked at the symmetry index. So Pablo Martinez-Martin, unfortunately he is missing today, but he developed very early a way of classifying patients as symmetric PD, which is basically the hemibody score of the left and right body side. If the ratio is 1, then we consider these patients to be symmetric. And we looked at the scopomotor activities of daily living. And I think this is also somewhat non-motor, because obviously there is a cognitive domain to ADL. And the secondary outcomes in this study were motor examination and quality of life measured with the PDQ, and medication requirements objectified with the LEDD. And we included 254 patients, 200 of which were asymmetric in their presentation and 54 were symmetric. And this is actually quite representative as a cohort. This is well in line with the established literature on symmetry and asymmetry in patients. And this is the main outcome. So in the upper row, you see the asymmetric patients. In the lower row, you see the symmetric patient. And in red, I've highlighted the activities of daily living, so our main outcome. And you can see that, you can see here that while ADL improves in the asymmetric group, it is almost unchanged, maybe even worsens in the symmetric PD group. And there is an overall trend. If you look at this, I mean, almost all aspects of motor symptoms improve in the asymmetric group, while this is only the case for the bradykinesia in the symmetric group. And the interesting thing is, I mean, dyskinesia and motor fluctuations improve in both groups. This is the primary indication, the traditional indication for DBS. So there is still a good reason to do it in patients with symmetric PD, but I think we would have to preoperatively make good recommendations of what we can actually improve with this treatment. This is another way to show you the same results. You see in the radar charts the changes from baseline to follow-up, and you see the idea of the slide is to show you with one glance that in the symmetric PD group, the effect sizes are quite small, so the relative changes are quite small, while in the asymmetric group, we see a nice effect. And the between group difference is significant for activities of daily living. And again, we also see an improvement of quality of life in both groups. So we can, offer this treatment also to patients with symmetric PD, but we have to keep in mind what can actually improve and what may actually not improve. Just to briefly show you this, we also looked at the motor laterality and looked at whether patients are left side dominant with their symptoms or right side dominant with their symptoms. In the upper row, you see the left side dominant, and you see a nice effect on many of the domains of the non-motor symptom scale. For example, autonomic symptoms, they improve in left-sided PD. And in right-sided PD, for example, urinary symptoms improve only in right-sided PD. And what I would also like to stress here on this slide is that sleep and fatigue and mood and apathy have a rather large effect size in right-sided PD. So just to keep this in mind when patients come into your clinic and you think, okay, what can be achieved with DBS? I'd like to continue with another topic. We looked at white matter lesions and outcomes of DBS, and we specifically looked at axial symptoms. And I just want to show you the workflow in this analysis. So we did the MRI scans with patients, and we had a subcohort of patients who also underwent deep brain stimulation. In the MRI, we did two things. First, we looked at the images. Two neuroradiologists assessed these images, and they assessed the age-related white matter changes scale. The advantage of this scale is that it looks at white matter lesions in 5 different regions of the brain. So it's not like the Fashagas scale, which has a global score for white matter lesions, but it's more region-specific. And then we did a semi-automated automated analysis where we segmented the lesions and we looked at the overlap with white matter bundles in the EVE atlas, so in neuroanatomic atlas. And in our analysis, we first look at linear mixed models. We try to predict the outcomes of axial symptoms and also the severity. And then we dichotomized patients in the DBS arm in those who had an improvement of axial symptoms and those who had a worsened outcome of axial symptoms. And also, I will show you in a minute, we also looked at cumulative distribution curves to do a stratification analysis. So these are our findings from the visual ratings by the neuroradiologists. When looking at cross-sectional data, we found that the more white matter lesions there were in the frontal, parieto-occipital, and basal ganglia regions, the worse the axial symptoms were. And in the longitudinal ST and DBS cohort, the greater the scores were in the age-related white matter changes scale for the parieto-occipital region, the poorer the outcome was of axial symptoms after ST and DBS. And we were also interested in the networks underlying this effect. So we did the segmentation analysis, and this is what we found. So in the volumetric analysis, greater white matter lesions volume in the left posterior thalamic radiation, which is basically the optic tract of the left side, predicted poorer postoperative axial outcomes. And I think the beta value is quite remarkable. And then we said, okay, let's take it one step further, because this tract carries information from the metathalamus, from the lateral geniculate to the occipital cortex, and it goes more or less in one direction only, this information. And when we did the dichotomization, looking at patients with worsened and those who have non-worsened axial outcomes after DBS, we found that the lesions in cortical regions in these two, angular gyrus and middle occipital gyrus, they differed. So patients who had more white matter lesions in these two gyruses, they had a poorer axial outcome. And then we said, okay, we now have established an underlying network, but does that really help you in clinical service, right? So you want something which you can use, which has a utility. And therefore, we went back again to the age-related white matter changes, assessments, and we categorized in patients with mild, moderate, and severe scores in that scale. And this is a cumulative distribution function. Just to briefly explain what you're seeing here, on the x-axis you have the changes, and negative number means there is an improvement. And on the y-axis you have the cumulative percentage. So you can see every one of these patients. These are 90 patients you're seeing. They're stratified in one of the groups. And the vertical black line, this is a clinically important change of axial symptoms after surgery. And you can see that while in the mild parieto-occipital white matter lesions group, more than 60% had a clinically important improvement, this number was far less in the severe parieto-occipital white matter lesions group. So this is a difference of more than 20% for the absolute risk of non-response in axial outcomes. And I think this is a significant number. Moving on, we did a lot of research on predictors of outcomes. We also, of non-motor outcomes, we also looked at the impulsive and compulsive behavior outcomes. This is work by Anna Sauerbier. And we found that, first of all, there was a large heterogeneity between inter-individually in our cohort what the outcome was. But one of the main things was here that in 16 patients, we had an improvement of the ICD as measured with the QIP rating scale, and 15 patients, almost 30%, had a worsening. So we asked which factors can actually preoperatively determine whether patients improve or they worsen, and these were the parameters which are important. So if they have more agonists, if the QIPS is moderate, and if they have attention memory deficit, these patients are less likely to have an improvement. They have a worse outcome of the ICD. And also we looked at predictors of global non-motor symptom outcomes. And here we found that each additional year of age had a 5% lower likelihood of quality of life improvement. And each additional point in the preoperative quality of life impairment had a 5% higher likelihood of improvement. And substantially better chances of quality of life improvement were seen when preoperative pleasure experience was present and when the concentration was reduced. And now I think I'll hand over to Lars with results from Marburg.
Yeah, I think we're going back to the networks, because at the end of the day, when we improve life by reducing symptoms by a stimulation in a system, as Heda pointed out, we seem to modulate in a beneficial way cortical or whatever subcortical cortical network. And it's sometimes very difficult when you have somebody in a scanner who has already electrodes. It's very difficult with fMRI. And fMRI is just a flushing of blood, but not metabolic activity. So therefore, my group investigated something quite new, and they told me it's very few places in the world make it. They combined normal PET activity, glucose PET activity, with what we know normally from fMRI by giving continuous infusion of marked glucose so that you have a time domain in scanning with a high resolution, very fast PET scanner. So they call it functional PET. And this is something that allows you not only to have metabolic activity, but also to look at the fluctuation and define the strength of networks of metabolic active areas. So this is what we did with a couple of patients undergoing it. This is the work of Marina Ruppert, and it's very fresh. It's just from our Science Day. And those are the first 8 patients. And what they did was that they scanned these patients, and that we were interested in one topic that was very particularly interested, and there was a topic of the last talk, which was sleep, because we wanted to know which network do we influence. And what they found was a very broad network that might be or that you get when you take the volume of tissue activated, where we later switch on and turn on our electrode. And when we take this as a seed and ask preoperatively which network is active at this point, we get a positive correlation if we have a strong network of motor and non-motor areas preoperatively in the spot where we later stimulate, then we get a higher reduction in these few patients in the PDSS. So with other words, we can define the networks that we have to influence to get good clinical results. Another aspect that Irina mentioned was maybe we can use modern MRI technologies to analyze the structure of the tissue where we stimulate. And this was something that Philipp Löhrer from our group, a close collaborator with Heda, was doing by using something new. It's called NODI. This is Neurite Orientation, Dispersion and Density Imaging. And I was explained, or they explained me, this is kind of the integrative, it's a form of analyzing how good are your nuclei and your neural kind of construction there. And what they found that an intact microstructure within specific areas like the insula cortex, the right putamen and the right cingulum is associated with an overall non-motor symptom burden and specific non-motor symptom domain reduction. So when we have this intact, it's very good to go into stimulation with these. But can we address these specific areas? And this is again something that came out of this collaboration, and I hand over to Hedda again.
Yeah, this is earlier work from 2019 by Jan-Niklas Petri-Schmelzer and Lars and also Philip. And this is the workflow. We did constructions of where the lead is actually located, and then we looked at the outcome of non-motor symptoms. And it was a fairly large cohort of patients, 60 patients approximately, and we found this. So in the colorful structure here, this is the STN. In red, you have the motor part. In yellow, the limbic part. And in blue, in the background, this is the associative part. And the green dots, these are the areas in which a stimulation has a good effect on these symptoms, the non-motor symptoms, total score, and also on specific domains of non-motor symptoms. And what we found was that more ventral stimulation improves these non-motor symptoms. We observed a different picture for medication requirements, which is basically a surrogate of motor outcomes. Here, a stimulation close to or inside the motor SCN was beneficial. So we have another hints that there is a network effect on non-motor symptoms. And now I'm heading over again.
And can we use this in everyday clinical work? Yes, we can. So this was a postman, and he had a nice STN-DBS effect, but he also had some panic attacks and some problems because his volume of tissue activity was a little bit low, and we used a new technology that was very handy by kind of shaping the areas here, and when we push it up, we did not have panic attacks anymore. Much better result because we pushed this into the STN, and this is the other side. With other words, we can really kind of get to a point that we tangle and that we tune STN-DBS to a point that we can address the individual motor but also non-motor symptoms of our patients. And why do we need this? Because we know, and we just want to show the picture again from this wonderful study or this paper from Valentina Leta to say, well, in the future we have to characterize our patients for tailored therapy in a very specific motor as well as non-motor symptom variety, kind of to improve them. And at this point, we thank you all for listening, and we endorse our non-motor symptom group. Thank you very much.
That was a fantastic double act. Time for one or two questions, if anybody has any questions. Anybody wants to ask any questions? Yes, we got one question at the back. Wait. Microphone coming.
I'm a bit curious with the pictures that you showed of the ventral stimulation of the STN. Are they within the STN, or might there be an area close by that is involved in limbic functions?
Yes. When you stimulate in the ventral part of the STN, you always have some limbic effects. And there's something even worse when you stimulate in the substantia nigra. There was this very old case from Bejani in the New England Journal of Medicine that with stimulation you could instantaneously get somebody suicidal and very much depressed. And I had now these days a lady on my ward, and she was very much depressed. Her husband died on a glioblastoma 2 years ago, but she was very much depressed, and she was not operated in our center. So we made such an analysis with CT scans and the pre-op MRIs, and suddenly we found out that she had a substantial stimulation within the nigra, and we were kind of pushing up the fields, and we got a much better effect, not only on the motor, but also on the non-motor part. So I think non-motor symptoms drive in these days also our tuning and our visualized, digitalized STN tuning, at least as much as motor functions.
Thank you. One more question there. Irena, just in the front, second. Yeah.
Thank you. Thank you very much for those double presentations. I wanted to ask you, what's the workup that you do prior to DBS, actually? Because there are some hints, right? Also for patient consultation, what you do and do not do. So what's the workup that you do before?
I think it's very similar between Cologne and Marburg. So
since he invented the rules, so yeah.
So what are we doing? First of all, we need a good MRI scan so that the surgeons can look at, and we just learned white matter lesions are not good. We look at the atrophy. Second, we always still make the levodopa test. We make a whole bundle of tests. I can send it to you to rule out that they're depressed, suicidal, hypomanic, impulsive, cognitively impaired. So it's it's like a one-day homework. We make EEGs because we found out in another study that once you have more temporal delta activity or theta activity, you have a higher likelihood of having a crash down in your function in the next years to come. We're still doing, in many of these patients, some walking analysis, but this is more research. We make a high-resolution EEG. This is more research. We make a PET scan, which is all research. So it's a full-blown thing. And we will always make the psychiatric consultation because we are always want to have this. So in total, it takes something like 4 to 5 days as an inpatient, which is a luxury.
And if I can just add also speech therapy assessments, because this is a common side effect of DBS, so 10% develop dysarthria. So this is also very important to have it like before surgery and see what really changes, because the disease itself, as you know, has dysarthria quite commonly.
With respect to MRI, do you do any tractography or anything specific?
Yeah, part of our MRI sequences is indeed that we make DTI so that we can make a tractography. And our neurosurgeons kind of load this into they use BrainLab, as probably many of you, not all, but many. Within BrainLab, they also use the tractography data to be a little bit better kind of in the implantation.
Thank you very much. I just want to make one comment as well, because you heard how beautifully nowadays we can personalize deep brain stimulation to the patient. And this is the difference between DBS and lesioning. So whether you lesion with focused ultrasound or lesion with radio frequency, you can never personalize because you cannot modulate. DBS, you can modulate, and that's where the difference comes. Personalized medicine versus non-personalized medicine. Thank you very much.
Thank you.
Yeah, one more question here. Yes.
Irena asked you about the workup, but do you think that genetic testing, GBA for example, as a poor predictive factor, is there any rationale now to measure this in the group of patients qualified for DBS? And my second question is maybe to the neurosurgeon: do you still use micro-recording or you switch to this preferred by some centers general anesthesia treatment?
You go first. Mine will be a lecture.
Okay, so if a patient has some or rather severe cognitive deficits, then we would do the biomarkers for looking at whether they have an Alzheimer's pathology. I think this would be the very first step. And then there is always research interest in genetics, but I think it's not quite clear whether this really impacts the outcomes of DBS. There is a case to be made that if they are likely to develop severe dementia within a few years because they have the genetic profile and they have the biofluid profile, then you could, rather say, okay, we think this would not really have beneficial effects for the patients. But very often I think with genetics, because there are some steps on the way, right? It's not as direct. I'd rather be a bit more not put too much weight on it, to be honest. But, yeah.
We were doing the genetics because we have this Panama cohort, Parkinson Network Alliance Marburg, and so therefore we do the genetics and the metabolomics anyway. So it's again research, as I told to Irena. It's kind of something we're doing anyway.
So in practice, just to follow on the GBA question, if we do the testing, and if somebody is positive, what we do the neuropsychology assessment 6 months later to see if there is any deterioration. If stable, we still go ahead with DBS. So you look at the genetics in the context of clinical picture rather than in isolation. Now, to answer your neurosurgical questions, so I look at deep brain stimulation as a stereotactic functional neurosurgery. It is stereotactic because it relies on imaging to find the starting point for your surgery. It's functional because you're aiming to improve the function of the patient. So it needs physiology. There's anatomy plus physiology mixed together. Now, I don't mind what kind of physiological refinement of the initial anatomical target you use. Some people use macroelectrode recording. In the UK, we traditionally haven't, but I do my surgery awake because the proof of the pudding is seeing the patient clinically improve. So I look for efficacy, I look for side effects, which you cannot do if you do under general anesthetic. It's purely anatomical. You can choose a point, you target it, hopefully, keeping fingers crossed, you won't have much side effects. But if you take an extra hour and do the operation awake, you can actually test for those. So always use anatomy, absolutely, MRI guided, but then physiologically verified, not anatomically verified. So that's the difference. I think we ought to end this bit, otherwise we'll be here all day. Thank you very much again.
Thank you so much.
Great. So our Cologne team continues with our next speaker, as she's coming down, Stephanie Just, and she's going to tell us about non-invasive vagal stimulation. So as a surgeon, I do a lot of very invasive vagal stimulation for epilepsy, for depression, but not a lot non-invasive. So really keen to hear about your experience. Thank you, Stephanie.
So thank you very much, Ash, for the nice introduction. Good afternoon, everyone. I feel honored to have the opportunity today to speak about the non-motor effects of transcutaneous vagus nerve stimulation, or TAVNS, in Parkinson's disease. And so now we've already had a really nice talk on the non-motor effects of deep brain stimulation, and I would like to introduce you now to quite a new neurostimulation approach, which has gained increased attention for treatment-resistant depression, and more recently also in Parkinson's disease. So in Cologne, we have started our own study on this subject, and my colleague Hader, who's working with me on the project, he already mentioned the project on the meeting last year, and since then we have continued recruiting patients, and today I would like to give you an update on the project and show you some preliminary results. So what is TAVNS? It is a non-invasive neuromodulation technique that targets the vagus nerve. And these figures illustrate how TAVNS is applied. On the top, you can see the innervation of the outer ear, and in pink, you can see the key region for the stimulation, which is the Zimba concha, as this region is supplied by the auricular branch of the vagus nerve. The lower image on the left shows how the electrode is placed to this concha region, and on the right you can see a typical stimulation device which delivers mild electrical impulses through the ear, and the patient is then able to adjust the stimulation intensity on his or her own. So why should this be helpful in depression? So the exact mechanism is still unclear, but this figure shows how TAVNS may engage central and also peripheral networks involved in depression. So on the one hand, the signal projects from the ear to the NTS in the brainstem, which is the key integration site for vagal signals, and from there it goes up, for example, to the locus coeruleus and other regions like the hypothalamus or the amygdala, and also cortical regions involved in mood regulation or stress response, and also cognitive control. And at the same time, descending pathways from the NTS may modulate the autonomic nervous system, which may also be very helpful for several depressive symptoms. And these descending pathways may also reduce peripheral inflammation via the anti-inflammatory cholinergic pathway, and this is also a known contributor to depressive symptoms. So what do we know so far about the efficacy of TAVNS in depression outside the context of PD? TAVNS is already widely applied for treatment-resistant depression, and here you can see the results of a meta-analysis, a recent one which found across 12 RCTs comparing TAVNS with different control conditions, an overall moderate to large effect on depressive symptoms favoring TAVNS. And this also included a subgroup of studies comparing TAVNS with sham stimulation. And here the authors report an even large effect. However, as you can see on the top, there's quite a lot of variability across study results. And in another subgroup of studies comparing TAVNS with antidepressants, the effect was smaller, but also more consistent. And in the last subgroup of studies investigating TAVNS as an add-on to antidepressants compared with antidepressants alone, the combined therapy was even more effective than antidepressants alone. All studies reported only mild side effects, and side effects for TAVNS were even lower compared with antidepressant therapy. So in summary, these findings suggest that TAVNS is safe on the one hand, and that it's effective as a treatment alone and also as an add-on to antidepressants. So what do we know about TAVNS and PD? There are only very few studies in PD so far, and as it is often the case, still, obviously not in this audience, but in more general, these studies still emphasize motor outcomes. And since this is not the topic, the focus of my talk today, I will keep this part brief, but interestingly, recent RCT reported improved gait outcomes following TAVNS. The study was by Marano and colleagues. They investigated patients with deep brain stimulation recordings and showed that TAVNS led to reduced beta band activity in the subthalamic nucleus. And this reduction was correlated with improved gait outcomes in the timed up and go test. So notably, they did not find any significant change of more global motor scores like the UPDRS-3. So now let's have a look at what is known so far about the non-motor outcomes in PD. Up to now, there's only one study that systematically reports a wide range of non-motor outcomes following TAVNS, and this is yet also only a pilot trial. The study was a sham-controlled RCT with 30 patients who received 10 one-hour sessions of TAVNS over a 2-week period. And by the way, this is what the sham stimulation usually looks like in the studies. The electrode is here applied to the earlobe, as this region is not supplied by the vagus nerve. So if we have a look at the non-motor outcomes in the study, they report no significant changes in global measures, such as the non-motor symptom scale, the MDS-UPDRS Part 1, and also no changes in global cognition. And interestingly, they even found that verbal fluency worsened in the TAVNS group. And so overall, they concluded that TAVNS was safe in their sample, but that there's no evidence of a non-motor benefit so far. And additionally, I wanted to show you another small study by Kaut and colleagues who were looking at gastrointestinal symptoms in PD. And here, 10 patients with PD received TAVNS and were compared again to sham stimulation. And they found that both groups showed some improvements in the gastrointestinal symptom rating scale. But however, this change was not significant, and it was also present in both groups. So to summarize, so far there's only very limited evidence on the non-motor effects in PD, and the available studies have not demonstrated any clear benefits. So as I've mentioned in the beginning, we have started our own study on this subject, and let me first tell you something about the design of the study. It is an ongoing, prospective, controlled observational study, which is so far monocentric. We included patients with PD with at least mild depressive symptoms, and all patients received an introduction on how to use the stimulation device, and they were then able to apply it independently at home. And according to the protocol, they were instructed to use TAVNS at least twice a day for 30 minutes over a 4-week period. And here you can also see our stimulation parameters. For the stimulation intensity, this could be adjusted by the patient himself, and they were instructed to keep the stimulation intensity just below the pain threshold. So if patients received any antidepressant medication, they were not allowed to change the medication during the treatment period. And so far we have 31 patients enrolled, and today I will present you data from the first 19 patients. This has to do with the fact that we had a relatively high dropout rate of 11 dropouts so far, and this is actually our first important result, as it tells us that patient adherence is quite a challenge. And for example, we had 4 patients who did not use the device as instructed. And so for the future, this means that we will have to monitor the patients even more closely to reduce dropouts. The adverse events were only mild in our study. So far, we only had 2 patients who reported headaches, and both cases resolved completely soon after stopping the stimulation. And here you can see the demographic characteristics of our cohort. Patients were on average 63 years old with a relatively short disease duration of about 4 years, and most of them were in a mild to moderate PD stage. And our primary outcome of the study was the Beck Depression Inventory 2. And here you can see how to interpret the BDI scores. So at study entry, the patients were on average in a mild to moderate depression range with almost 19 points. So let's have a look at our first results. On the group level, we see that the average score in the BDI improved from almost 19 points to almost 12 points. And so this means there's a reduction in points about 7 points, which is not only significant, but also exceeds the minimal clinically important difference for the BDI. So the MCID for the BDI usually depends on baseline severity, and around a 17% improvement usually indicates that patients report to feel better in terms of depressive symptoms. And in our data, you can see that the reduction in depressive symptoms was about 40%, so this clearly represents a clinically meaningful improvement. So looking at the right, at the individual patients in our sample, you can see that the majority of lines slope downward, showing improvements. A few lines remain almost flat, indicating stable outcomes, and only one line slopes upward, indicating a clinically relevant worsening. And finally, this pie chart summarizes the individual outcomes you can see on the right. We see that more than 2/3 of our patients can be classified as BDI outcome responders. So they had a clinically relevant improvement of depressive symptoms. We have about 1/4 who remain stable, and as I said, only one patient with clinically relevant worsening. So let's have a look at our secondary results. We also measured quality of life in our study using the PDQ-39. And here we also observed a significant improvement of quality of life with a reduction of about 5 points, which is around the MCID for the PDQ-39. And on this radar chart, you can see the different baseline scores in blue and the follow-up scores in red. So you can see that across most domains, the red line is shifted inwards and compared with the blue line. So this indicates improvements. And if we have a look at the subdomains of the PDQ, we see the strongest improvement in emotional well-being, which is obviously not very surprising, given the significant reduction in depressive symptoms we've already observed in the BDI. We also saw an improvement in the communication domain, and this maybe reflects that patients with improved mood and improved emotional well-being, the patients may feel more comfortable in social situations and also in daily communication. And interestingly, we also saw a significant improvement in the cognition domain, which is also in line with the literature on cognitive effects of TAVNS outside the context of PD. And here you can see another secondary outcome of our study, the MDS non-motor symptom scale. Here we again found a significant reduction in overall non-motor symptom burden with an improvement of around 28 points, which is quite good, and a moderate effect size. And again, you can see here the radar chart, which shows the individual domains of the MDS and MSS. And again, we can see a consistent reduction in depressive symptoms. And what's new here is that we also observed an improvement in the anxiety domain and also in the sleep domain. So the next question is, which patients benefit the most in terms of depressive symptoms? We performed first exploratory regression analyses, but obviously the sample is still quite small, so these results should be seen with caution. We included several demographic factors and clinical variables as potential predictors, but patients' age, disease duration, motor stage, etc., did not have any predictive value on the outcome. So the only significant predictor was the depression severity at baseline. So patients with higher depression scores had more improvement after the intervention, which is actually not really surprising, as these patients obviously have the most room for improvement, but it's still quite interesting for us when it comes to defining inclusion criteria for future studies. And this may also explain, by the way, why there was no effect on non-motor outcomes in the study I showed you earlier, because in the study by Lund and colleagues that I showed, they did not include patients specifically based on depressive symptoms. So another aspect that is often discussed in the context of TAVNS is its effect on cognition. And we already saw in the PDQ that the patient subjectively had the impression that their cognition improved after the intervention. And now I would like to show you some of our results from the objective cognitive measures. We applied a MDS level 2 cognitive test battery for the characterization of our cohort, which you can see here on the right. And importantly, we did not see any significant worsening in any cognitive domain, but we even saw some small improvements in some domains. So the subjective impression from the patient was consistent with the objective measures. So, example, we saw a slight improvement in verbal learning in the CIRAD. And interestingly, we also saw an improvement in word fluency with category switching, which is particularly noteworthy, as I mentioned earlier, that the study by Lund et al. Found a significant worsening of verbal fluency under TAVNS. And thirdly, the global cognition was measured with the MOCA in our study. Then there was a small but non-significant increase in points of the MOCA. So in this context, it is important to stress that cognition was not the primary outcome of our study. So we did not specifically include patients with cognitive impairment in our study. In fact, the majority of patients was cognitively unaffected. But this means that there was only little room for improvement in cognitive outcomes in our patients. So it will be quite interesting for future studies to study patients with cognitive impairment. So up to this point, I showed you only data from our intervention group only. So this has to do with the fact that at the beginning of our study, our design had only 2 time points. We had the baseline, then we had the intervention, and then the follow-up. But as the study went on, we decided to add a waitlist control. And so now the design looks like this. We now have 3 assessment points. We have the baseline, then the waiting period, and afterwards the intervention, and then the follow-up assessment. And at this point, we only have data available from 7 patients who completed all 3 assessment points. And here you can see their BDI scores with, again, downward slopes indicating improvement. So, but this is, at this time point, only very descriptive preliminary data, as it's only 7 patients. I just wanted to show it to you so you can get an impression of where the project is heading. We didn't do any significant testing on this yet. So to conclude and sum up, our study and also previous results have found that TAVNS is safe and well tolerated also in PD. We observed a large improvement in depressive symptoms, and looking at the secondary outcomes, we also saw improvements in quality of life and non-motor symptom burden overall. We observed that cognitive outcomes remained stable with even some slight improvements. And we saw that patients with more severe depressive symptoms appear to benefit the most. So looking ahead, we definitely need larger and well-controlled trials with wait lists, or also in the best case with sham stimulation, control groups, and also comparisons with antidepressant therapy or also cognitive behavioral therapy would be really interesting. Another interesting direction is, as I mentioned, to study patients with cognitive impairment and maybe also patients with autonomic symptoms, as these patients may also benefit from TAVNS. So overall, these results are quite promising, but it's clear that there is much more research needed. So these are my references, and with that I would like to thank you for your attention, and I would like to express my special thanks to the team. Here you can see some of the persons who have been involved so far in the study. And as I mentioned, so far the study is monocentric, but we would really like to invite you to join the study, so just talk to me or also to my colleague Heda if you're interested in taking part. So thank you.
That was great, Stephanie. Thank you very much. So in the interest of time, we can allow 2 questions. Irina, do you want to go first?
Thank you for sharing these interesting, promising results. As you said, well, there are various non-invasive stimulation techniques that are now used for home-based therapies. And maybe you could have a look at how to check online, because there is a published guideline for these home-based therapies, at least for TDCS, TACS, for transcranial direct current stimulation and alternating current stimulation, how to check them so that you do not have that many dropouts, right? That's one thing.
Oh, that's really interesting. Thank you. Yeah.
Yeah. And one more thing, I would honestly really warn you to publish uncontrolled studies, because all these studies, and I know it because we've done it a lot, have huge placebo effects. So I think you really need that sham arm. And I have some ideas we may then discuss. Maybe it might be even interesting to have similar design, but using various home-based non-invasive methods, like VNS,
really
and compare it to TDCS or TACS might be also very interesting.
So thank you for this comment, really good ideas. So this is obviously not published yet, so it's just preliminary data on the project so far. But yes, we definitely need this control group, and will be really interesting. So maybe next year we can give you an update on the controlled results of the study.
Any other questions?
Thank you for the interesting talk. Perhaps I missed something because I came in late. But when you said that this intervention has an anti-inflammatory effect via the cholinergic pathway, is this based on some biomarkers in humans, or has it been substantiated with experimental models? And do we need to substantiate this with experimental models?
So I'm not sure actually if there was a direct study investigating this, but I guess it does. Heda, do you know? There are some very good. Sorry, thank you.
Yeah, there is some data available from animal studies. So Martin Szedlowski, who is in Essen, he has worked extensively on this issue. And there are also studies in humans which show the effects. And there is a mechanism behind it. And so it seems to be working through different modalities, basically.
Great. I think we will end this talk. Thank you very much, Stephanie, again, for a lovely talk.
Thank you so much.
The last speaker of this session, great pleasure to introduce Professor Slovak, who is going to tell us about non-motor indications for Botox? Thank you.
First of all, I would like to thank organizers for a kind invitation to share my experience and knowledge on botulinum toxin treatment. And in Gdańsk, we established the Movement Disorder Center almost 30 years ago, and I started to treat with botulinum toxin my first patients in 1995. These are my disclosures, and you probably know from the literature and that botulinum toxin is useful treatment and licensed treatment for cervical dystonia, blepharospasm, spasticity, for cosmetic uses also, but they are all based on the mechanism, intramuscular mechanism of blockade of the acetylcholine release. And in the recent years, we also investigate the other mechanism of botulinum toxin, and especially for the treatment of pain, but also for sialorrhea and overactive bladder. And those three non-motor indications were, I think, the first one published in the literature. Why it is important to treat patients or to have more treatments we can offer to our patients with Parkinson's disease, because patients need such a treatment, as you can see in this paper on patients' perspective, where patients included with the less than 6 and over 6 years duration of the disease. You can see here that rank of the 24 most bothersome PD-related symptoms and conditions. In those advanced, not very much advanced, 6 years is not a long period, patients, mood, drooling, sleep, pain, bowel problems, urinary problems were on the top of this list of complaints. So I think it's important to think and remember about this when we deal our patients in everyday practice. On 200th anniversary of an essay on the shaking palsy, Professor Chowdhury with Dr. Titova, they edited the series of papers, and we were involved to write the chapter on botulinum toxin therapy for non-motor aspects of Parkinson's disease. And at that time, we focused on drooling, neurogenic bladder, and constipation. And what is new now? Now we have also some evidence on pain treatment, on mood and cognitive treatment, and sweating and other small indication. But let's start from drooling. I think it's very important and very neglected symptom. We do not pay as much attention to this as it should be. This is, of course, the extreme case of debilitating consequences of drooling described by the Bas Blem group. The man, 71, with Parkinson's disease, lasted 13 years, and for the last 4 years he complained of drooling, which started at night. It's a wet pillow. It's useful phrasing for communicate with our patients, and then converts to the whole day drooling. Anticholinergics were badly tolerated, and they should not be prescribed because of side effects, cognitive side effects, hallucinations, and we should avoid them. And substantial improvement was noticed after botulinum toxin injection. Who suffers drooling? Of course, Parkinson's disease patients, but also the atypical Parkinsonism patients, especially MSA, amyotrophic lateral sclerosis, and head injuries, facial nerve paralysis, and many others in the child neurology, cerebral palsy is probably the first indication. In most cases, chronic sialorrhea or drooling is not caused by the excessive production of the saliva, but the excessive collection of the saliva in the mouth due to the problems in swallowing and in orofacial functions. It may occur in the majority of our advanced patients. Here you can see the meta-analysis of 15 studies, and the drooling was noticed in between 10 and even 84% of patients. And it correlated mostly with dysphagia and dysarthria, so it was related more to swallowing problems than to hypersalivation. In Parkinson's disease, it is also responsible for there are other mechanisms responsible for drooling, not only dysphagia, but also lingual bradykinesia, upper esophageal dysphagia, hypomimia, and abnormal stooped posture when the patient cannot close the mouth and to stop the increasing salivary flow from the mouth. And it is not only the problem of the hygiene or stigma or poor quality of life, but I think that we do not remember or bear in mind that it may be responsible for respiratory tract infections and aspiration pneumonia. So I think it is worth it to be noticed and to be treated. As you remember, drooling was the third on the list of the complaints of patients with advanced Parkinson's disease. How can we treat sialorrhea? We can use oral medications, but this is problematic as it was described in the case of Bas Blum because we can use scopolamine, atropine, glycopyrrolate, but all those anticholinergic medications may be not well tolerated in elderly patients. X-radiotherapy, it's another option, but I think botulinum toxin is relatively easy and effective and well documented method of treatment. We have 3 salivary glands, but we usually inject parietal and submandibular. They are crucial to this production of the saliva, and we have to inject both because they're responsible for different kind of saliva which is excreted. What is the evidence in the literature? I think this was the first publication on the treatment of sialorrhea in Parkinson's disease by the Polish group for Professor Friedman from Warsaw, and it was almost 25 years ago. And when we published the paper on the 200th anniversary of the essay by James Parkinson, I noticed in the literature only 4 small studies, double-blind, placebo-controlled, and 2 of them were with the use of botulinum toxin type B and 2 with botulinum toxin. 1 was with type A and 2 and 3 with type B. And the improvement and the results were encouraging, and it was probably the reason for organizing the big study, placebo-controlled, randomized, with acronym SIAXI, which was performed by the Merz company. And the results were published in 2019, and now this is the FDA and EMA approved and licensed, and in some countries reimbursed, unfortunately not in Poland, treatment of drooling. So the only product with licensed this indication is incobotulinum. This is the FDA name, and Xeomin, this is the trade name. In this study, the majority of patients included were Parkinson's disease patients. However, other indications were also allowed, but the PD were 130 patients, and there were two doses tested, 75 units of INCO and 100 units divided between the two parietal and submandibular glands. And it was compared to the placebo, so it was 2-to-1 randomization. And if you look at the primary endpoint, you can see the excellent result for both lower and higher dose. However, the higher dose was significantly better than the lower one and placebo. Also, the secondary outcome measures, global impression, drooling severity and frequency scale, all they showed the good results. And it was very, very safe. There were no discontinuation from the treatment, and there were no fatal adverse events, especially related to this treatment. Is it efficacious in the long term? Yes, it is. It was this placebo-controlled phase was continued with the OLEX period, and it lasted 64 weeks. And as you can see here, the effect was stable for the whole period. So we can repeat this every 3-4 months, but sometimes effects are longer, lasting even 6 or more months. If you would like to inject, it's relatively easy. In the SIAXI study, it was not mandatory, but allowed to use ultrasound, but there were no differences between those who injected with ultrasound or without ultrasound. So you can use only anatomical landmarks, but if you want to study in more details how to use ultrasound guidance, I recommend this paper by Wolfgang Kiost. So you can see here that those submandibular and parietal glands are can be easily detected with ultrasound. And even the neurologist who is not an injector and do not inject botulinum toxin for cervical dystonia or blepharospasm can learn this very simple technique and can do it. It takes only 10-15 minutes to inject all four salivatory glands. Neurogenic bladder, very shortly, because this is the indication in between neurology and urology, but definitely we need the treatment for the neurogenic bladder, and what we have now, this is oxybutynin, tolterodine, and other antimuscarinic agents. We have one, which is mirabegron, adrenergic one, who is safer, but it's not cheap. And we have botulinum neurotoxin, which is probably not used as frequently as it should be, but this is very effective. And majority of patients, 60%, even up to 80%, at some point of the disease suffer from neurogenic bladder. So the first publication was published in 25 years ago, and it was highly effective, and it increased the bladder volume. Improvement was very long, 6 to 9 months. But what is the limitation of this treatment? This is the self-catheterization. In the majority of patients, they have to be taught how to do this self-catheterization, which is obligatory. Gastromotility and constipation in Parkinson's disease. We know that this is the very complex problem with a complex etiology, but we have one of the possible mechanisms of the constipation. This is the paradoxical tone increase, or rather lack of the relax of the puborectal muscle. So it may be even present in the quarter of our patients, and the natural treatment would be the relaxation of this puborectal muscle with the use of botulinum toxin. But nowadays we know that this is not the only muscle for the treatment, so we can treat with botulinum toxin the gastrointestinal tract at the level of esophagus, a level of intrapyloric part, and also the puborectal part. And you can see here those 4 levels, different units of Botox, mostly published in the literature, but quite good results. Historically, the first paper probably was from the Italian group, from Alberto Albanese. This was the letter to the editor on the treatment of so-called outlet obstruction, constipation, and Parkinson's disease with botulinum toxin. So this was the very small trial with good result, showing that injecting this muscle, which should be relaxed during defecation and is not in the 25% of our patients, this paradoxical puborectal syndrome, we call this the belt syndrome, may be effective, and you can make this angle, which is shown also here at these radiographs, we can make it more open, not so sharp, and this will result in the better function. What about the studies? It is not the approved indication, licensed, but we have some clinical studies by Albanese, which was the first one, and then the next one also in the very small group of 18 patients. But in 2016, there was the meta-analysis. There was 7 studies analyzed, and the improvement after botulinum toxin was very good, 77%, with the mean dose 100 units. 100 units, this is the whole vial of botulinum toxin injected into the anal region. So maybe we think all of us think about the possible consequences of this, but we studied this many years ago with the gastroenterologist, and we injected up to 1 vial in different diseases, so-called benign anal disorders, and we didn't notice any complications. So I think this is very safe method of treatment, even with the high doses. Of course, it's better to start with lower dose and increase this at the following sessions. What about the pain? We do not have many papers, but in pain is also a very complex symptom related to different things, and if it is related to the dystonic or musculoskeletal activity, it can be improved. In those open studies, it was improved even up to 81% in this group of dystonic and musculoskeletal indication, and dystonic pain 77%. But the same group performed the study. This was the study, the initial study from the Canadian group. But the same group performed a new study, which was double-blind, placebo-controlled, only 12 patients with advanced PD, and this the results of the study were disappointing, and there was no significant difference when compared to placebo, and authors stated that further studies on the use of botulinum toxin for pain in PD are needed to define the optimal treatment protocol. But now we can think about the dystonic pain and in this algorithm, it is noticed that trial of botulinum toxin for dystonic limb pain can be a good option for this treatment. However, we do not have the solid evidence that it is really a good treatment method. Another more recent study was published with the use of incobotulinum toxin, and it was used only for the flexion, plantar flexion of toe dystonia, and the results were very, very good. There was a question about the sweating also. We can call this also hyperhidrosis, which can be the non-motor effect of fluctuations, and we can use this also. We know how to treat patients with hyperhidrosis when it is located, of course, to the palmar or plantar region. Regarding the mood and cognitive treatment, I'm very skeptic on these indications, but it was based on the first paper published many years ago by the Hanover group, by Dirk Dressler, on the possible benefit of treatment of depression with botulinum toxin injection within the face region. And the Chinese group, they tried to prove this effect in Parkinson's disease depressed patients. 89 patients divided into two groups, observational versus control. But you can see here that the effect was noticed, but there were no difference between placebo, and this was what Irena told, that in the Parkinson's disease we can see the very high placebo effect. Even after the sham surgery, we can observe even up to 1 year the placebo effect. So the conclusion from the study is that PD patients commonly experience multiple neuropsychiatric symptoms, and we can use this try, but I don't think now we have evidence that this is a good method of treatment. And coming back to the title of our conference and the case series of published in 2017, Hidden Phase of Parkinson's Disease, I think that is still hidden. And looking at the paper published by the Per Odin Swedish group on the compliance with national and international guidelines in the treatment of non-motor symptoms in late-stage Parkinson's disease, you can see here that sialorrhea was treated with botulinum toxin, despite it is present in the national guidelines, only in 3% of patients. And as you remember from epidemiological studies, it may affect almost 60% of patients. And if you look at all more than 100 participants, it was the same with depressive symptoms, hallucinations, and delusions. Only half of the patients were treated, and even less with dementia, 33%, and for sialorrhea again, it was 2 of 42, which means 5% were treated with botulinum toxin. So I would like to conclude with the conclusions of the study that the present analysis suggests a need for clinicians to further screen and treat non-motor symptoms, and botulinum toxin is one of the possible options. And thank you again for your attention, and you are invited to Gdańsk, which is not far from here, only 1 hour flight. Thank you very much.
Thank you very much for that great talk. Any questions? I can't see any hands. I think, yeah, please, thank you.
I'm not sure if it's a question or a comment, but I was thinking about the complications of sialorrhea and the risk of dental and periodontal disease, which I think is something we need to think about in this group of patients because they have a low oral clearance.
Yeah, it's a very good question because it was tested. It was obligatory tested during the SIAXI study. The patient had to visit the dentist to look for some complications. That there were no complications resulted as a result of the decrease of the production of the saliva. So, but of course, this is very important also.
Great. I don't see any other questions, so thank you very much. I'd like to bring this session to an end, and again, thanks the organizers, particularly Ulrika, Ray, and Per for inviting me. I'm going to hand over to Ulrika to invite you to have some coffee. Thank you.
Yes, thank you. So soon we're going to have a short break, but first I have a message to 4 of the participants. So you need to listen carefully now because I'm going to try to pronounce your names. Might be less than perfect. Nikolai Katori, Kamaran Shores, Alexia Karayong, and Filippa Gonsalves. It's regarding dinner tonight. You were on the waiting list, and you can go to Elizabeth, who is raising her hand, to get more information about that. And also for those of you who have a space or are going to the conference dinner tonight, we will go together. If you don't, it might be a bit hard to find if you haven't been there. But what time are we meeting here at the? So 7:15 at the main entrance, and if you want to walk in a group, then that's where you go. Now you're free to stand up and have a little rest, leg stretch. Okay. Okay, welcome back, everybody. It feels almost ridiculous to introduce, because now we've spent the day together and feels like we know each other. But I give the word to Ray Chowdhury.
Okay, so we have an interesting addition to our program. In terms of the setting of the program, it's just different, and I think it makes it, for me, certainly very educational. So we have great pleasure to have Sir Nicholas Mostyn here, Professor also, and so we will ask Nicholas about his journey in Parkinson's. But just a very brief introduction that Sir Nicholas, I think, came to my clinical practice when was it again?
21.
21. For another opinion and another management of his condition. I've known him since for his diagnosis of Parkinson's. And of course that he's become a very important part of my whole learning process about Parkinson's. It's nothing, lived experience is very different to what often we consider as part of Parkinson's. So, and particularly with me, my interest in non-motor aspects, which is often more felt rather than seen. It's been very important to have Nicholas's view. And of course, he leads a huge body of people with Parkinson across the UK, and I think more so globally, with his very prize-winning, award-winning podcast with a group that Nicholas is part of called the Movers and Shakers. In the UK, they are all quite well-known celebrities and broadcasters and celebrities who unfortunately have been diagnosed with Parkinson's, but are living with it and then made it into this podcast, which is transmitted, I think, now globally. Is that right? And if you haven't heard it, I would strongly encourage you to hear it, because it's held in a very British tradition of the interview of the interviewers are grilled in a pub. Usually in the afternoon. It's a very nice pub in Notting Hill. It's the same place where the film was made. And usually 6 of them sit there, and people are invited, like myself and various other people, and they're absolutely grilled with questions that you really struggle on radio live. So it's actually quite a learning experience in many ways. But I found it quite interesting, and of course then we got together in doing many different type of work, and particularly now we're developing this dashboard app, which bears Nicholas's name, which he contributed in a major way to the importance of looking after these issues, such as anticholinergic drugs, such as sleep, such as gut health, bone health, oral health in Parkinson's. So great pleasure and privilege to have you here.
Thank you very much.
Traveling up to Copenhagen and then on to Lund, straight from New York.
Yes.
Is that right?
Indeed.
Yes. So I think what we would like to do is ask you some questions, and perhaps you can ask us some questions. You know, we are involved in the Parkinson's management field. So perhaps I could start by asking you, would you like to give us a brief description of your own perception of how the diagnosis was made and your journey into Parkinson's so far?
Well, we have decided that because we've only got half an hour, that the whole of the backstory would consume too much valuable time. And so on the pieces of paper, my backstory is set out. I mean, the longer one is in fact an expanded version of an interview I gave to the Sunday Times in July 2023, just following my retirement, because although I was diagnosed in 2020, I sort of struggled on as a High Court judge. It's a big job, trust me, it really is a big job. And I was finding the combination of fear of falling asleep and inability to write meant that I was not doing the job as well as I could. They gave me an assistant who was a note taker, but that's not the same if you're a judge of note takers. You want to write your own notes, really. Like, this person is not telling the truth. You want to be able to write down. But and so I made the decision I would retire early. So I retired in 2023, which was 9 years earlier than I was required to retire. In England and Wales, you go on to 75. So I retired at that point early, and the story up to that point is in this. It has some nice stories in there as well. In our group, we have a very famous broadcaster called Jeremy Paxman. If you ever watched any television in England, you will have probably seen Jeremy Paxman on it. And the final thing, I think, is at one of our meetings, Rory Kettling-Jones, who was the technology correspondent of the BBC, asked, why would anyone want to listen to some decrepit old relic talking about living with Parkinson's? To which Jeremy replied, because they might fucking well get it.
And so that's why we made the podcast. Now, I should say that I was in quite a bad state before my diagnosis. If you look at the other piece of paper, you can see, because my principal problem was tremor. And the results of the tests, if you look at the July 2021, you can see that I was having tremor 25% of the time. So, which is a lot of the time, bearing in mind you're asleep for quite a lot of the time, aren't you? And so the tremor was one of the problems, but I also had terrible insomnia and night terrors, and the night terrors were extreme. They'd been going on for about 7 years, and so they would count as a prodrome, I expect, wouldn't they? And you can see in the second paragraph of this, I describe what it was like. As I said, frequent graphic nightmares involved acting out desperate struggles against wartime invaders, shouting and swearing, hurling furniture about, attacking my poor wife. This had been going on for rather a long time. So I had that problem, and then I had tremors, and then I had narcoleptic problems, which was causing me considerable concern. Driving around, you get very little notice of the fact you're about to fall asleep. So the combination of all these things said, it's time to call it quits. On the judge front, I mean, Ray had been helping me judging because you'd given me some modafinil to make sure I didn't fall asleep. So I just love the idea of any people who've been in front of me here judge on speed. You know, you didn't want to get that. So that was basically my story. But the tremor document, if you look at the second column, this is after I'd been on a pickbone for about a few months. And it is an extraordinary, this is measured by an extraordinary result, is that the tremor went away. Now, I can't say that the apicopone on your sleep session had any effect on my insomnia at all. And in fact, nothing seemed to have had much effect. I'm on 12 milligrams of melatonin a night, and it's still, I'm lucky if I get 4 hours sleep a night, which is not healthy at all. And so that is a continuing problem which doesn't seem to go away. And I thought that the night terrors had gone away, but I've ended up, I was driving. I drove all the way with my brother to Bilbao to watch the UEFA Cup final, can you imagine? And I was staying in a hotel near Bordeaux, and I was in my sleep, I was in the most terrible assault on somebody who was trying to kill me, and I had him on the floor, I was kicking him, but I wasn't kicking him, I was kicking the wall of this French hotel. And I had to explain in the morning why the walls were covered in blood. So the night terrors haven't quite gone either. Sure. Anyhow, so that's the backstory.
Well, that, you know, it's really eye-opener from what you say in terms of the night problems that you're having, which often. But you know, some of the things perhaps you could tell us about the diagnosis issue that has confronted you. Firstly, when you were given the diagnosis originally, how that was handled, and subsequently, what other issues have you had?
Well, yes, I mean, if you listen to our podcast, you'll hear complaint after complaint after complaint about neurologists not having, how should I put this politely, a perfect bedside manner, and dealing with people who they've just diagnosed in a peremptory, unsympathetic, and I want to get you out of here and the next one in as soon as possible. I mean, in my part, I was referred to a neurologist, and he did the normal test of drawing circles and walking up and down and swinging my arms, and then he sent me off for a DAT scan. And a DAT scan came back positive, said that it was highly suggestive of Parkinson's disease or Parkinson's syndrome. And so I went back to him and I said, well, what does this mean? And he said, it's likely you'll be in a wheelchair in 5 years' time. That's what he said. So I said, what do you mean it's likely? And he said, well, at least a 20% chance. I said, well, that's unlikely, isn't it? I mean, that's 4 times more likely that I won't be in a wheelchair than I will be in a wheelchair, I would have thought, wouldn't you think? So that was not. But the thing that was, I mean, I've always say to the clinicians, if only you could just be me for a day, so then you would know what Parkinson's is like. And the thing for me that keeps the Parkinson's at bay is a combination of 3 things. Firstly, I'm on a really good regime of drugs, okay? 9 pills a day I take, but they really do seem to work. But secondly, I take a prodigious amount of exercise. Now, one of your numbers said you don't take too much. I'm very lucky because I can afford it. I've got a judge's pension. I can afford to pay for a personal trainer. And I actually think that the apathy problem that you mentioned, and also overdoing it and doing it in the right way, it would all be resolved if everybody had a personal trainer. But of course, it's unfeasible. You can't all have a personal trainer, but I'm very lucky. So I take exactly the right amount of exercise with my personal trainer, who's Spanish, got a degree in sports science. He knows exactly what exercises I should do. I do it 3 times a week for an hour with him. I play golf twice a week, I play tennis twice a week, and I ride a horse and a bicycle. So I take a lot of exercise. And thirdly, I keep my gut in good order. I take Simprove, and I basically have given up entirely dairy products. I only have oat and things of this nature. And keeping the gut in order, that I believe strongly contributes to me giving the disease at bay. Now, none of this was explained to me. I had to go and work all this out for myself. None of our group, nobody had any advice from the diagnosing clinician saying, the medication regime is just part of the solution. So there was no embrace at all of the holistic treatment.
So we will come to that. I think we have a question for you.
So you go ahead now. I've burbled.
Carolina will ask that question. But maybe if this is the opportune time, I'll open it up to Per as well, to ask you. But recently you've also had some issues where people have doubted your diagnosis.
Oh, yes. I did another one of these sessions, as some of you may have been there, in Portugal. And I flew in for the day from Geneva, and I was then cross-examined by interviewed like this by 2 neurologists. And it was but I have not ever suffered in any significant or appreciable sense from bradykinesia. I have never shuffled. The bottoms of my shoes are fine, have always been fine. I have not had the mask. I've not been stooped, although my wife says I am a bit more stooped. And she says, point your what's it down, stand up like this. And so, but I've never had a bradykinesia, but I believed that the diagnosis of Parkinson's that Ray gave me was absolutely infallibly correct, and it was supported by the DAT scanner. So I was slightly surprised in Portugal to hear one of my interrogators say, well, without bradykinesia, you haven't got Parkinson's. I said, really? I said, well, I wish you could occupy my body for a day, because then you effing know whether you've got Parkinson's or not. But, and he said, no. And furthermore, he said, and that, placing reliance on that DAT scan, they're very unreliable. I don't use them myself, maybe no more than 2 or 3 times a year. I said, well, as far as I'm concerned, I mean, the DAT scan, if they're not showing the lights are on, then the neurons are dead and you're up shit creek, aren't you? And so, I mean, I was, I have to say, slightly taken aback. My own neurologist there, with it being doubted whether, in fact, I had been diagnosed with Parkinson's at all. But maybe this is just language.
It's a bit surprising because I think most of us regard a positive DAT scan as a strong indication of Parkinson or atypical Parkinson. And if you have that in combination with the classical tremor, I think very much speaks for Parkinson, because the bradykinesia can be a delayed phenomena and can be very light in the beginning. So,
well, I think I was in that when you were being interviewed, and I did think that was a bit of a weird statement made, because it sent the wrong message. Because we do use DAT scan, and when it's used judiciously, it's very useful. Particularly if you have tremor and you're not sure about the type of tremor, it happens to all of us. DAT scan can help, and its false positive rates are really very low. So I was a bit surprised, but I don't think there's any problem with your diagnosis. I think perhaps the neurologists also did not realize that if you actually properly treat it, then your bradykinesia actually become normal kinetic. So I think it's unlikely that you'll always have bradykinesia when you're being if you're treated, if you're on, by definition, you lose your bradykinesia often.
And you also have an effect of the dopaminergic treatment.
Correct.
Yeah.
Which speaks for the diagnosis. Yeah.
Yes. But or is this just a question of language? I mean, is there a difference between Parkinson's disease and Parkinsonism? Is there, in fact, a medical difference, or are they just describing much the same thing?
That's a different issue because, there you have typical Parkinson's levodopa responsive syndrome versus all these other conditions like multiple system atrophy, PSP, DLB, which we heard about. So that's more it falls into the Parkinsonism bracket.
Okay.
So I think
those sound bad.
Yeah, you don't have that, so I don't think you need to worry about that. Perhaps we can sort of ask. You want to have a question for Sir Nicholas?
Holistic care, or
that would, because it touched upon that. Yes,
I think the explanation of the situation, coming back to this DATSCAN thing, is that we know that clinical definition of Parkinsonian syndrome is that bradykinesia must be present, and at least resting tremor and/or rigidity. But these symptoms are not equal, and especially from the beginning, the bradykinesia. You probably had bradykinesia, but it was so mild. And the tremor was so dominant, so that's why very often we do DATSCAN in this scenario, just to differentiate between essential tremor or Parkinsonian syndrome, because in that case, DATSCAN is very useful. So this is only my comment. But
I think we agree with all, and most people here would agree.
Could somebody explain to me, what is a DATSCAN measuring?
So it's a measure of the presynaptic dopamine transporter, which carries the dopamine. So it has a direct correlation with the amount of dopamine reserve in your presynaptic terminals. And it shows, there is now a sophisticated way of looking at that scan between your caudate, and you can measure it by ratios, an approximate measure. So it can be really quite useful in cases where, there is a doubt, and there can be doubt in everybody's mind. So an analogy would be that if you had a pattern of epileptic seizure, let's say, and you're not entirely sure, you often go to different types of EEG, to confirm or disprove your findings. And this is similar. So I don't understand why there was this hesitation about, or this saying that I don't believe in that scan type comment, which I remember hearing. But let's move on. So I think you mentioned, do you want to talk a little bit about the step care aspect and
I just want to ask you about your perception, because today we talk a lot about holistic care. Actually, I'm very into it. And this is the thing which I learned, and I think I'm still learning when I start collaboration with Ray, that we, like physician, we have to learn, listen the patient properly. We have to ask them questions properly, not only about rigidity, not only about resting tremor, because as we saw today and we heard today, there is plenty of any other issues. So I would like to ask you your perspective about this holistic care. What are the key components of the holistic care in Parkinson's disease from your perspective?
Well, as I was saying earlier, maybe it's a problem in England and the United Kingdom, is that everybody seems to occupy their own silos, and there doesn't seem to be any sort of willingness to reach out to the other people in the next silo. So with your clinician, you're not given any advice about exercise, for example. In fact, one of the questions I wanted to ask you is, why does exercise work? I mean, because you're not making new neurons, are you?
Well, some people say you do. Because it causes sprouting of neurons in animal models, physical activity, to a certain degree. And I think one of the comments that was made today, over-exercise might be actually not that good an idea, but up to a certain level, you get increased dopamine release and you get increased sprouting of neurons. So it probably is something similar happening. It's irrefutable that it does help.
And why? I mean, we've had to work all this out for ourselves, and so many of our listeners, we've got over 40,000 listeners, and we did win Podcast of the Year. So many of our listeners say, I've only found out what I should be doing by listening to your podcast. This is the only way I've found out. And then, of course, Parkinson's UK also do a very good service with their groups and things, but not as a result of any advice given by the medical profession, I'm sorry to say. And so the other thing, as I mentioned earlier, is I concentrate, I'm not quite sure why, I'm going to explain, on keeping my gut in good health, right? and drinking masses of water. So but even that doesn't fend off the constipation, which seems to be a feature for everybody. But why does gut health help with Parkinson's?
So I think before we go to answering that question, I think what you're saying is really what is in the dashboard, isn't it? That's why it was created, that these things are not missed out. And you showed in your talk how much of less than 20, you were not there that time. In that survey, less than 20% of consultations ever deal with bones, gut, and all of this stuff. So that's why hopefully the dashboard would help. Regarding gut health, Per, do you want to?
Well, we have increasing evidence that the gut plays an important role, and the microbiota in the gut play an important role for the symptomatology that you have, and that one can influence the symptomatology by influencing the microbiota.
Yeah.
So at the same time, we do not fully understand it yet, I think, but there is probably much to do.
In fact, there is a talk on this tomorrow. I don't know whether it's Valentina is in the audience. I can't see her. Valentina Letter did a randomized placebo-controlled study of the Simprove versus placebo in Parkinson's, and her reports, which has been submitted for publication, is going through initial review, shows a clear improvement after this period, 3 months period, of just by using Simprove arm, not in the placebo arm, of improvement in several non-motor symptoms, such as anxiety, such as mood and sleep. But in addition, it improved also time to on after levodopa.
Yes.
So in other words, the period that you take popular levodopa in and you get an effect, that time is substantially shortened just by using a probiotic. Yeah. And we don't completely understand the mechanism, but we measured inflammatory markers in the blood, and they go down significantly. So whether there's a pro-inflammatory, not pro, but anti-inflammatory effect of using the gut, improving our gut health is also very interesting too. So we're seeing an effect, but in a placebo-controlled randomized study, so skeptics won't be able to say, oh, it's open label, blah, blah, blah. But now we need to find what might be causing that. And it looks like, as Per said, that the microbiota abnormality can be something that you're addressing by using this particular probiotic. And why this particular probiotic? Because it gets into your large bowel and it's not destroyed in your stomach like the other ones. So I think that's the benefit, because it's used in irritable bowel syndrome as well, where you have the similar bowel gut issues. And by the way, irritable bowel syndrome is quite common in Parkinson. So there's overlap between the two.
Yeah, the thing is, it's quite useful, Parkinson's. You can blame everything on Parkinson's.
True.
As you get old, you say, oh, I've got Parkinson's. You know, as you park in a disabled space, oh, I've got Parkinson's. And the answer to your question is, on the dashboard, which has been mentioned, not the dashboard, the iceberg, which has been mentioned already. You were going to ask.
She was going to ask about.
Yes. Yeah, because I can see your screen, so that's why I want to ask you about the hidden part of the iceberg, and about your, the most difficult non-motor problems.
Now, iceberg is your thing.
Yeah.
I mean, you've been hooked on iceberg since.
Well, what percentage of the iceberg is below the water and invisible? Would you say? What would you say?
About 70?
80%.
80%
of it is below the water, and 20% is above the water, as the Titanic found out. So the bit above the water is the visible symptoms of Parkinson's. So what are we talking about? We're talking about tremor, with the mask, slowness, shuffling,
stiffness,
drooling a bit, perhaps. And then below, in the 80%, I mean, just think what a range of things which we're given no advice about at all. You go in because of the obvious symptoms, you're given some pills, and nobody says, I should tell you that insomnia, nightmares, mood issues, gut problems, constipation, memory loss, hallucinations, anxiety, pain, sexual problems, depression, fatigue, sleepiness, impulse control disorders, and drooling. I mean, this is the 80%, and which, to a greater or lesser extent, all of us Parkies suffer from these quite badly.
which is the worst one for you personally?
Personally,
what symptom is the disturbing most?
It's constantly not getting enough sleep.
Mm.
I mean, this ring here, this ring, an Oura ring, as worn by Prince Harry and Kim Kardashian and me, it measures one's sleep very effectively, and it is a bit depressing because if I look at that, what it tells me about my sleep, and I've tried everything on this. I don't know where I'm going to go from now. It says in relation to, I'll just look at this 1 second, brow sleep, here we are. I have averaged 4 hours a night.
And that's in spite of melatonin, opicapone. But we must say one thing about opicapone. When I first started it on you, the effect was quite dramatic on the tremor. But we moved it to morning opicapone.
First thing in the morning,
Yeah, because you were having problems at night. So dopamine overstimulation can be a problem.
Well, we made the decision, we'd use the opicapone to stop the tremor during the day because it was really impacting me. But I think it's sort of run out by the time I go to sleep. And so I don't think it has any effect on my... Well, I know it doesn't have. So I've got the statistics here. Last night, for reasons which we can explain... because I was coming back from America, I had 5 hours sleep. But over the last 7 days, it says you've averaged 4 hours, 17 minutes. Over the last year, you've averaged 4 hours and 46 minutes. And over the last month, you've averaged 4 hours and 47 minutes. I mean, these are not healthy times to be sleeping that.
And that's in spite of us doing lots of stuff, and you're seeing a sleep specialist as well.
Exactly.
So it's something just goes to show that how difficult sleep problems can be in Parkinson's.
Is it the sleep in itself, or is it the daytime tiredness that is most disturbing?
The fact that I'm sleeping so little is of itself disturbing because it is not healthy to be sleeping that little. I mean, I know they say Mrs. Thatcher always said she never needed more than 4 hours sleep a night, okay? But I'm not sure I particularly want to be compared to her, I mean, and I know that somebody else was saying you only need 4 hours sleep a night, but I am disturbed objectively by the fact that I just think that 4 hours sleep a night is not healthy. And then there are the physical consequences of it. I mean, I fall asleep very, very easily during the day. I do feel tired a lot during the day.
Mm. Well, there is now a cutoff. People say 6 hours, particularly in a Parkinson context, is really very important. But it doesn't have to be in one go. So you can have a little snack of sleep in the afternoon or in the evening. So as long as it totals about 6 hours.
The other thing that worries me is I mean, I know, whatever the Lisbon interrogators may have said, I know I've got Parkinson's. When I went to my place in France, we had a small place in France, and we went for a month, and I counted out all my pills, as you did, and I managed to go there and leave myself 4 days short. So I completely ran out of pills when I had 4 days to go. And I had anticipated this by only taking half a dose up to then, and I really could feel how the pills worked by not having the pills.
That goes to show how it works as well. Sometimes, I'm not advocating that, but
so the answer to your question is, I do feel psychologically disturbed that I have this condition. I mean, you should never underestimate the impact of. I mean, the impact. You've got Parkinson's. I've got Parkinson's, and it's you wake up when you're awake in the night.
Do you think? Since the diagnosis, and now you've adapted to a different lifestyle, particularly with all the media work you're doing, plus you're keeping yourself very busy. Is that advisable in a Parkinson context, or is it something not to do anything and just...
I've overdone it. I've overdone it, which is why I'm taking a non-executive role on one of the things you keep trying to rope me in on. I have overdone it. I mean, it's not the same as being a judge. It's only when you stop being a judge you realise what a big, important and difficult job being a judge is, because you basically have to get it right. You cannot afford, I know there's a call for appeal, but you cannot afford to get it wrong, okay? Especially in the family division where I was working, so I'm making decisions about whether children should be adopted and brought up by other people, whether people should have life supports turned off, whether children should have life support turned off, making those decisions. So, I mean, what I do now is basically a hobby, and on the podcast I can talk total rubbish, and it doesn't matter. It's not going to impact anybody. So, but even allowing for that, even allowing for that, I am doing too much.
So the advice would be to take a healthy balance, not to stop doing everything, but also try and get a balance if you can.
Yes.
Yeah, I mean that's a general advice. So what we've established is that we're not asking enough questions about lifestyle and the holistic advice that we should be giving: sleep, gut microbiota. Recently, you asked me about oral health.
Yeah, I did. Yes.
Which, you know, the importance of oral health in Parkinson is coming up. Then Simprove, or using a probiotic, physical exercise, of course. All of these are as important probably as the drug therapy.
And I don't mind mentioning that the lady who spoke about impulse control disorders, if you remember, you put the pramipexole up from 1.5 to 3. Do you remember?
Yes.
And I suddenly found myself starring in my own porn film in my head. And so that was quite disturbing, really. So I went back to you and we cranked it straight down to 1.5 again when it's been fine. But it is interesting. It is interesting how those drugs have. I mean, they fill your mind, occupy your mind with the quite disturbing thoughts, actually, and which you say get out, and then it keeps coming back into your mind again. So anyhow, that just reduced it to the old dose, and it went away.
But that itself was very interesting, because one of my colleagues, when this happened, was going to stop the pramipexole in your case. And I actually said, cut the dose down, and let's see how you go with that after discussion with you, and completely cleared up your problem. I think Professor Slavik mentioned agonist phobia today. There is also an agonist phobia, because some of these agonists are actually pretty good for you. Pramipexole has been brilliant for you from mood-wise, and initially it also helped your tremor. So we didn't have to stop it, cut it down. Of course, you have to be monitored for the impulsivity. Any comments on that?
Well, you have now been into the Parkinson field a lot and discussed with many people. What is your feeling? What is the most important area for research in the future? What shall we try to find out, improve, get better?
Okay, these are my thoughts. I just want to say, though, that as a result of getting Parkinson's, I have met the most amazing people in the Parkinson's community. And I have been out, for example, they asked me to go out and to be a roving commentator for the Four Nations Championship between the English Parkinson's Disease Golfing Society, the Scottish one, the Irish one, and the Welsh one. And they all went to the Belfry in Birmingham, and I was going around interviewing them. And these were people who had really, really bad movement disorder. I mean, when you're standing on the tee and you thought, they can't, there's no way they can hit that ball, they were shaking so much. And then the power of the mind, momentarily, the disorder stops, whack, the ball goes 200 yards straight down the fairway, and then it started again. And it made me almost weep at the stoical determination not to let the disease beat them. It was tremendous. What was the question you asked me?
What are the unmet...
Oh yes. My own view is that a cure to find a replacement for dead neurons is a bit like the people going off to the South Seas looking for a black swan. I mean, I think that's going to be really difficult. In my opinion, what one should be looking at is in the same way that antiretroviral drugs have the effect of, they don't kill off HIV, but they make the HIV inoperative. And one should be looking for medications that make Parkinson's disease inoperative. And that can be done, in my opinion, in one of two ways. By really getting Big Pharma to work on the enzyme blockers, so those mean enzymes can just be stopped from doing what they're doing, and so we can get the benefit of the L-DOPA through the blood-brain barrier without it being intercepted and abducted en route. And secondly, I think that the pumps, if they could follow suit with the diabetes pumps and be intelligent, if technology could work out when you're going off and give you a burst of levodopa without just, at the moment it's a constant stream, isn't it? But if technology could work out how much you needed from time to time, that would be...
But you would not be averse to going on pump therapy if required?
No.
But you just want it to be more intelligent.
I want it to be more intelligent. The idea, I mean, the diabetes ones are intelligent, aren't they? Yes. They can tell when.
But there you have a sugar as your, blood sugar level as your indicator. So we have a bit of a problem with Parkinson's.
Sure, but I mean, we're talking about clever things that are going to be done in the next. Yes, that's how I see the future. But I mean, obviously I'm speaking in a partial way, but the enzyme blocker has worked so well for me. Why can't it work well for everybody?
Sure. I think we'll open it up.
But I think I'd quite like to know if these people think I've got Parkinson's.
The audience, if anyone has questions.
Anybody has any questions for Sir Nicholas, please feel free to ask.
Did you try an extra dose levodopa at night when you wake up? No. He did suggest this, but I thought, well, is that likely to get me back to sleep again? Could it?
It's worth a try. You have tried it. We give you a dispersible matopar at night.
Okay. But I thought the whole idea of dopamine was a sort of it's a great energy drug to get you rampaging around the place.
No? It can help with the sleep aspect. Well, we've discussed that actually once. And one other question we had actually was your views on sensors, wearable sensors, because a lot of our community are very against it.
Why?
A lot of neurologists don't like using sensors. I get told off sometimes.
But you wouldn't have this data.
Well, I know. But perhaps we can have your views, because we have debates on it, and some of our old-fashioned neurologists hate sensors.
But I'm wearing an Oura ring and an Apple Watch. I'm completely... Mr. Putin probably knows exactly what I'm doing. But I have no problem with sensors. I mean, anything that gathers the data so that you can live a more normal life is obviously... I mean, if we hadn't done this, we wouldn't have known... We wouldn't have been in a position to...
So that's what Sir Nicholas is alluding to is PKG. I use a lot of PKG. Perry, you use it. Currently, you had some experience. It picks up the tremor score, and that went down from 29
to
2 with the pick-up. So I think it's an objective measure that... I mean, we use it in everywhere else. I mean, if you had MS, you'd do an MR scan to look at surrogate markers. If you had... epilepsy, do EEG. If you have cardiac problems, do ECG. Why don't we do something similar in Parkinson? It's just, I don't know, something similar. But Per, would you agree, or what's your view on this?
Absolutely. Maybe a final thing, when at lunch you had some interesting reflections on the international development for Parkinson.
Yes.
Maybe you want to tell the audience.
I've got... in Africa, there are at least 3 million people with Parkinson's disease. When I say Africa, I mean sub-Saharan Africa. And in sub-Saharan Africa, there are... How many factories do you think there are making L-DOPA in sub-Saharan Africa? The answer is no factories in making L-DOPA in sub-Saharan, even though L-DOPA is out of patent, and it's very, very simple to make in a lab. It's only a two-step process. In fact, they're just getting it down to a one-step process. It costs 1 cent per pill to make, 1 cent. But there are at least 3 million people in Africa who are not getting no treatment at all. The only people in Africa who get treatment are people with money. There are some countries in Africa, like Zambia, where there is, not even if you're rich, can you get L-DOPA. In Nigeria, there are 240 million people. How many neurologists do you think there are? Fewer than 100. And so if you think about all the people who are disabled from working because they've got Parkinson's, 3 million, for each of them, there was going to be one member of the family looking after them, so it's another 3 million. Just think what those societies, those countries, how much they'd benefit if all those people had L-DOPA and came back into the workplace. Just think how much more productive those countries would be if those people were able to come back, because they're all very, I don't want to generalize, but in that part of Africa, everybody's very resourceful. And so there is a tremendous, so our plan is to have levodopa for Africa. And it's not going to have some sort of symbolic convoy leaving Portsmouth on a boat or something and landing and driving to Zambia, because that, you do that once, the TV cameras are there, and then it's over. We've got a very nice, we're setting up a group. Our patron is going to be Sir Andrew Mitchell, who's a former Secretary of State for International Aid. We have got the Director General of the World Health Organization setting up a special party to take this forward, and we're going to get levodopa into Africa. We hope to build small factories in Nigeria, Rwanda, and South Africa, and then get the regional countries to realize how much it would be in their interest. Unfortunately, it's seen as an old man's disease, and Africa, they're only interested mainly in people who are young, but I think that they probably could be persuaded that this would be economically in their interest. So that's what we're doing.
Well, thank you. And thank you for coming. And thank you for your time.
My pleasure.
And I'm sure people can talk to you.
Fortunately, one of the great advantages, nobody's ever said that drinking alcohol is not allowed with your medical.
Just be careful with the red wine, French red wine.
Okay, so last part of today's program. I welcome Haidar Dafsari from Cologne and Kit Wu from King's College London, who will share the last session of today.
Thank you so much for having us. So we're going to do a double act again, Haidar being the star. For today's talk, I would like to warmly welcome and introduce Jessina Paul Wiese from Sweden. She is a principal investigator in translational neurology and as part of the Multi-Park initiative and a senior consultant neurologist at Lund University and University Hospital. And she's going to help us answer the million-dollar question, which is stem cell-based neurotransplantation. Does it work? Over to you.
Okay, thank you very much. So I'm the last blockage between you and the dinner, so I hope you can bear with me another 20 minutes. I've got this question to answer whether stem cell-based neurotransplantation works, and I can already say it's much too early to answer this question. But I will give you a little bit of an introduction about what's ongoing right now, where is the evidence of using cell transplantation in Parkinson's disease, and also what is our vision, what we can possibly do if we can make this into a global treatment. So these are my disclosures. So I don't think I have to introduce Parkinson's disease. Everybody knows it's mainly a loss of dopaminergic cells, but not only, but we're focusing on dopaminergic cells. And the question is, can we replace dopaminergic cells? And the answer is yes, we can. And the concept of replacing cells in Parkinson's disease, I mean, we're used to transplanting all types of other organs, but to transplant nerve cells to the brain is a little bit different. But the concept of cell replacement in Parkinson's disease is primarily based on three hypotheses. And the first one is that the predominant motor symptoms of Parkinson's disease are dependent on the loss of one cell type, dopaminergic neurons in the nigrostriatal pathway. The second hypothesis is that dopaminergic neurons grafted into the striatum can actually survive and functionally replace the lost neurons. And the third one is that we get a chronic physiological delivery of dopamine into the striatum, and that can treat dopamine responsive motor symptoms, aspects of Parkinson's disease. And by doing that, we will avoid off-target side effects and also possibly get less levodopa-induced dyskinesias. So the history of transplantation goes back about almost 50 years now, at least when it comes to clinical trials. The first clinical trials were, among others, centers performed here in Lund in Sweden, and they were performed on fetal cells. So when you transplant dopaminergic neurons, you cannot take mature neurons, you have to use immature neurons because any other neuron type will not survive the procedure. That's the first kind of basic knowledge about it. So we have to find some kind of cell type that is immature, that has decided to become a dopaminergic cell, but has not fully developed with full axons. And these cells were actually taken from aborted fetuses. And they come from routine abortions according to an informed consent and ethical guidelines. And there were certain donor age restrictions. So the age of the developing dopaminergic cells were approximately the same where the abortion age age was defined 6 to 9 weeks after fertilization. And this tissue is donated, and then the developing midbrain, which is a tiny little region in the embryo, can be dissected and made into a cell suspension. So it's not a piece of tissue, it's a cell suspension. And that can stereotactically be injected into the putamen. These patients were immunosuppressed, and this is also a topic, is it necessary to do that or not? But the patients in the early trials were all immunosuppressed for 18 months here in Lund. This is work which was pioneered by Anders Björklund, among others, Patrick Bondin and Ole Lindvall, and 18 patients have been transplanted here in Lund between 1987 and 1999. And then we have conducted a study which was called Transuro, and I will briefly also touch up on the results of that study. And that was done in collaboration with Roger Barker at Cambridge University here in Lund and in Cambridge between 2014 and 2018. These patients were grafted, and this were another 11 patients. So I just want to give you an idea of what is the potential of cell therapy if it works. So here we're looking at one patient, and that's a very early study, just to illustrate that some of the patients really show a significant improvement, both in the UPDRS motor score and also here in the off time per day, which goes down to 0. But you also have to look at the axis of this graph, which is really in years. And when we put in the time point of transplantation, you can see that this is not a quick fix therapy, as it sounds like. You take cells, you transplant, everything is back to normal. No, we have to wait. We have to wait for the cells not just to survive, but they have to integrate into the host brain, and they have to mature, and then they have to start working. And it's worthwhile to wait several years for the optimal effect. And this is really important when we look at clinical trial design, and not just for transplantation, but also for neuroprotective trials. And I know that Ray said that he doesn't believe in all these neuroprotective trials anymore because they all fail. But I think it's worthwhile to look at the trial design, because you have to ask yourself, when do we graft? How long do we wait? And maybe if we have an endpoint at 12 months or even 24 months, it's just not long enough to wait for the optimal effect. So I just want to show you two patients. These are English patients who have been grafted here in Lund with fetal cells, also in the 80s, to show you that a long-lasting improvement is possible if this therapy works. So these are two patients from Tom Foltini's group, and he has followed these patients and examined them then again, I think 18 years after they've been grafted. So these are two Parkinson patients who have been grafted when they were 10 and respectively 12 years into the disease. So if we then take another 18 years on top of that, we are 28 or 27 years after they got the disease. I have never ever seen a Parkinson patient in my entire career who does not need any medication 27 years after getting the diagnosis. And these patients are today still without any dopaminergic replacement therapy. And their DUT scans show a reconstitution of, they look almost like normal. And that is I'm still getting very excited when I talk about this data, just because it illustrates what the potential of the therapy is if it works. And all we have to do is now we have to get it to work. This is fetal tissue. So we went on and looked at all the patients, or the ones that were available, at least in the literature, who have been grafted worldwide, and there are about 450 patients in different centers, and it's a very variable cohort, and one can see that maybe a third of all these grafted patients with fetal cells actually have a meaningful clinical benefit. But there's also a very high degree of the type of improvement and also duration of improvement. So there is a problem with a very high variability. So this is why we started Transuro. We set out and we thought, okay, if we choose younger patients earlier in the disease, we standardize the way we treat the fetal tissue, we do everything very similar between our centers, maybe we can get this to to be a little bit less variable. So that's how we started the transeural cohort. And we had a large observational cohort, and 11 patients were transplanted, and we had 20 control patients who actually got exactly the same imaging, the same type of treatment, but they were not grafted. All these patients were also immunosuppressed for 18 months. This was a logistic challenge because we had to cancel 82 neurosurgical slots during this trial, and everybody who works in healthcare understands what this means. And this was due to the shortage of tissue. There is not enough fetal tissue that can be gathered for a certain day to transplant enough patients. So we understood very quickly that it's not possible to do a global therapy based on fetal tissue. And the results were also disappointing. This was a phase 2 trial, so we did not look at safety. Of course, we looked at safety, but it was not the primary outcome parameter anymore. We wanted to look at efficacy, and the endpoint was to look at the UPDRS-off score 3 years after grafting. And here you can see, now there is no pointer, but you can see the blue line is basically the control, and you can see they're progressing over time. And then we can see that there is a clear point of inflection, at least in the transplanted cohort, but there was no statistically significant difference between the control and between the transplanted cells, which means that the study would be negative if you kind of not explain the study design. Then we looked a little bit closer at the patients who have been grafted, and we had 2 different surgical sites. And there were quite a lot of issues with the surgical instrument at the UK side because the instrument had to be made. Anyway, what you see is that the green patients are the Lund patients who've been grafted here, and they show a clear improvement. And one of the Lund patients actually has almost normal values on the PET scans now after transplantation, and the British patients did less well in this trial. So it's also important to kind of to troubleshoot and to see what could be the reason. Maybe there was less cell survival due to the surgical instrument. That's one of our interpretations. But the conclusion from the fetal studies now is basically there is a large variation in outcome. It's not possible to standardize this as a treatment. There's a lack of material. Of course, there are ethical considerations, and they are connected to the type of tissue source that we are using, and enormous logistic and practical issues connected with the source of dopaminergic cells. So what we need is we need another cell type as a starting cell population to grow dopaminergic cells. We want a large-scale production. We want cells that you can put in a biobank and take out of the freezer the day when you operate. They need to be standardized, so all the patients are getting the same product, and it needs to be, of course, safe and efficient. And this brings us to stem cells. So just to bring you all on board, what is a stem cell? When we're talking about stem cells, what does it actually mean? And the definition of a stem cell is that it has the capacity of self-renewal, so they're making more and more and more of themselves, totally unlimited. Yeah? And the other feature is also that a stem cell is what we call pluripotent. That means they have the ability to differentiate into all the 220 different cell types that we have in our body. When we're talking about embryonic stem cells, and there are other types of stem cells, but when we talk about embryonic stem cells, we're talking about cells that are derived from the blastocyst stage. So they are coming from cell lines that are derived from in vitro fertilizations. When the family planning is concluded, a couple has the opportunity to donate the fertilized embryos for research or to destroy them. You can keep them for 5 years, and then there is a limit. And this cell line which we are working with in Lund at the moment is derived from one donation in 2011 in Scotland, actually. So that cell line, which is called RC17, comes from this blastocyst stage, and these are embryonic stem cells. And they can form all different germ layer-derived cells. So you can use embryonic stem cells to make heart muscle cells or insulin-producing cells for diabetes. And this is a big research field which is ongoing, which falls under this expression of ATMPs, advanced therapy medicinal products, which is gene therapy, cell therapy, tissues. So it's very much up and in the field right now. But we are interested in making neurons, and not just neurons, we want to make dopaminergic neurons. So when we go back to Parkinson's disease, there are different cell sources. We talked about fetal cells, and then we have the embryonic stem cells, but there's also something which is called iPS cells, and I think everybody maybe has heard about them. iPS cell stands for induced pluripotent stem cells. So what you do there is you take a somatic cell like a fibroblast or a blood cell, and you can actually convert the cell back in time into a pluripotent cell. It has the features of the donor. So if you take it from the patient himself or herself, you don't have to immunosuppress, but it's a quite expensive and of course not standardized procedure, but it is possible. So today we can reprogram these cells back to iPS cells and then drive them to become dopaminergic cells. All these cells are already in clinical trials as we speak today. So the ones in green are clinical trials that are using embryonic stem cell-derived dopaminergic cells in Parkinson's disease, and the ones in orange are clinical trials that are using iPS cell-derived dopaminergic cells in clinical trials. So I will just talk about 3 of them, where the first results have just been published. The one which is maybe one of the most known ones right now is an American-based trial. It's a Blue Rock therapeutic trial. And it's a trial which is using a cell product, which is a cryopreserved dopaminergic progenitor cell that comes also from an embryonic cell line, but it's a different cell line from the one that we are using. Has a slightly different features, but in the big picture is pretty much the same approach, the same idea. And they have transplanted 12 patients. So this is the first time these cells go into the human brain. So all these trials are phase 1 trials. So at the moment, we're only looking at, are these cells safe? Can we put them into the brain of patients, and do they cause side effects? So they have transplanted 12 patients, and the patients were between 50 and 78 years old. A bit of a variety in disease duration, 3 to 20 years, and the starting population was Högn stage 3 actually and off. And the results have been published this year in Nature in May. The neurologist behind this is mainly Claire Henchcliffe, but the cells are basically produced by Lorenz Duda, and Vivian Tabar is a neurosurgeon in that group. And what they've done is they tried a low dose and they tried a high dose. So they had 5 patients in the lower dose, and then they had 7 patients in the higher dose. They transplanted them, and they also immunosuppressed the patients for a year, because that is probably the time the blood-brain barrier is open, and then we assume that the blood-brain barrier is closed and that you would not need to immunosuppress anymore. And then the immunosuppression is basically tapered off, and they followed the patients for 18 months. So what they have published right now is the 18-month data. So it's still very, very early. They're following the patients for 24 months for the secondary endpoint, and then they follow them for another 5 years, and probably for the entire life if it's possible to keep them. So what they can say so far is that the treatment is safe. So here we're looking at a table at the 12 months post-transplantation treatment emergent serious adverse events. And what you can see is basically there were no serious adverse events related to the cell product. So that means there's no tumor formation. This is, of course, when you use stem cell-derived products, the big worry in the field. They had two serious adverse events. One was a COVID infection and one was an epileptic seizure, probably in conjunction or in connection with the surgery, but otherwise no other serious adverse events. And that means that the study has met the primary endpoint, which is safety. They also have efficacy outcomes, but this is only an indicator of efficacy, which helps a little bit with dosing for the phase 2 trials. And what they have seen is in the different dose groups, you can see there is, of course, variation between patients, but overall, there was an 8.6 point improvement in UPDRS off in the low dose group, and that's between transplantation 18 months, and 23 points improvement in the high dose group. So they see a dose response as well. And of course, these are numbers where you think, wow, this could be something. This is a little bit more than just variability. But one has to keep in mind, of course, that this is an open label trial. So the patients know what they get. The investigators know that everybody has a transplant. So it's also important not to over-interpret the results. They also look at on time, and they find a slight increase in the low dose and a much more pronounced increase in the high dose of 2.7 hours per day, which is quite substantial. So that's the data that is available right now. It's still very, very little, and it's an ongoing trial, but Blue-Rec has already started to recruit for the phase 2. And I just want to show you a little bit, because we are having a non-motor symposium, and stem cell transplantation is maybe a little, you know, what does it do for non-motor symptoms? And again, it's very, very early to look at non-motor symptoms, but you can see that the non-motor symptoms did not improve at 18 months. And when I looked at this table a little bit more in detail, I found that the main driver of that negative change actually is sleep. But then one has to keep in mind that it may not be the result of a stem cell transplantation, but the result of the immunosuppression. So these patients are on high-dose prednisolone for quite a long time, and this will obviously affect sleep. So there are a number of factors. You just have to wait a little bit longer before we can draw a conclusion. Am I too late? Then you have to stop me. Yeah, okay. Good. Just to tell you a little bit about the Japanese trial, the Kyoto trial. So these were cells that were iPS cells. They come from donors who have donated blood, and then you convert the blood cells into pluripotent stem cells, make them into dopaminergic cells, and they were actually not cryopreserved. They were transplanted as fresh cells, as spheres, and they transplanted a number of patients also between 50 and 69 years, 7 patients in total, and they report 6 of those. Also hernia stage 3 or worse. Published back-to-back with the other paper, very similar follow-up design, but they report 2-year data. They also looked at inflammation, microglial activation, and could not see any signal. They find also a reduction in OFF score, not as pronounced as the American trial, but still a 20% reduction overall in the entire group, and also some change in on time, but actually not in the positive direction. But what they find is a very clear signal actually on the PET scans. So here is one of their patients, and you can really clearly see the change in signal between pre-op 12 and 24 months. They report a almost 45% increase in flow-dopa uptake average from both sides. So this is where we are in terms of these 2 trials. Just briefly, the trial that we have ongoing here in Lund is a STEM-PD trial, which is also human embryonic stem cells. We're using also a cryopreserved cell product, and it's a trial that we do together with Cambridge, so it's a multi-center trial, first in human. Our patients are a little bit younger. That was quite some effort to convince the ethical committee, but we believe that this is important. So they have moderate disease, they're hernia stage 2. But they have had their disease at least 10 years and are between 50 and 75 years. We have transplanted 8 patients in this trial. The cells are produced in England right now under GMP conditions. The protocol comes from Lund University, and it's Malin Palmer and Agnete Kirkeby who actually have developed this differentiation protocol to actually make the cells, and they are tested in animal studies extensively before they actually go into a human trial. So we are looking also at safety and at some efficacy parameters, as you do in a phase 1 trial. The procedure is so that we take a neurosurgical instrument, and it's the same one that has been used here for the fetal cells. And we are transplanting the cells along 5 tracts into each putamen in one session. It's quite a long operation. And then we dose by either setting 4 deposits per tract or 8 deposits per tract. This is a picture showing our neurosurgeon here and transplanting one of the patients. So we try really to distribute the cells as well as possible across the putamen. We also have a dose escalation step. So we have a lower dose and then a dose 2, which is a double dose of what the first patients get. It's a staggered inclusion, so we start with 1 patient, we wait 2 months, we look at safety, we transplant patient 2, we wait 3 months, we look at safety, and then patient 4 and 5, and then we waited half a year between dose 1 and dose 2 and took a decision on whether to escalate the dose together with a DSMB. So this is a very carefully regulated process to proceed in that study. But we have at this time point transplanted all our patients. And we're approaching the primary endpoint in October this year. This is when we will look at our safety data and also publish the safety data. But what we are doing, we're following all patients for at least 3 years after the transplantation. And since they are transplanted in a staggered way, the study is expected to meet the secondary endpoint at the end of 2027. So you can see here is the primary endpoint, which is now due in October, and the secondary endpoint at the end of 2027. It's a very challenging program for the patients. There is a large number of MRI scans, of course, due to safety, very frequent visits, a large number of PET scans they undergo, and they have to be really committed, and also they have to be able to tolerate the immunosuppression. So we immunosuppress with triple immunosuppression, the same protocol as we use for organ transplantations for 12 months, and then we taper off the the drugs over another 3 months, so it's 15 months. They are immunosuppressed. So this is a huge team effort, and we had a lot of help from all kinds of different people. Malin Palmer is the project lead, really producing the cells and keeping us all together. And Roger Barker is the clinical lead in Cambridge, and I'm the PI here in Lund. And as a large number of collaborators, we also had substantial help from Novo Nordisk, who is interested in developing this then further as a cell product. Thank you.
Thank you for this wonderful talk. Are there any questions? For Gesine.
Hi, Jacine. Fabulous talk. I think you have me. I just wanted to ask you, with the pluripotent stem cells, so you're getting the effects with the dopaminergic neurons and the effects thereafter. Do you think one of the reasons the non-motor areas didn't improve could be the lack of serotonergic and or cholinergic influences that you would see in a Parkinson's? And how would the transplant, we are now getting the subtypes of cholinergic PD where cholinergic involvement is more or serotonergic. How do you think that might be addressed? Do you think there is a way that you can have these neurotransmitters involved in the transplantation process? Is there any such activity?
Nice, really good question. We do not want serotonergic neurons in the transplant. This may have been a problem in the fetal transplantation trials. It's something that I haven't touched upon, but in some of the trials, patients developed off-dyskinesias, and experimental evidence and also analysis with PETs of some of the transplanted patients indicates that this is probably a mismatch in the ratio between dopaminergic and serotonergic neurons, and the serotonergic neurons use levodopa as a force transmitter, and that's causing the dyskinesias. So this is one of the advantages with using these stem cells, that they actually do not contain serotonergic neurons. Coming back to non-motor symptoms and other transmitter systems, I think if you were to transplant, you would also have to put them into the target sites, which would probably be a little bit of a more difficult endeavor. I think we will continue to treat non-motor symptoms. There are non-motor symptoms that are responsive to dopamine. Pain, it's a lot, but some of them are not, and I think we will need to continue treating those in the way we do right now. Yeah.
More questions? So you're doing stereotactic neurosurgery, right?
Yes.
And does this open up the blood-brain barrier, or is it the transplant, the graft itself?
So the stereotactic surgery means, in this case, that you just do a borehole, but you still have to go through the dura, and by that you will actually damage the blood-brain barrier just by doing the different tracts. It's a small lesion, but it's opening the blood-brain barrier, and of course that allows immune cells to infiltrate and to recognize the transplanted cells as not your own bodies. Yeah. Yeah.
Could you do MRG first to open the blood-brain barrier just selectively to get the grafts in?
You would still need to place them where you want them to be, and that's quite deep in the brain, in the putamen. So so opening the blood-brain barrier with other methods is maybe more relevant for certain drug deliveries. But in this case, you really need to target them into the target structures. You need to physically, basically, get them there. Yeah. So that's what we're facing. Yeah.
Any more questions? Yep.
So if I basically understood you right, you did 5 tracks per site. Did you experience any surgical complications, such as focal deficits or hemorrhages?
Yes, it's a good question. It's, of course, something that we're worried about. It's a bit like doing 5 deep brain stimulations, isn't it? Where just that the target is a different one. It's not the subthalamic nucleus. You go into the putamen, but each time there is a risk for bleeding and there's a risk of infection. No, we did not actually. We had one minor bleeding, which was totally asymptomatic and was resolved within a month so far in this study. But no major. And none of the other centers has. They're using a different approach in a different neurosurgical instrument in the other clinical trials, but luckily we can say we did not have any complications in terms of intracerebral hemorrhages or infections related to the neurosurgical procedure.
Good, wonderful. So thank you very much for this wonderful lecture. And
think I'll use that.
No, please use the handheld.
Oh. Yeah, that's what I thought. Just use that. Hello. Okay, so this is not another talk. So we just we are now coming to the end, and I think what we thought is I'll just quickly summarize what we had today, and then Per will outline what's going to happen tomorrow. So I thought it was a fantastic day, very heavy in science, and some superb speakers. And we went through, I think what was really interesting is the journey from basic science, hearing about biomarkers, finishing up with this fantastic talk on cell transplantation. But in the meantime, touching on real-life effects on, for instance, the dashboard, the step care, botulinum toxin effects, clinical science, neuroradiology, all related to non-motor symptoms and device-aided therapies, of course, which you did. So I think we'll look to many more of the same tomorrow. We have a fabulous program again, and Per will outline. So I think that would be the summary of the day, and I hope you've enjoyed it. We will put together something on this so that there's a document we'll think about, that there's a resource that people can access with all the material that's been presented today. So I think, and again, I thank the patience of all the people who have actually survived so far, although it's thinned out a little bit as it happens with normal aging process and hair. But you know, I think it's been a fantastic day, at least for me. I took lots of notes and pictures and stuff. So thank you to all the speakers and to all the audience who also participated. And of course, I can't forget. And of course, we should always remember the contribution by Nicholas Mostyn and that session with the patient, the lived experience of Nicholas. He's so articulate, and I think that was a big learning experience from all of us. So I think that was a special highlight of the day. So Per, I'll pass it on to you.
Thanks, Ray. Thank you, everybody. And the evening continues. So those registered for dinner, we will have dinner at Hypoteket. That is approximately where the cathedral is, on Kyrkogatan 17, Church Street 17. 13, okay. And the dinner will be there at 7:30. So if those that want to leave in group and go together down, we meet 7:15 at the main entrance of the hospital building. And tomorrow, is it 8 o'clock? Okay. Are you sure? I think the drink is at 7:30. Yeah, so tomorrow morning is 8 o'clock. Yes, yes.
But you get to drink 7:30 tomorrow. Excellent.
Yeah, tomorrow is 8 o'clock, and tomorrow we end at 2:30. So, but now we wish everybody a very happy evening, and see you tomorrow.